you going through the forest, you see the animals and all the wildlife and everything, and rivers. So it's an amazing place. If you want to visit, you're more than welcome one day. Come and give us a visit here. Anyway, today we go back to the main topic, which is the ceramic. And the reason I chose this topic that is most of my postgraduate students and also colleagues, they find it difficult to find out what kind of restoration they need to prescribe for the patients with different conditions, especially with the new technologies that's evolving. And more and more we're moving towards the composites and the ceramics in dentistry rather than metals. And many of the patients are actually demanding for metal-free restorations for many reasons, and mostly because of the aesthetic. And not surprising, because of the technology, advances in technology, now providing these services cost less and they come cheaper. So it's an interesting topic, but there are lots of information around, there are lots of materials around, which makes it difficult to make decision for the dentists, especially who are in the general practice and they don't have too much access to the academic environment. They are not sometimes updated with the new materials. So I choose this material to present it to you today, to our kind audience and colleagues. The ceramics, as we said, is a long-standing material. It's not a new material, but the properties of the material has changed. So we have now restorations fully made of different types of ceramics, crowns, onlays, as you can see in this picture, probably in the middle one. It's the one on my case. These days I use onlays. Most of the extensively damaged teeth, especially endodontically treated teeth, rather than crowns. 90, probably 80% of my cases are treated with onlays and adhesive onlays. So I strongly recommend our audience, if they are in the business of dentistry, if they don't know how to use this material and how to choose these materials, attend the courses and try to learn from that aspect. It's an amazing tool, an amazing type of restorations. If you do it properly, it's as strong as crown, and it's even better, and it preserves the tooth structure, and you have a better access to the margins and less problems with the periodontal issues in the future that you sometimes have with the crowns because of the subgingival preparations and so on. And if anything goes wrong, you can immediately identify and restore it. And at the end of the day, if that fails, you have still option of going to the crown. And as you can see in the other side of the picture, you see the patients that attended with the multiple composite restorations, defective, and the restoration which are recommended to put a ceramic veneers instead of composites. I'm not against the composite, but it has its own limitations. Today we're talking about the advantages of the ceramics, apparently. So these are the advantages of ceramics, that you see the anatomy, controlling the anatomy is much better than the composite, and also durability of the ceramics are better. It has its own downsides, but we will discuss all this in the lecture. But it's a great tool in hand. So it's very popular kind of a material that we need to learn about it. There are different ways of classifying and categorizing the ceramics. I try to put all things together to present you as a package, but in a very simple way. As I said, there are different materials around. It's difficult to work it out what is what. But there are basic classifications. Based on the crystal structure of these ceramics, generally ceramics are classified as two types. They are made of crystals and the amorphous matrix, which is glass matrix. And that amorphous glass matrix is a weak structure. All of the ceramics that you see in the market is a combination of these two. You have a bit of matrix, you have a bit of ceramics. The ratios are different. apparently the composition is different, but in terms of crystal structure, this is the difference between the different type of the ceramics. So the glass matrix is not particularly strong, so it's a weak part of ceramic. But the advantage is that it has high translucency. So the more glassy phase you have in the structure, the more translucent the ceramics is going to be, and the more aesthetically pleasing for the patients. At the same time, is etchable and bondable to the tooth structure. That gives an advantage. That actually compensates the weakness of this phase, because when it's bonded to the tooth structure, it becomes a part of tooth structure. And with the biomimetic approach that these days we follow, we replace like with like, we replace the enamel with the ceramic, which is very similar to enamel, and we replace the missing part of dentin with the material which is similar to that, for example, composites. So this material, if it's bonded to the tooth structure, becomes ideally part of tooth structure and regains its strength. So that weakness goes away. Plus the fact that it has better translucency. The crystal part on the other side, in the composition is almost the same, but the arrangement of the atoms and molecules are different. And it's very organized, it's not random. It gives a kind of crystalline structure, which is mechanically very strong, but is difficult to etch and bond. So it's itself has a good strength, but it cannot bond to the tooth structure, so it doesn't benefit of bonding to the tooth structure. And these kind of ceramics, which has more of crystalline, they need to be cemented to the tooth structure because you can't etch them and bond them. The ratio of the crystals to the matrix varies between the crystals, different types of the ceramics. And then, for example, Emax or lithium disilicate ceramics have like around 40 to 50% of matrix. Some ceramics has more, some ceramics has less. So based on this classification, we have two groups of the ceramics. Glass matrix ceramics, which has a big chunk of amorphous matrix, which is etchable, bondable. In this category, you have feldspathic ceramics. These are the early ceramics developed in dentistry in early 20th century. They failed a lot because there was no bonding to the tooth structure. They were cemented, and that because of that, most of these restorations, especially on the posterior area, failed and fractured, and it was not a favorite restoration. So over time, they strengthened it by adding metals, which we had the PFM porcelain fused to metal ceramics. On the other hand, we have polycrystalline ceramics, which basically they are oxide or metal oxide compositions. They are almost fully crystallized. For that reason, they have a good mechanical strength, but poor bondability. They cannot be etched or bonded to the tooth structure. Plus, because they have crystal structures, they are not aesthetically pleasing. So because they scatter the light and they look opaque. So as you go in from the glass matrix ceramics, which is the feldspathic has the highest one, is the most translucent, and then lucite-based ceramics or lucite reinforced feldspathic ceramics. These are the type of ceramics which are reinforced, and they develop a certain kind of crystals, which are called lucite, are the second. And then lithium disilicate is in the middle in terms of aesthetic and in terms of strength. And then zirconia is the best one. Alumina is out of market because zirconia has all the advantage and there is no point of using alumina. It's been in the market for a short period of time and then disappeared. I want to give a little bit of information in terms of terminology because the terminologies are confusing in the books and in the text, unfortunately. Dental ceramics and dental porcelain. Students keep asking me, what is the difference? Sometimes you refer to some ceramics as a porcelain, sometimes you call it a ceramic. What is the difference? And the same goes to all the textbooks. This is the definition from the glossary of the prosthodontics in the US. and also British standards, which follows the same definition. Dental ceramic, by definition, is an inorganic, non-metallic material, which is specifically formulated for use when processed according to the manufacturer's instruction to form the whole or part of the dental restoration or prosthesis. So it's a very general term, whereas dental porcelain is predominantly glassy dental ceramic materials. So the materials we mentioned as a glass-based materials, we can call them porcelain. But the zirconia alumina cannot be called as porcelain. They are under the category of ceramic. Porcelains are also ceramics. So if you call feldspathic porcelain or feldspathic ceramic, both are the same. It doesn't make any difference. The initial ceramics which are developed, as I said, early 20th centuries, they were feldspathic ceramics. There was no bonding ability. They had and still they have inherent flow inside the fitting surface of the crowns or interior surface. And there was no bondability. And because of that, crack would initiate from those defects inside the fitting surface to the surface, and especially on the posterior areas, all these ceramics were failed because they were cemented, they were not bonded. That's why they become redundant for a while. Then towards the end of 20th century, we start developing the proper ceramics, the stronger ceramics. And then we started bonding the ceramics to the tooth structure and that we learned more about the tooth structure and the mechanism of bondings, and the techniques developed and protocols developed and improved. Now we have the chance of, again, using this type of ceramics, which are aesthetically still the best ceramic in the market. In other category, we have ceramics classified in two groups. Ceramics which are in one part, so the whole ceramic is made of one block material, is called monolithic, or the ceramic which has a strong core, a strong ceramic used as a core, like very similar to porcelain fused to metal. Metal is used to reinforce the ceramic on top of it. And the same way, strong ceramics came to the market and replaced the metal. This is called layered ceramics. So if you look at the image, probably gives you a better idea what's the difference between the layered and the one layer ceramic. So these are the different types of ceramics that can use as a core. For example, lithium disilicate, we said that in terms of strength is the strongest glass-based ceramic. And then glass infiltrated ceramics, Inceram, we're going to discuss that, was another strong ceramic. Alumina, which is not in use anymore, but historically, yes. Zirconia is the most advanced ceramics and are very strong ceramics. They are not bondable, but they are very strong to be used as a core material. And on top, they are layered with the more aesthetically pleasing ceramics. I personally don't recommend this layered ceramics for posterior restorations because of the high failure rate of these layered ceramics, which is weaker, and there is a bit of lack of compatibility, let's say, between the core ceramic and the top ceramic, which is used for the aesthetic reasons, because they are different materials. They're two different elements. But they are a good tool. I mean, these layer ceramics for the anterior teeth when you have an issue with the covering the discoloration or masking the discoloration, because these core materials are the strong ceramics, particularly zirconia. They are opaque. So one of the indications to mask the highly discolored teeth. And then on top of it, you have translucent ceramic, which gives a better aesthetic. New technologies developed a new type of zirconias that we cannot discuss, which provides both of them. And there are two types of ceramics, they bond together well, so that gives a better option. Monolithic ceramics, as we said, again, a different type of ceramics can be monolithic, almost all of them. In one piece, they are stronger, especially zirconia on the posterior teeth. But on the anterior teeth, because of the poor aesthetic of zirconia, because of the opacity, if they are not covered with the aesthetically pleasing ceramic, they look very opaque. And normally we don't use on the anterior teeth. But the lithium disilicate, for example, glass-based ceramic can be monolithic, and even on the anterior teeth, because aesthetically they are still good. This is another example on the anterior teeth. You can see, as I mentioned, on the left side, you see a glass-based ceramics made. It's a monolithic ceramic. And compared to that, on the right side, you see the zirconia as a core used and layered with the glass-based ceramic. The glass is very translucent, but the core is opaque. So first of all, you have to cut too much of tooth structure to create a space for both. In this type of restorations, like PFM, very similar to that. The only difference is that the metal is replaced by high-strength zirconia. And also, it gives a bit of opaque appearance. So it's not aesthetically as good as like the other glass-based ceramics. But the advantage is that they cover the heavy discoloration. If I want to classify the ceramics based on the sintering, based on the manufacturing, this is a different category. The reason I'm mentioning is that you need to, an endodontist needs to understand the difference between these 2 or 3 types of kind of classification. It's easy and it's common to see that in the authors, they mix up these different techniques and the materials and crystalline structure, and it makes it really difficult to work it out what materials they used. Sometimes they refer to the processing technique, sometimes they refer to the crystalline structure, sometimes they refer to the chemistry structure, and so on. So it's so confusing. But I tried to divide them to different categories to make sense of this. In terms of processing, sintering is the oldest technique in which you have a powder and liquid, you mix them together, reheat them, and the liquid evaporates and the particles dissolve and become soft, let's say, on the periphery, and they join or fuse together. The clear example of this, the oldest ceramic, feldspathic ceramics, alumina reinforced feldspathic ceramics, lucite reinforced feldspathic ceramics. These are the kind of old ceramics. Is still gold standard, despite the being old. The reason is all manually made, and it kind of shows the art and the capability of the technician. And you can build up all the fine details in the restoration in terms of the stain and different characteristics, surface characteristics, and so on. So still gold standard, but as you can see, it's expensive because of the time that is spent on it. In terms of strength, they are not very strong, 105 to 160. The weakest one is the feldspathic ceramic in this category, and the lucite reinforced is the strongest one. Another technique is heat pressed, in which you have a wax pattern. You make it in the form of crown, full crown, or core, or whatever you want, substructure, and bury inside the investment, and you heat it up and burn out the wax. Then you heat the ingot of ceramics, which are made for this purpose, and then plunge it into in the cavities or the voids that is created inside. That's why it is called heat pressed. In this category, examples are the lucite-based ceramics. IPSM press was probably the first one that's developed, commonly available. And the lithium disilicate-based ceramics, which they call, dentists now popularly called it EMAX. Initially, it was Impress 2, that is improved, and then they called it IPS EMAX press. And lithium phosphate is another ceramic in this category. The slip cast technique was another technology. And just go back to the strength, you see that the strength range for the heat press, it varies from 140 to 450. So it's much better than sintered one, and in terms of strength. The slip cast technique, on the other hand, was a different technology. They had a special die that they laid down the ceramic, a core ceramic on top of it as a core. And these particles of the ceramic were coated with the wax. And when they burned it out, or they heated up, the wax had burned out, and also the core, not the core, sorry, the die shrunk and dropped. That's why it is called a slip cast, which is slips down, and then you get like a kind of core with a porous structure. Then you put any type of glass on top of it, similar compatible one, and heat it again. Due to the sintering and also melting the glass, it infiltrates to those porosity. That's a basic form of explanation. It's more than that, but just I want to make it simple. And you get a kind of a double layered crown restoration. In this category, you have alumina-based, spinel, which is magnesium oxide base, and zirconia. And not that zirconia that we're going to discuss that these days are available. This was the initial form, which has the zirconia as a main composition in the structure. And now we have more sophisticated equipments, machinable ceramics developed, and the machines are developed based on the CAD/CAM system, which drills out the restoration out of blocks, and the blocks are highly sophisticated. They well processed, and then the restoration is drilled out of those blocks. In terms of CAD/CAM system, we have two technologies: subtractive, which is the milling, as we said, that's you mill out the restoration out of blocks. The other technique is the additive, which is 3D printing. It is developing now. It's coming up. It's almost there. Because of expensive equipment and the lasering and all those things, technology is still not popular, but it's developing quickly. And I won't be surprised if within a year or two we'll be in the market for making the ceramic restorations. But what we have now is the milling system available, and it's been available for a while. Initially, is invented by Dr. Dorrit in 1971. Because of the expensive equipment and probably the technology was very expensive those times, it didn't gain popularity. Later on, it picked up by Dr. Martin in 1978, and first they drilled out inlays, ceramic inlays, chairside, which was exciting. Sirona got the patent, and they got the contract, and they started working on it, and they later developed further by joining to Dentsply, and now jointly they're working on these technology and developing all types of the crowns and things. Lab milling systems are there. You take either digital scanning, scanned impression, or you take an analog impression, send it to the lab, and they will scan it for you, and they make the restoration and send it back. There are also industrial scale milling systems, which are just a few sites or centers in the world globally. It's amazing. You either, again, scan or take an impression, send to them if it's close enough, and they prepare the restoration, send it back to you. Cemented in
Hi,
place.
Dr. Tauraj.
Yes. Hi.
Yes, sorry for the interruption. That we have got 10 minutes left for the presentation.
Okay. Sorry, I thought it's 1 hour time. I didn't see that. Okay, that's okay. That's all right. That's fine. Okay, I'll try to finish
Thanks
as
for
much as I
understanding.
can.
Yeah,
That's okay. That's okay. That's all right. CAD/CAM has its own limitations because it's limited by the size of the drill and the precision of the drill and the angulation and so on. So it's not straightforward kind of preparation. So you need to make all your restoration and preparation rounded angle to make sure that is produced by the machine. This is, again, a brief review of what we said in terms of the different type of ceramics. As you can see, feldspathic is the weakest one with the highest translucency. Lucite ceramics are stronger than, and again, the same way, less translucency is still acceptable. Lithium disilicate is the strongest in the glass based ceramics, 350 to 450 megapascal. And then it comes to the zirconia, 3 yttrium, which is the strongest one with 9,000 to 1,400 megapascal strength. And because of the opacity, it has its own issues, and then the anterior area should be layered, and we already discussed that. This is the point with zirconia. Why zirconia is so strong? Because it has a kind of glass transition formation or toughening effect. The initial crystals are in the tetragonal form, and as they expose to the stress, they convert, they transform to kind of monoclinic, which is larger slightly, and that will put a pressure wherever the stress concentrates on the ceramic, which is the big point of the ceramic. So as the crack grows inside the ceramic, these crystals develop and close the crack. That's why zirconia is tough. But we said that 3 yttrium mole zirconia is a bit opaque. That was the downside of the ceramic. Then they developed 4 mole yttrium percent yttrium ceramic or zirconia. It has more zirconia in it. More yttrium, which generates cubic kind of crystals, and less tetragonal. So the material is less tougher, less stronger, but the cubical crystals gives more translucency. So material becomes weaker, and the strength down to around 850 megapascal. Then 5 mole yttrium, which strength went even further down by improving the translucency. And then the company, Ivoclar Riverdent, come with a genius idea. They combine this together. So the inside of the ceramic, the block that they made is 3 yttrium, and the outside is 5 yttrium, which outside provides good aesthetic, inside provides good strength. Are still not bondable, but aesthetic-wise is better, and they are cementable restorations. So in terms of the fitting the crown, how the crown is, or the restorations are hold on the teeth, you have two systems: adhesive, which is bonded to the tooth structure. You need to have enough tooth structure, enamel dentin, and good moist control. If you don't have that, you have to cement the restoration. In that case, you have to go for zirconia. I brought 2 cases here. The tooth, which is very over tapered, and the big part of the tooth is covered by the restoration composite. You can't bond the restoration to the restoration. So in this case, probably a cemented type of restoration would be better. You have a metal post on the lateral. In this case, again, covering this discoloration is difficult. Might be zirconia, might be able, but ideally I would go for PFM, porcelain fused to metal. In molar, it is over tapered, the crown fallen off, and I would go for, if I can isolate the tooth, I would go for the bonded restoration. Otherwise, I have to prep the tooth to make it more parallel, and the height of the tooth is not enough to provide enough retention. Another factor, excuse me, in providing, in choosing the material is the sufficient strength that we discussed. But consider the fact that zirconia itself has a high strength, so it doesn't need bond to tooth structure. On the other side, glass-based ceramics are weaker, but they are bondable to this structure. They gain that advantage. In terms of clinical evidence, evidence shows that there is no difference between these two types of materials in the clinical performance. They do well as long as you do and use it correctly. Feldspathic ceramics are disadvantaged in terms of the strength of it. Said that we don't recommend it on the posterior teeth, probably on the anterior teeth as a crown, and on the low stress bearing areas. Other than that, other restorations are fine and they do well. In terms of aesthetic, we said that the feldspathic ceramics are much better, and the zirconia is the worst one. The lithium disilicate or the Emax, in other words, is in between. And in terms of tooth conservation, bonded type of restorations are better. This is a new novel CAD/CAM made hybrid materials to overcome the brittleness of the ceramics. All the ceramics are brittle, and in order to overcome that problem, also the wear effect on the opposing tooth, two different materials they develop, which is somewhere between the composites and the ceramics. One material is the polymer reinforced with the ceramic particles, basically is a composite with the higher filler particles in it. Example of is Lava Ultimate. You can mill it and indirectly bond to the tooth structure. And the type is a ceramic infiltrated with the polymer, also known as hybrid ceramics. Vita Enamic is this one. So the main structure is ceramic infiltrated with the resin. In terms of elastic modulus, it's very similar to the enamel, and also wear effect on the opposing teeth. So the patients with the bruxing habit, probably this opens a new window, a new era for the restorations. Long-term results are not available as a crown, but the onlays are doing as good as the other materials, although the strength is slightly less than even Emax. It's around 200 megapascal, but because they are bonded, they are doing really well. And in terms of the preparation, I just, Dr. Kiran, how much time do we have? Or we run out of time? Okay, I'll just finish a couple of slides. In terms of tooth preparation, there are factors that you need to consider. Ceramics are very brittle material. They can fracture. And for that, all the preparations, all the margins should be rounded, smoothened, and polished. There shouldn't be any sharp edges left. Ceramics have low tensile strength, high compressive strength, so the margin finish line should be vertical to the axis of the load. As you can see, you should avoid any bevel on the margins. So the round shoulder is the best preparation, or the second one is the deep chamfer. The amount of tooth reduction is 1 millimeter all around, and 1.5 millimeter to 2 millimeter in the incisal edge. On the posterior teeth, on the functional cusp, 1.5 to 2 millimeter. On the non-functional cusp, 1 to 1.5 millimeter tooth reduction is needed. The thickness of the ceramic should not exceed the 2 millimeter because the glass ceramics are prone to fracture. If you come across the tooth that is extensively damaged, worn down, and broken, you need to either restore the tooth to the anatomical form and cut it back 2 millimeter or 1.5 millimeter, or instruct the lab to make the core anatomical in an anatomical form, so you have glass ceramics just not exceeding more than 2 millimeter. Okay, I think we run out of time, isn't it, Dr. Kiran?
Yeah, no problem. You can take 5 more minutes.
Okay. Okay, that's fine. Thank you very much. In terms of preparation, the new ceramics that we said Ivoclar developed with the combination of 5 yttrium and 3 yttrium, they recommend cutting even less, 0.8 millimeter. Some manufacturer even recommend 0.5 millimeter for the zirconia, which is amazing. And in terms of because the amount of reduction is like equal to metal. I myself, I don't cut the teeth for the crown anymore. It's rarely, I would say 99% of my cases are treated with the onlays, ceramic onlays. And I recommend for all of you, if you don't know or if you don't provide these services, take courses and learn about this. It's easier, faster, and it's safer for the tooth and protect the tooth structure more than preparing the crown. And as I said, there is less chance of periodontal issues, and all the margins can be revisited, re-examined in the sessions, and you can see over the time if anything goes wrong, address it quickly. And the amount of reduction, the same, 1 millimeter all around, except the functional cost, which is 1.5 millimeter, or in a stress-bearing area, probably 2 millimeter it's enough. And you can see only all the margins should be on the enamel and includes the restoration. In terms of the bonding, as I said, if you're bonding the restoration, which is the glass-based ceramics, you have a ceramic on one side, you have the resin, lutein resin, which goes in between, and you have the tooth structure. The tooth structure, you treat it as like bonding to the composite. On the ceramic, you have the sandblast the ceramic and etch it with the hydrofluoric acid, and the silanated after that, and which makes it compatible with the resin, and you can bond it to the tooth structure. And the key point here is to isolate the tooth properly. We have finished that material part. I'm just going through some preparation. This is the extra bit that it wasn't in the plan, but we go as much as we can. The key point after tooth preparation is immediate dental sealing. Probably you have heard of it. A study shows that doing this will increase the strength and durability of the bonding to the dentin over time. And because study shows that the bonding to the dentin takes 2 weeks to develop and mature. And if you keep it to the last moment when you cement in the crown, you don't have the opportunity. So the point is, when you prep the tooth for the crown or onlay, you acid etch and bond it and cure it, and then glycerin on top of it to eliminate the oxygen inhibition layer, and cure it again. And only at the end, one key point, you don't need to leave, and you shouldn't leave the bonding agent on the enamel, and you need to remove that. Just by, if you don't have any other equipment, just fine diamond bare, just go gently and refresh the enamel. You don't need to cut the enamel, just to refresh the enamel. Or you can use ultrasonic devices to remove that bonding agent from the dentin, from the enamel, or polishing the stone. All work better. And when you get the, you did the immediate sealing and dentin sealing, take an impression, send it to the lab, and temporize the tooth. When you get the ceramic back, onlay or crown, you need to prepare the tooth surface, which you do for the bonding system as you do for any bonding system that you're using, doesn't matter. I use 4th generation, and I use adhesive resin cement, which doesn't bond itself, but needs a bonding agent to bond to the tooth structure. And if you use self-adhesive resin cement, you don't need to prepare the tooth. It says, the company says that you can use directly without preparation, but I have a bad experience with them, so I don't use them self-adhesive. On the ceramic, after trying the ceramic in the patient mouth, the tooth has to be isolated from the saliva. You take it out, you wash the inside, sandblast it, and etch it with the hydrofluoric acid, and then wash it and apply silent coupling agent, keep it for 1 minute to dry, and then use the resin, and you inject the resin on the restoration and place it on the tooth and cure it all around and clean it. Just very briefly, I would say. Zirconias, we said that is, although there is technology developed, this chemical technology, which they sandblast the surface of this fitting surface of the zirconia with the special type of particles, which is silica coated, and they claim that this provides the base for silent coupling agent to work and bond. Laboratory results are good, but the clinical evidence is still not there. So until that clinical evidence is available, we don't consider that as a bonded restoration. And I don't bond you can use bonding system. There is no problem of using, but don't rely on that. Your preparation should be retentive enough, means that you need to have a parallel walls like PFM to provide the retention. Don't rely on the bonding. That's my message. There are products developed to clean the ceramics after trying in the patient mouth, because they believe that the saliva contaminates the surface. Sometimes even when washing, even you apply the phosphoric acid, it's not going to go away. So it's better to use some kind of a solvent to remove that. So they developed like an IvoClean, from Ivocolor is a kind of a paste made of zirconium oxide particles in an alkaline suspension, suspended in an alkaline solution. You apply it to the surface and wash it. This neutralizes and washes away all the remnants of the saliva and ensures the surface is ready for bonding. And studies, I mentioned this before, studies shows that performance of all the ceramics are good except the feldspathic ceramics as a crown. And you need to be careful when you're using that. It's better to use for anterior crowns where you don't have too much of stress on the teeth. And apart from that, other ceramics do well if you use it properly. This is a kind of a brief on what we said so far in terms of the glass-based ceramics, hybrid ceramics, we mentioned that, and polycrystalline ceramics. So in the glass-based ceramics, you have feldspathic ceramics, you have lucite-based ceramics, lithium disilicate. These are the three main that we discussed. There are other types, but these are the main branch of the, let's say, ceramics, and the other ceramics are actually derivative of these ceramics. So the feldspathic ceramics can be monolithic or can be used as a layer on top of other ceramics. They have better aesthetic, that's why. They can be manufactured through the sintering, they're old-fashioned, or can be milled out of block. They are etchable, bondable, yes, mostly used as a veneer. And as I said, if it's a low stress-bearing area, you can use an anterior crowns, but be careful with that. Make sure that is not under too much stress. Lucite-based ceramics, almost similar to that in terms of the use, but they are strong enough to be used as a full crown rather than veneer, and also partial crown. They are pressed and milled, they are not sintered. Lithium disilicate is strongest ceramic in this category. Glass-based ceramics we mentioned can be pressed and milled. It can be used as a core, it can be used as a monolithic, or even layer on top of other ceramics because aesthetic is acceptable. They are etchable, bondable, like other glass-based ceramics. They are used for all type of veneers, crowns, partial and full coverage crowns. Hybrid ceramics is almost the same as lithium disilicate. We said that evidence behind the long-term durability of full crowns are limited. So, and they are milled. They are not processed in otherwise. They come as a block, and there's only CAD/CAM system that can mill that out. It opens a new era for restoration of the teeth, especially in the patients which has a bruxing habit, and they don't like metal in their mouth. Otherwise, I would go for gold. Polycrystalline ceramics, alumina is out of market, so there's no point of discussing that. Stabilized zirconia, we said that we have three types now available, and also combination of those. So it can be used as a coping, so you can layer it with other type of ceramics. You can use as a monolithic, which mostly we do with the yttrium 3, and the core also yttrium 3 or 3 yttrium. And layered, layer means here is a 4 yttrium or 5 yttrium, and mostly 5 yttrium, just used on the 3 yttrium as a layer. Only milled, and because they are milled, there is no other way of manufacturing, and they come in the form of green form, what we call it, immature form, millable, because if it is completely processed, it's difficult to mill. So they come in the form of immature synthesized or sintered, and you mill it, they mill it and they form it, and they mill it 20% bigger, because during the second stage of heating or reheating, which is the final maturation, it's going to shrink and that will shrink like 20%. So they kind of compensated that. That brings a problem of inaccuracy. We said that if you look at my slides, I just jumped at that stage. The problem with the zirconia crowns is one problem is the opacity, another problem inaccuracy in the margins. And because the second stage of synthesizing or heating will shrink the crown, but because it's so complex, that the tooth structure is so complex in terms of the shape, the amount of shrinkage in all dimensions is not the same. So we end up with some inaccuracy on the fitting surface and the margins, and the study shows that the average gap is between 100 to 150 micron on the margins, whereas in PFM, ideal situation is 20 to 40 micron. So that big gap is a concern. But the point is, the clinical evidence luckily shows that there is no significant clinical effect. So that's good with that aspect. We are fine with that. The only problem is going to be aesthetic. And on the anterior area, that's why we recommend putting the finish line 0.5 millimeter subgingival to hide that gap. The advantage of zirconia, because of the strength, can be used on top of the other implications or applications, is to make bridge out of it. And some manufacturers even recommend lithium disilicate for making bridge, for ceramic bridge. I'm not convinced with that, because lithium disilicate is a bit weak for that, but the zirconia is fine for even 4-unit bridges according to the company, and I've used it for 3-unit bridges, and it does well. So that is the kind of indication and contraindication. We mentioned this point that we don't count zirconia as bonded restoration. We count as a cemented restoration, and unless there's enough clinical evidence. Probably if you see me next year, my opinion has changed. Depends on the evidence available, but as we stand in now, we don't rely on the bondability of zirconia. Thank you very much for your attention. These are my email address. If you have any questions, apparently here I'm present as long as I can. I am allowed. And thank you for your attention for the whole lecture. If you have any questions now, if you have time, I'll answer. If not, you just send me an email. I'll get back to you as soon as I can.
Are there any questions?
If we have time, hey, Kyron. Oh,
Yeah, Dr. Raz.
hello, Kyron. Yes, can you hear me? Is my audio good?
Yes, I can hear you.
All right, sorry about that. Very, very interesting talk, and thank you for that, Dr. Ross here. I did have a few questions with the presentation. I wanted to know in use case scenario, is there between the different options, does lifestyle or diet matter? Or do you know, meaning thinking of like military, like naval or swimming and spending a lot of time in maybe aquatic situations, and then also dietary restrictions. Are there differences in a different type of options in that situation? And then also with the heating situation and the variability, is there a role for AI and 3D printing as well in this case, and will that be commercialized soon enough?
Okay, thank you very much. Interesting question, Dr. Ross. Yes, it's actually very much related to my previous kind of experience with the sports dentistry, and it's very much linked to military as well. Yes, diet is a big factor. We didn't have time to go too much on the many other factors as well. Diet plays an important role, especially if you look at the margins of the integrity of the margins of the restoration. That's one of the concerns with the zirconia. We have 100 to 150 micron gap on the margin. The cement that we use, if you use GIC, for example, or resin modified GIC, and mostly GIC, because it's dissolvable in acid, especially in the lower jaw, the patient with the high acidic diet is going to get dissolved and you're going to get gap. So we don't recommend in those patients using this kind of cement. Probably zirconia is fine if you don't have any other choice, but we use resin cements instead of GIC in those cases. And apparently all the ceramics, without exception, even zirconia, is prone to hydrolysis against the acid. So if they have too much of acidic food or internal acidic attack like regurgitation, it's going to affect in long term. And the most actually danger is on the opposing teeth, because ceramics has a wear effect on the opposing teeth. And doesn't matter whatever you do, if acid is added to that issue, it's going to make the tooth more prone to wear. So it accelerates the wear on the opposing teeth. That's where it's the hybrid ceramics are developed to answer that problems. When you have those cases, probably these hybrid ceramics work better in those patient mouth. Studies shows the well-polished, mirror-polished, what is called zirconia, has a wear effect on the opposing tooth equal to metal, to gold, which is interesting. However, there is no study on long-term effect, because these acidic attacks on the ceramic over a long period of time can wear off the glaze, can get to the ceramic, make it porous, and then what? We don't know. So these are the bit of evidence. The laboratory evidence is there in favor of zirconia, well-polished zirconia, but long-term effect, we don't know. So in those cases, probably hybrid ceramics are best choice, or better choice, I would say. We have to wait and see the evidence, but it's a good question. In terms of second question, AI definitely has a place. AI is going to come sooner or later. And I think it seems that it's going faster than we think, and it's going to take over. And already there are kind of inventions that actually the AI is involved in the treatment planning, even the preparing the tooth, and so on. So it is coming. It is coming.
Thank you for that. Sorry, wrong.
That's okay.
Sorry. Thank you. That was very interesting topic and conversation. I'll definitely like to talk with you behind the scenes about more, and have you do another presentation to some colleagues of mine. But I'm very interested to know moving forward how these different options will be handled by insurance, and which ones would be approved and based on what and what level and things like, so working out those details, right, and the workflow of that, I'm very interested in having that conversation with you about. But thank you for your time and your presentation today.
You're welcome. Thank you for your attention.
Yeah, thank you very much for your great presentation, Dr. Tauraj.
You're welcome. You're welcome. My pleasure. It's been a pleasure being here. Yes, my email address is there. If anybody has any question later on, can send me an email. I'll get back to you as soon as I can. Hope you enjoy your day.
Yeah. Our next speaker is Dr. Alain Magubo Chijo. Dr. Alain is a holder of PhD in developmental psychology and a lecturer at the Department of Philosophy, Psychology, Sociology, Anthropology, Faculty of Arts, Letters and Human Sciences in University of Ebolowa, Cameroon. Her research was fundamentally focused on femininity, maternity, construction of identity in adolescents confronted with bioecological, social, cultural, technological changes and developmental tasks. Please join me in welcoming our speaker, Dr. Alain.
Hello.
Yeah, hi, Dr. Aline.
Hi.
Yeah, hi.
Hi to everyone. Hi, dear colleagues. It is a real pleasure for me to be part of this forum, scientific forum. I am happy to take part of this forum. I hope I will learn most, and I hope that you will be interested by what I have to share with you this morning. So let me share my screen. Mm, I don't know if everything is okay. Hello.
Yeah, hi, Dr. Aline. Please share your screen.
Hmm. So can you see my screen? Is everything okay?
No, no, you have not shared your screen. Can I share your screen? Can I share your
Yes.
PPT right
Thank
now?
you.
Yeah, I will share it. Please be online.
Okay. Thank you. So the study that I've conducted is untitled Family Coping. I'm a psychologist, and this study is focused on one neuropsychological problem. So the title is Family Coping and Reconstruction of Socio-Emotional Ties in the Biopsychosocial Care of Degenerative Vascular Dementia, a case study. So my communications uh, is have been prepared on eight points. The first point is the context. The other point is a research problem. And next, we will have the hypothesis. And next, the objectives, the methodology, the results, and the conclusion. We first begin with context. Please, slide. So as context, we first present what is degenerative vascular dementia all about. It's a form of psychosis caused by problems with blood flow in the brain. It significantly affects the subject's motor and cognitive functions. It is some of the most common clinical signs includes impaired memory, reasoning, problem solving, or activity planning, speech disorder, impaired walking and balance, vision disorders, focal neurological regulation disorders. The patients suffering from degenerative vascular dementia are the patient is almost a stranger to the care protocol to which he or she is subjected. Caregivers and carers experience a symbolic absence of the patients. We don't have any interaction, especially the emotional interaction between the patients and his environment, especially the family members. We also note the deconstruction of socio-emotional ties between the patient and his family. Here, this means that both physical and mental health are affected. Now, what is the problems concerning a psychologist? According to George Angel, physical and mental health depends on three main factors, which interact permanently: the biological, the psychological, and the social. But in case of degenerative vascular dementia, especially in the African and Cameroonian context, especially talk about hospitals. The emphasis is placed on taking care of the biological dimension of the disease to the detriment of psychological and social dimensions. This means that the doctors treat the body and not the psyche. In such a context, what can be done to guarantee the reconstruction of social emotional links between the patient and his family? What resources can the patient's relative mobilize to integrate the psychological and social dimensions into patient care process? As main answer of those questions, we formulate our hypothesis as follows. The involvement of the family, the team of caregivers, in the therapeutic projects can guarantee the reconstruction of socio-emotional links between the patient and his family, because we know that patient needs to be in a good, to be happy, to enjoy his being. He has to be, how can I say it? He has to be on a good, the care will be at the two dimension, physical and psychological. But in the context where there is not the biological on mental health dimensions, it's important that the patient benefit on it by using other actors. If the hospital is not able to make patient benefits to psychological care, our study is focused on the idea that even the environment can help the patient to manage the mental health.
Hello, Dr. Aline.
Hello.
Yeah, please.
Yes, the next slide is about our objectives. So the main objective of this study is to show that in a case where there is no care. There is no psychological care in the hospital or in the therapeutic protocols. The environment can support the patients affective social in the social or affective dimensions to guarantee the well-being of the psychological dimensions. So to formulate this objective and this hypothesis, we based on three main theoretical perspectives. The first hello?
I think you have logged in from two devices.
Yes.
Please mute for one
So
device, okay?
we focus on three main.
Hello.
Are you getting me?
Yeah, you are. I'm getting you. Okay. Please proceed.
Yeah. Okay. So the the theoretical perspective on which we base on to formulate our hypothesis are the interactionist perspective, the humanist perspective, and the coping perspective. All those theory focus on the idea that if the environment is sufficiently is the environment is able to emotionally affectively interact with the patient will the mental health of the patient will be guaranteed. Hello?
Hello.
Yes. So the next stage is methodology. Concerning our methodology, our study use a descriptive method. Descriptive method and with 6 participants. A patient suffering from degenerative dementia and his family. As family, the patient is 70 years old. As family, we have a spouse and 5 children. So our patients were a number of 6. 6 members of the family and the patients, for a total of 7. As data collection instruments, we used direct observations for the patients, and we use semi-structured interviews with different members of the family. The data that we have collected were analyzed using content analysis. The interviews were focused on retracing the therapeutic itinerary followed by the patient and analyzing the coping strategies put in place by the caregivers. As a result, next slide, please. As a result, we observed that there is indicators in the gradual reconstruction of the social-emotional ties previously broken by disease. Through its role, the team of caregivers, families members, succeeds progressively in restoring a social, cultural, and religious identity to the patient. The team of caregivers provides space for emotional expressions. The team of caregivers provides space for carrying out developmental tasks specific to the elderly. So this means that, okay, this conclusion. So this empirical discovery documents the theoretical field of harmonious aging, one of the most prized and explored in recent years in the psychology of human development. Thank you for your kind attention. This is just a synthesis of our study. I am ready to answer about any questions. Thank you so much.
Are there any questions?
Thank you, Dr. Alina, for your talk. This is Dr. Ross. I have a question. So, did you find between the mental and the physical health, which one was more important in the care or deterioration of care within the patient? Which had a more impact, the mental or the physical?
The mental were more impact, because we realized that when by the beginning of the disease, the family doesn't know that they have a role to play to help the patients to be to interact, because the patient were too much isolated, too much. There were no languages, no verbal languages, and no gestural languages, no behavior. The patient were his in his way. But when the family realized that he has to be interesting by what the patient needs, by what he wants, by what can make him happy, we noticed that the patient were not change the behavior. Can say it that to be simple. He changed the behavior. He now likes to be with the family. He now try to express himself by using behaviors, gestural languages, because with the disease he lost completely the verbal language. So with the support of the environment, he become able to interact, to share his emotion, to share his needs, and the family were now able to know what he needs, what can make him happy, what how to make him happy, and so on and so far. And we
Thank
realized
you.
that the yes the he,
Oh, yes, I had an additional question. Thank you. So, with that, with your intervention, just for some clarity, so was your intervention to the patient alone, or you also had intervention with the family?
I only observe the patients. I have
You only
interviews with the family members. Yes.
Okay, so from your work and what you've done, could you suggest on the timeline of a patient coming in and being assessed with a mental and physical issue, um, at what point and how do you introduce some type of intervention measure or having the discussion with the family and the observation of the patient? When would you suggest that begins?
uh what begins the support of the family, the interaction
Yes.
of the oh the by the family inform me, now giving me information about what how were the patients, the behavior of the patient before they begin to change their behavior. So it's the interviews that I have with the family. How can I say it? It's the family that give me the information concerning the history of the disease.
Yeah, so
It's
my
from the family
question
that
to
I have
you,
that
so,
information.
so my question to you is, do you think this information is valuable enough that it is something that as a practitioner we should design to collect this information upon the initial identification of a patient that is going to require mental and physical care, right? Is this something we want to put up front, and or is it something that you wait until post hospital care, or when the patient is at home, or is it an extended care that begins later on? At what point do you begin to bring in the family and have that understanding, and the information that you got from the family is what I'm trying to get across within the lifetime or the span of the patient care?
The thing beginning with when I was doing a stage in the hospital, I realized that the care of patients suffering from dementia, degenerative vascular dementia, is focused only on the biological points, biological dimensions. And I realized that there is one patient from where I observe a different behavior, and I wanted to know how does he made to be different from the others, because we can observe it was easy to observe that these patients were different from the others. He can smile when he see when you greet him. He can express emotions. He can express needs. He can. So I observed that he is different from the other patients. That's why I've decided to study his case in particular. That's why I decided to study his case in particular, and I decided to contact the family to ask about a study of the case, and of how does he, what mechanism was put in place to have just a wonderful behavior coming from a patient suffering from that disease. So that's the history of the study.
Thank you. Thank you. I really appreciate it. Like the information, and good luck with your future studies.
Thank you so much.
Are there any questions? Thank you very much for a great presentation, Dr. Alang.
Thank you so much, Mr. Kuma.
Kavya, you can introduce the next speaker, Ms. Mio.
Our next speaker is Miss Mio Ondo Flora. Miss Mio is a dental surgeon since July 1st, 2024. She is passionate about oral health and research. After obtaining her bachelor's in 2016, she pursued her studies in dental medicine at Faculty of Medicine and Biomedical Sciences of the University of Yaoundé. During her training, she completed numerous internships and ranked 8th out of 124 in the national ranking examination in dental medicine. Additionally, she founded Smiles Code, a non-profit organization promoting oral health awareness. In 2024, her research thesis on the relationship between periodontal diseases and the uricemia in a group of adults living in Yonde was awarded with high honors and jury congratulations. Please join me in welcoming our speaker, Miss Miu.
Hello, good morning.
Very good
Hello.
morning, Miss Mio.
Okay, thank you for the introduction. It is a pleasure to participate in this conference. Let me share my presentation. Is it okay? Everybody can see my presentation?
As we
Hello.
can see your screen.
Okay. Wait a minute. Okay. It is our pleasure to address this gathering. Dear Professor, distinguished ladies and gentlemen, we are privileged to present our research findings on the relationship between periodontal diseases and uricemia in a group of adults living in Yaoundé. Our presentation will be organized according to the following outline. Following a brief introduction, this presentation will proceed with a chronological manner to address our research objectives, a methodology employed, result which will be discussed concurrently in the context of relevant literature, leading to conclusions. As an introduction, we can say that periodontal diseases are inflammatory disorders affecting the tooth-supporting tissues, primarily manifested as gingivitis and periodontitis. The accumulation of dental plaque is the primary causative factor. Globally, periodontal diseases are prevalent oral health issues affecting over 1.5 billion individuals in Africa. 1.5 billion individuals. In Africa, limited access to dental care exacerbates this public health challenge. In Cameroon, a staggering 62% of population is affected with gingivitis, while 15% will suffer from periodontitis. Periodontal diseases are the leading cause of tooth loss, resulting to compromised mastication, aesthetic, self-esteem, and overall quality of life. Notably, the consequence of periodontal diseases extend beyond the oral cavity, having far-reaching implications. Periodontal diseases have been linked to various systemic conditions, including arterial hypertension, diabetes, obesity, which contribute to increase the risk of cardiovascular disease. Additionally, periodontal diseases are associated with several metabolic disorders, particularly those involved uric acid metabolism. This molecule is the end product of purine metabolism, and the primary associated morbidity is hyperuricemia, which increases the risk of gout and subsequently cardiovascular disease. However, the relationship between periodontal disease and uricemia remains controversial. Indeed, Chai and collaborator found that elevated urine serum levels are associated with a higher risk of periodontitis, whereas Brotto and collaborator did not find a significant relationship between the two. Nevertheless, in sub-Saharan Africa, particularly in Cameroon, few studies have investigated these issues to date. To address this research gap, we conducted this study with the primary aim of studying the relationship between periodontal diseases and uricemia in a group of adults living in Yaoundé. More specifically, our objectives were to present the socio-demographic and clinical characteristics of the study population, to determine the prevalence of hyperuricemia during periodontal diseases, and finally to investigate the link between uricemia and periodontal diseases. To achieve our objectives, this analytical cross-sectional study was carried out over a period of 7 months at the Implantology and Periodontology Laboratory of the Faculty of Medicine and Biomedical Sciences and the Biochemistry Laboratory of the Yaoundé University Teaching Hospital. Participants were Cameroonian residing in Yaoundé, among whom we include participants aged 21 years who provide informed consent. We exclude individuals receiving hypo or hyperuricemia treatment, and with those conditions known to affect uric acid levels or periodontal health, such as pregnancy, chronic kidney disease, obesity, gout, and hypertension. Additionally, participants with unusable samples were excluded during the analytical phase. In summary, our methodology consisted, after following the necessary administrative approvals and ethics clearance, we conducted the study in compliance with Helsinki Declaration, encompassing participants' requirements, data collection, analysis, and interpretation. The clinical data for interest collected include sociodemographic information, medical history, lifestyle factors, periodontal examination data, and biological data. To assess the period-rich food consumption, we developed a semi-quantitative food questionnaire adapted from CADO and collaborator. To evaluate the period-rich food consumption in our Cameroonian population, with expert nutritional guidance, we identified commonly consumed period-rich foods in Cameroon. Consumption frequency were assessed over daily, weekly, and monthly periods, and score from 0 to 8. The total dietary score ranged from 0 to 64, facilitating comparative analysis. Following the dietary assessments, we proceed with periodontal examination. To collect periodontal examination data, we assess each participant's periodontal status using a non-chromatic millimeters scalar periodontal probe. This instrument enables us to measure the periodontal pocket depth, the attachment loss. The adjacent figure illustrates in left the probe's graduation making, and in right the pocket depth measurement in a 25 years old participants. During periodontal examination, we evaluate the various periodontal index scores. This score enables us to assess the status of each parameters with a severity levels ranging from 0 to 3, where score 3 represents the highest degree of severity. To evaluate the index, the evaluated index includes plaque index, gingival index, periodontal pocket depth index, and clinical attachment loss index. We return a diagnosis of gingivitis for a gingival index score greater than 1 on at least 2 non-adjacent teeth. For periodontitis, the diagnosis was based on a clinical attachment loss greater than 3 millimeters, for a clinical attachment loss of at least 1 and 2 millimeters, and a pocket depth greater than 3 millimeters. Following the periodontal examination, we then proceed with biological analysis. This involved measuring serum uric acid levels from a fasting venous blood sample, which was then centrifuged at 3,000 revolutions for 5 minutes to obtain the serum. The measuring method used was urical colorimetric method. After adjusting the reagent and serum, the mixture was homogenized, and 5 minutes later, a pink colored quinonamine complex formed. The intensity of the coloration was proportional to the uric acid concentration in the medium. The reading was taken using a spectrophotometer at a wavelength of 5,020 nanometers. Based on uric acid levels, participants were classified as having hyperuricemia if their levels exceed 70 mg per liter for men and 60 mg per liter for women. The pre-rich diet was stratified into 3 groups based on Kerchill. Data analysis was performed using SPSS software. Quantitative variables were expressed as mean and standard deviation, while quantitative variables were presented as frequency and percentage. Student tests and ANOVA tests were used to compare the mean. Fisher exact test was employed to assess the association between the variables. As a statistical significance threshold of 0.05 was adopted. Ladies and gentlemen, our concurrently analyzed and discussed results. Initially, 187 participants accepted the invitation. After applying eligibility criteria, 181 remained. Two additional participants were excluded, resulting in a final sample of 174. The demographic characteristics of our population show a mean age of 29 years. The sample was predominantly female. In our population, 46% of participants consume alcohol, 46 visited a dentist at least once a year, and 52% had a moderate frequencies of consuming pure-rich foods. Most participants have a visible plaque in the gingival sulcus probing. After probing, 48% of the sample presented with mid-gingival inflammation. A pocket depth of less than 3 millimeters was found in the majority. We found that 75% of individuals suffer from periodontal disease, specifically 71% with gingivitis and 31% with periodontitis. These results differ from those reported by Fado and collaborators, who found that 84% of individuals suffering from periodontal diseases. These discrepancies can be attributed to the fact that their study focused on individuals with rheumatoid arthritis. Indeed, patients with rheumatoid arthritis experience chronic systemic inflammation, including in the gum. This systemic inflammation can exacerbate the periodontal tissue and this inflammation can exacerbate periodontal tissue inflammation and promoting the development of gingivitis and periodontitis. We found that individuals over 29 years old have 7 times more likely to develop periodontal diseases, while alcohol consumer had a 2-fold increased risk of periodontal diseases. These results are consistent with existing literature regarding age, physiological tissue degradation associated with aging, combined with prolonged exposure to etiological factors, make it the major risk factor of periodontal diseases. Our findings on alcohol consumption corroborate those of Souza and collaborator, who demonstrate that alcohol consumption in rats led to alveolar bone loss, likely due to alcohol-induced dry mouth, which can facilitating the accumulating plaque and tartar and subsequently periodontal disease development. Our population's serum uric acid levels show a mean value of 54 milligrams per liter. The prevalence of hyperuricemia in the general population was 20%. Specifically, among individuals with periodontal disease, the prevalence was 20%, and 21% among those without periodontal diseases. We did not find a significant difference in prevalence between periodontal disease subgroups. In contrast of Juyung and collaborators study, who report that 30% of individuals with hyperuricemia present periodontal diseases. A result differ from ours due to their focus on the population with metabolic syndrome. Indeed, metabolic syndrome leads to insulin resistance and disruption, resulting in decreased uric acid excretion, thereby increasing the risk of hyperuricemia. Our study found that males, sex, and frequent consumption of purine-rich foods were associated with elevated serum uric acid levels. These findings corroborate those of existing literature. Male testosterone appear to play a role in increasing uric acid levels, while female estrogen promotes the decrease in uric acid levels. Moreover, purine-rich food constitute the primary exogenous source of uric acid. To assess the relationship between uricemia and periodontal diseases, we first investigate the impact of purine-rich diet on the periodontal disease, and then compare uric acid levels in different groups with and without periodontal diseases. There was no association between frequencies of consuming purine-rich foods and various periodontal diseases, indicating no link between periodontal diseases and food and purine-rich food consumption frequencies. These findings are consistent with existing literature which highlight that diets associated with periodontal diseases are typically high in carbohydrate, which are relatively low in purines. We found no significant difference in uricemia levels between individuals with periodontal diseases and healthy individuals. Additionally, there was no difference in uricemia levels among various periodontal diseases groups. These results are consistent with those reported by Brotto and collaborator. However, they differ from those of Chai and collaborator, who conduct a study on adults aged 19 and 40 in Taiwan and found that individuals with hyperuricemia had a significantly more periodontitis. Notably, their population had a higher prevalence of metabolic syndrome. Those components have established association with periodontal disease. Therefore, analyzing the association between uricemia and periodontal diseases in our population without metabolic syndrome will be the less biased. Our study findings to contribute this understanding. Finally, this work laid the foundation for a longitudinal study to confirm this finding and investigate the risk of gout in individuals with periodontal disease. Dear Professor, Honorable Guest, following the completion of our study on the relationship between periodontal diseases and uricemia in a group of adults living in Yaoundé, we then present the following conclusions. A sample of 174 Cameroonians living in Yaoundé, primarily consisting of young adult females, we found that periodontal diseases affected 75% of population. Gingivitis was the most prevalent condition and was mainly observed in individuals over 29 years and those who consume alcohol. The prevalence of hyperuricemia among individuals with periodontal diseases was 20%. Hyperuricemia was the more common among male and those with purine-rich diet. No significant association was found between uricemia and periodontal diseases. We thank all people who participate in this study, and we thank you for your attention.
Are there any questions? Yeah, thank you very much for your great presentation, Ms. Mio.
Thank you.
Yeah, our next speaker is Dr. Neha Upadhyaya. Dr. Neha is a skilled dentist who is an academician and specializes in oral and maxillofacial pathologist, forensic odontology. She is a fellow of prestigious Piri Fortune Academy, USA. She has been instrumental in establishing the Department of Oral Pathology and Microbiology and postgraduate at Chandra Dental College and Hospital since its inception. She was one of the mentor teacher and was instrumental in cultural organizing committee in the college. She has attended and volunteered multiple lectures and workshops and conferences nationally. She is a life member of various organizations and active in social work. She has been awarded with Inspiring Icon, Dental Diva Bharatiya Nari Ratna Award as a Best Researcher in Oral Pathology at various platforms. She has been external examiner and paper sitter for various renowned Indian universities and has chaired in several scientific sessions in various national and international conferences, convention workshops. Presently, she is working as a professor in PIMS Lucknow. Please join me in welcoming our speaker, Dr. Neha.
Hello, everyone. Am I audible here?
Hello.
Can you hear me?
Yeah, yes, we can hear you.
Okay. Thank you for the kind introduction, Dr. I thank this HK conferences for giving me this opportunity. Can I start with my presentation here?
Yeah, 1 minute, please. Yes, you can proceed with your presentation, Dr. Neha.
My presentation is visible on your screen because I'm
Yes, we
sharing,
can.
so I'm not able to see the view what I'm getting it here.
As we can see.
Okay.
Please click on slideshow option.
Sure. Right.
Yeah, the fourth one. Next.
Fourth one?
Yeah, next. Yes, that's.
Okay. Thank you. So my topic for presentation today is the oral pre-cancer and early cancer detection in the dental office, a review of the new technologies. Before starting with my presentation, let me first clear the oral pre-cancer is a very, very deadly term because it is as deadly as cancer itself. Early diagnosis can save a life. So it's very important, and it's today my lecture is to make you all people aware of the importance of the biopsy and the importance of the pre-cancer, because many times we take pre-cancer lightly, and the global burden, we all know the consequences. So starting with my introduction, the idea of the pre-cancer has been slowly changing and is often confusing concept, beginning with the long history of 1805 suggestions by the European Panel of Physicians that there are 9 diseases which will always develop into invasive malignancies if followed long enough. In its definition, a precancer is considered only hold an increased risk of cancer transformation. The workshop held by WHO in London, New York back in 2005 actually recommended the elimination of the term precancer and the use of the term, presumably more illuminating term, the potentially malignant lesion for the oral lesions. Historically, the definition of the oral pre-malignant lesion dates back to 1978 when it was defined by WHO as a morphologically altered tissue in which the cancer is more likely to occur than its apparently normal counterpart. Here is a big list of the potentially malignant lesions and conditions. I'll just read this list. May be boring for you people, but you should know that these are not the non-serious lesions. They should be taken care of in your clinics if they visit you. The proliferative verrucous leukoplakia, the nicotine palatinus in reverse smokers, erythroplakia, oral submucous fibrosis with leukoplakia, erythroleukoplakia, granular leukoplakia, laryngeal keratosis, actinic chelosis, syphilitic glossitis with dorsal leukoplakias, smooth thick leukoplakia, smokeless tobacco keratosis, the plumbus in Wilson disease, that is same as the sideropenic dysphasia, or related with the iron deficiency anemia. Next is the lichen planus. It's all the form. The dangerous one is the erosive form, and the smooth thin leukoplakia, lupus erythematosus, disc keratosis congenita, epidermolysis bullosa, and the Clark-Howell-Evans syndrome with the oral leukoplakic lesions. Of these, the leukoplakia represents more than 80% of the precancers and shows an increasing prevalence with increasing ages as well as with the increased daily uses of the smoked tobacco. Once applied to any kind and all the white mucosal plaques of the mouth, the leukoplakia today is defined as the white patch or plaque that cannot be characterized clinically or pathologically as any other disease and is not associated with any obvious etiological agent except for the tobacco use. This definition excludes the lichen planus, frictional keratosis, smokeless tobacco keratosis, nicotine palatinus, and alveolar keratosis. All these diseases were once included in the diagnosis of leukoplakia. The term leukoplakia is now used in the strictly clinical sense and does not imply a specific microscopic tissue alteration except, of course, the excess surface keratin, which is responsible for the white color change. So how often are the dysplastic cells found in the leukoplakia or erythroplakia? Before going on to this slide, let me first discuss what do you mean by the dysplasia, right? So what is dysplasia? Dysplasia is aberrant and uncoordinated cellular proliferation. It is aberrant and uncoordinated cellular proliferation, which can be depicted at the cellular level called as the atypia, and the reflection at the tissue level is called as the dysplasia. So coming back, how often are the dysplastic cells found in the leukoplakia or erythroplakia? First, let me make it clear that leukoplakia are the white patch and erythro means red. So it is related to a red patch, which may be previously a leukoplakia or from the beginning it may be erythroplakia. So in leukoplakia, the overall only 5 to 25% chances are there to see the dysplastic cells when biopsied. While in the erythroplakia, it is almost more than 90% of the chance to have the dysplastic cells. So we can logically consider that all the erythroplakias are of high risk in the conversion to cancer, and the same cannot be said for the leukoplakia. In fact, a great majority of leukoplakic lesions may not even show the atypia. But it is a clinical entity and it has a malignant transformation rate of approximately 4%, roughly, I would say. Then the transformation rate with epithelial dysplasia will become significantly higher, approximating to the 4 to 11%. And with the severe dysplasia, it may also transform to 20 to 35%. These are some of the histopathological features of the epithelial dysplasia. While observing under the microscope, we see all these things. There should be either loss of polarity in the basal cell, or there are more than one layer of cells in the basiloid appearance. Then there are increased nucleus cytoplasmic ratio, dropped or bulbous retiridges. I'll explain that in the diagram, but just let me tell all the points. Irregular epithelial stratification, increased number of mitotic figures, the presence of mitotic figures in the superficial half of the epithelium, the cellular pleomorphism, nuclear pleomorphism, and the mitotic figures can be abnormal also. Then the reduction of the cellular cohesion, keratinization of the single cell, that is individual cell keratinization, or some group of cells. We have the grading of the dysplasia as mild, moderate, and severe. The mild, when all the epithelial dysplastic features, which I have enumerated in the last slide, when they are confined to the basal third of the epithelium, it is called as a mild form. Then when it is confined to up to the two-third form, two-third of the epithelium, it is called as a moderate dysplasia, and severe, it is more than two-third. Sometimes they will be in toto, all the cells be involved, that is more than two-third. Then the top to bottom dysplastic changes is called as the carcinoma in situ. How then we can determine clinically whether the lesion is a high risk or not? So it will depend upon if the lesion is large in size, or there are rough or granular surface changes. Initially, it may be smooth. Now it has become granular or rough. Then red or pink patches incorporated within the white patch of leukoplakia. It is termed as speckled leukoplakia or the erythroleukoplakia. Then we can have multiple leukoplakic lesions that is involved in the concept of the field cancerization, where not a single area, the whole of the oral tissue in different sites is likely to have increased risk of cancer. And the ulcerative mucosal breakdown, that is, more of the ulcers, can also be significant in this regard. So these high-risk clinical features suggest that the increased risk is identifying the potential biopsy site where the dysplastic cells are more likely to be found and can be easily diagnosed. Suppose if we have a white lesion and the red lesion, so in the same patient, it will be seen that the biopsy site will be better to take from the red areas rather than the white areas. That is, we are more likely to discover the dysplastic cells in the red areas. And sometimes if we take it from the white area, there may be a negative biopsy, and that will give us a false sense of security that the lesion is not very dangerous, and that will be a poor follow-up of that lesion. So for several decades, the above mentioned clinical features had been the only guide we all had for the risk assessment of the oral precancers, and in the hand of the experienced clinicians, they have always served remarkably well. Unfortunately, most of us lack that level of experience or that level of expertise required, or it will take time, almost 5 to 10 years, to make the ideal decisions. I'm not commenting personally, but fortunately, the new technologies are providing the general dentists with the help. They can do it in the office settings. Before coming to the actual technologies, let me differentiate between the screening and the case finding. Screening is a term related to the oral cancer diagnosis when the application of the test or tests are required in the apparently free from disease person. And case finding suggests the application of the test to a person who has already developed the things and their abnormal signs or clinical symptoms in order to establish a diagnosis. And now the patient has come for the treatment. So the aim of this lecture is the increase in the number of screening patients, because case finding is already there. The patient knows that he has developed something wrong. Screening is important for us to learn and to send the patient for preventing the cancer. The pap smears. Today, the pap smears can be used effectively for the oral lead and the oral ulcers to identify the infections, which is especially candidiasis, atypical cells in the erythroplakia, a disease in which the dysplastic epithelial cells are typically near the surface. But the oral white patches have a thicker keratin, and the dysplastic or immature epithelial cells arise from the bottom of the oral squamous epithelium. So should not be expected to be taken by the breaking of the thick keratin. So pap smear is quite successful in the red lesions and ulcers. But when it comes to the white patch, if there is thick keratin, there will be just a superficial scraping of the keratin, leaving behind the dysplastic cells. In this regards, we can take help from the brush biopsy. The brush biopsy has overcome this fatal shortcoming of the pap smear by screwing a bristle over the wire, that is the brush, through the thick surface of keratin to the basal layer of the epithelium. It's a relatively painless procedure. Painless in the sense it will not be as painful, but it is necessary to take the cells from the bottom layers of the deeper epithelium. So it captures the deeper epithelial cells on the bristles, and the entire brush is sent to the pathology lab, where the cells are removed and plated on the microscopic slide. And from that point onwards, the process is same as the routine pap smear. So advantage is that the brush will take the deeper cells here, not only the superficial scrape, it will be taking the deeper cells. So we'll get the dysplastic cells from the basal epithelium, and we can get the diagnosis of the dysplasia. And from there, the cytotechnologist or the pathologist can take, even now we have the softwares and computer associated optical scanners to see the size of the each and every cell. So we can compare with the dark nuclei, dysplastic immature cells, or the abnormal nuclear shapes of pleomorphism. And the result will be reported in the one of the level of the risk of dysplasia, that is the mild, moderate, severe. Recently, the liquid-based cytology has become the principal methodology in the cytopathology, replacing the conventional smears, owing to better cell recovery and the morphologic preservation. In the liquid, what will be done? There will be more of the morphology of the cell will be preserved. They will not distort, they will not dry up, they will not undergo that level of desiccation. So it will be better if we can send the biopsy in the form of the liquid-based cytology. So here that will use either a filtration method or the sedimentation process to recover the cells from the biopsy specimen. So here the method is similar. We have the liquid-based cytology that is collected in the bottles. And now the bottle will be sent either for filtration or sedimentation, and then the process will be similar, that the cells can be slid on the slides. So advantage that these methods will produce the evenly distributed thin layer of epithelial cells devoid of blood and inflammatory cells that may interfere with the cytologic examination. And liquid brush biopsy method appears not only to increase the sensitivity and specificity of the cytologic diagnosis, but significantly also provides the additional samples which can be sent for the higher studies of the immunohistochemical and other molecular studies, which are not possible with the conventional cytologic smear. But the limitation is that the brush biopsy is not a true diagnostic tool, because the definitive diagnosis can only be established with the incisional biopsy. And we all know that the biopsy is the gold standard for the diagnosis or the histopathological diagnosis. it can be a good adjuvant aid rather. So it is a good tool in the experienced and knowledgeable hand who knows from where the severe areas are there, where to brush the tissue. It also implies that the clinician is capable of distinguishing between the lesions, and that is why I took your time to enumerate all those lesions. Kindly go through the manuals and do not leave any suspected lesion. Do the at least first brush biopsy in the clinics. Next is the toluidine blue, highlighting the area of the dysplastic tissue. Toluidine blue, the toluenium chloride, is a metachromatic dye long used in the histology laboratories that is used to the stain of the nuclear material since it stains the DNA very well. So this test is premised on the fact that the mucosal cells with extra DNA, which is seen in the dysplastic cells, that is the large nuclei, they will attract and retain the stain even after the bulk of the stain will be washed off with the help of the acetic acid. So this was the thin layer of leukoplakia in the floor, and with the help of the toluidine blue, we can see that it has highlighted the area of the potential dysplastic cells. So here the biopsy should be done. Advantages: it is simple, quick, and cost-effective, and it can be used or clear areas of the dysplasia prior to the definitive cancer surgery, and it can be good adjunctive test in the hand of the knowledgeable clinician who is especially effective with the erythroplakias and the carcinoma in situs. Coming to the limitation, unfortunately, it is quite awkward to use because it requires the acetic acid, which is vinegar, and the taste may not be good enough for the patient. And there are high proportionals of even the false positive and the false negative cases. So in case of the trauma or inflammation, that should be clearly ruled out. Moreover, the dysplastic cells lying deep in the thick keratotic lesions will not be stained adequately. So it should not be considered the standalone test and will not give the diagnosis, but it can help to localize the areas where the biopsy or the brush biopsy has to be performed. Coming to the Visilite, that is highlighting the keratin. Visilite, we have long ago been aware of the ability of the acetic acid to enhance the region of the thickened surface keratin. So in the oral environment, likewise, it will make the keratin more white and more visible to the naked eye. The thin leukoplakia, which might otherwise have been missed, now could be detected after a minute of contact with the acetic acid. This technology uses the reflected light solely and so can only give us the information of the most superficial cell layer. Again, so it is not going to give us the idea of the deep dysplastic cells, but it can just highlight the superficial layers. The light is derived from either the chemical tube, that is chemiluminescence, or laser, or recently the toluidine blue, which has been added to the Visilite Plus R kit. The advantage, the method is simple, quick, and result is achieved only in the 5 minutes. And disadvantage, it will show the high proportion of false negative and false positive as in the previous cases. One of the example here is shown in the Visilite. This is making the leukoedema more noticeable. We all know that leukoedema is not a dysplasia, condition of dysplasia. Another disadvantage is that suppose if this whole area is dysplastic, you can see the drop-shaped red ridges, and the dysplasia is seen here as well with hyperchromatic nuclei. But the Visilite will highlight the keratin area here because this is the keratinized area. So it will give you idea that the biopsy area is this one. Rather, the dysplasia is spread across the layer and this whole area is dysplastic rather than this one. So the Visilite is good in emphasizing the keratotic surface changes, and this should be taken care of that the other areas may not be missed off. Again, that requires with the switch of the acetic acid before and after the examination. So it is that is a disadvantage of the taste of the acetic acid, and it is best performed in the completely dark room, which is quite difficult in the dental clinic or dental office. Coming to the next devices, the oral autoimmunofluorescence, when the mucosa does not glow. We have two optical devices. Actually, there are more, but I have taken the two commoner ones, the Veloscope R and the Identify R Ultra. And to a certain degree, we all can glow. That is the fact. That is the autofluorescence. Each our cells contain some molecules which are capable to show the fluorescence, that is glow, when activated or excited by a specific light wave. So if a cell is there and we have the excited specific light wave, we can glow. But the excitation and emission of the fluorescence depends on how the light is scattered and how it is absorbed in the tissue. The scattering will cause the difference in the indices of the refraction of the different tissue component, while the absorption will change on the molecular composition of the same. So these are some molecules in the cell which can glow: the tryptophan, porphyrines, collagen crosslinks, elastins, NADS, that is nicotinamide adenine dinucleotide, and flavins, flavine adenosine dinucleotides. This fluorescent signaling has been used to assess the metabolic state of the tissue and to identify the primitive or dysplastic cells. The amount of fluorescence given off by the living tissue is very slight, certainly not capable of being seen under the normal circumstances. However, if violet or blue light is used in the darkened room and the clinical peers through the eyepiece of the glass, which will filter out the virtually reflected light, that will give us the excite the greatest fluorescence in the oral mucosa, ranging between the 400 to 460 nanometers. So these devices use the same range of light. Like Identify R3000 Ultra shines the violet light of approximately 405 nanometer, and it is a battery powered device, as light as a handpiece. This device will provide a white light suitable for the conventional visual examination, and green amber light that will be highlighting the keratinized mucosa, submucosa, blood vessel. So something like this. There is a filter goggle, and the light green is seen through the examination. And similarly, Veloscope is there, which uses the light wave of approximately 436 nanometer that stimulates the green fluorescence here. Very similar to the gun-shaped thing, and the light is used. The operator and the patient both are wearing the goggles to prevent themselves from these rays. And the principle is that the immature or the dysplastic epithelial cells, which has much less of NADH and FAD activity than the normal cells, so the mucosal areas of such cell will not fluorescence. So that will appear black. That is, those areas in which the cancer is more likely to be there, that will appear darker in color. So this was the appearance in the normal light of the squamous cell area affected in the tongue. And you can see that under the Veloscope or Identify R, the area is much, much darker because it has lost autofluorescence in this area. Another example is from the actiniculosis in a 37-year-old woman. Here you can see that the areas are appearing much, much darker and showing the dysplasia. Another photograph. Here you cannot clinically differentiate what it is, but with the help of the Veloscope, we can see a well-demarcated loss of the autofluorescence, and we can identify the area in this dysplastic area. So advantage is that the light can be used to excite the oral cells that is penetrating the deepest part of the epithelium, and it can easily reach the dysplastic cells, as we have seen in all the examples. And this technology has identified the dysplastic cells even in the micro-invasive lesions, which can be easily overlooked in the clinic. Disadvantage is that it is several non-dysplastic tissues, that is false positive and false negative. And problem is with the hemoglobin, melanin deposition, mild trauma or inflammation, and equipment cost is quite high. Some of the recent advances are in the field of the spectroscopy, ratio imaging, optical coherent tomography, multiphoton excited fluorescence, nuclear magnetic resonance spectroscopy, the PCR polymerase chain reactions, and the immunohistochemistry. I am not going into details with that. So the take-home message from me is that the biopsy are the important adjuvant aid in the diagnosis of the potentially malignant lesions. And most of the technologies are beneficial but must be used with intelligence and must be considered adjuvantive test rather than the standalone diagnostic test. Thank you.
Are there any questions? Yeah. Thank you very much for your great presentation, Dr. Neha.
Thank you.
Our next speaker is Dr. Colo Toro Francis Daniel. Dr. Daniel trained as an oral physician. He holds a master's degree in odontological sciences and a PhD candidate. He is passionate about teaching and basic research. He is interested in clarified tissues pathologies and bone remodeling anomalies. He is a medical expert in legal compensation for personal injury. He is interested in the nominative aspects of odontostomatology. Please join me in welcoming our speaker, Dr. Daniel.
Dr. Daniel, you can share your screen. Yeah, please unmute your mic. Yeah, you have to open the Zoom. Then you have to unmute your mic. Open the Zoom app. Yeah, please speak now.
Okay.
Yes, we can hear you. Yeah, click on the share option. Open the Zoom app. Click on share. Yeah, that's great. Yeah, under you can
Okay.
click on the
Is it
slideshow.
okay for you?
Slideshow option. Slideshow. Go down. Yeah, here. Yeah. Right side. Down. Go down.
Okay.
No. Here. Commentaries. You can see down. On the footer, you can see the commentaries, right? Footer. End. Not there. Here you can see 98%, right? Yeah, that's one. Yeah, perfect.
Is it okay for you? For everyone?
Yeah, thank you. Yeah, it's okay.
Okay. Thank you for this very flattering presentation of me. It is a pleasure to present a summary of our work in this webinar. So, our plan will be constituted as follows. After an introduction, we will present a methodology used, the result obtained and discussed, and we will end with a conclusion and perspective. By way of introduction, we can say that Bone lesion is an abnormality occurring in and previously normal bone. It includes simple or serious fracture. A mandibular fracture is a break in continuity which may or may not be the result of trauma. The prevalence of this fracture was 54% in Cameroon in 2000 and the treatment modality are surgical, orthopedic, or mixed, leading to bone consolidation. Bone healing is defined as the action whereby bone fragments are reassembled via complex biological mechanism. Its assessment is a necessity and in our context is carried out radiological and or clinically. However, it encountered constraints such as high cost, unavailability of equipment, subjective nature, and high radiation doses. Bone consolidation also leads to the release of biochemical markers in the blood. The assay is accessible and inexpensive. However, can these biochemical markers predict or confirm good bone consolidation compared with clinical radiological element in mandibular fracture in vista rate? The general aim of our work was therefore to determining the kinetic of biochemical marker during two types of mandibular bone lesion in vista rate. More specifically, it was a question of establish the evolution of anthropometric data during experimentation and to determine the activity of biochemical markers of bone remodeling in total alkaline phosphatase, calcium, and inorganic phosphorus. To achieve this objective, we conducted an experimental study for age mount probes. The reference period for data collection was from January to June. Our study took place successively at the EMPM, the Faculty of Sciences, the Biochemical Laboratory, and the Radiological and Medical Imaging Department of the CHU in Yaoundé. Our source population consists of male and female rate, all of vista screen sampling. Our sample was probabilistic and the sampling method was simple random. Our sample size was 24 rate divided into three groups of age rate. Group 1 represent control rate. Group 2, rate that had undergone dental extraction. And group 3, those who had undergone bone drilling. Our study include vista rate of each week of age minimum. Exclude from the study were descended rate and those with a 10% reduction in initial body weight. In addition to written research authorization from the Director General of CHU, we have obtained ethical clearance, respect to martial law principle, the principle of laboratory animal care, and the 3A rule and the principle of standard of the Declaration of Helsinki. Our study began with the selection, research, and acclimatization of our rates over a 3-week period. The rates were made on the tail with a non-toxic blue pencil for male and a black pencil for female. This marking also enabled them to be identified within each group. They were stored in 5-liter plastic basin, labeled and covered with Thai mesh, white mesh to prevent escape. Water was given and left them from a homemade bottle. Food was given every other day during acclimatization. Bedding made of shaving was changed every other day, which were taken every other day using an electronic scale. Bone lesions were initiated by sedating the rat with ketamine and diazepam injection. Injection was intraperitoneal. In group 2 rat, the lower sacral incisor was extracted using a lower incisor forceps. In group 3, grill holes were drilled using a 1.6 millimeters drill bit mount on a handpiece and a micromotor running. Irrigation was constant during grilling to avoid overheating. Samples were taken weekly in retroorbital position using glass microhematocrit capillary tube. The sample size was changed at each session. The blood collected was placed in dry tube and transported in the color to the biochemistry laboratory for analysis. Once the blood had been centrifuged, we used a spectrophotometer to determine the total alkaline phosphatase by kinetic method and the calcium and inorganic phosphorus by colorimetric method. Our data were entered and analyzed using CS Pro version 7.3 and GraphPath version 8.0.1. Quantitative data were expressed as mean and standard error of the mean. Person coloration coefficient was used to investigate the relationship between biochemical and radiological parameters. Our result, anthropometrically, weight loss was observed exclusively in the female rate of group 2 and 3 from 1 to 3 weeks of experimentation. This weight loss was greater in rate with extracted teeth than in those with drill holes. In 4 weeks, dental extraction resulted in a significant increase in phosphatase alkaline concentration in female rate. In week 6, phosphatase alkaline activity was highest in group 2 and group 3 compared with the control group. In male, at week 3, the drill hole result in a significant increase to that of the extracted rate. This is in agreement with study conducted in India in 2000 by Patil and collaborators in phosphatase alkaline at week 4 post-op in dogs. This could be explained by the proliferation of osteoblasts and the lesion sites and the contribution of the periosteum of the scroll bone, which is a source of alkaline phosphatase. In the present study, in week 5, the bore wall result in a significant decrease in calcium level in female rate compared with the control group. In week 4, the bowel significantly increased calcium level compared with the control group also. This in an agreement with Nila Jaggi and collaborators in India and Vane collaborator who observed a non-significant decrease in serum calcium up to week 4, followed by non-significant increase up to week 8. Here, in week 1, grading result in a significant increase in phosphorus level compared with the control group. In the week 6, dental extraction result in a significant decrease in phosphorus level in female rate compared with rate in the control groups also. We can conclude that the activities of our biochemical markers increase gradually in our experimental groups compared with the control group. Biochemical markers can be useful to assess bone healing of an alveolar dental or cortical lesion and can therefore constitute an alternative to traditional methods. Thank you for your attention.
Yeah, are there any questions? Yeah. Our next speaker is Dr. Elizabeth Ruiz. Dr. Elizabeth is a passionate leadership psychology scholar practitioner dedicated to empowering individuals and organizations to thrive. With over 35 years of experience in strategic communication and leadership development, she specializes in unlocking potential through customized solutions and innovative training. Elizabeth holds an MBA from the University of Texas of the Permian Basin, a Master of Science from Columbia University, and a PhD in Organizational Leadership from Concordia University, Chicago. Beyond her personal pursuits, she is adventurous and skilled, enjoys skiing, climbing, and flying. A committed advocate for animal welfare, which she thrives to make a positive impact in her community. Please join me in welcoming our speaker, Dr. Elizabeth Ruiz.
Thank you, Karen. Welcome, everyone. I'm in the United States and it's 5:26 a.m. here. I don't know where everyone is right now, but it's either good morning, good afternoon, or good evening. It's a pleasure to be here.
It's great, Dr. Elizabeth.
Raise your hand if you know what behavioral psychology is. Anyone? Well, this presentation is part of a one-day workshop that I created from my latest book. And it's called Unlock the Secrets to Exceptional Leadership. And today we will look at 3 sections. This is normally a one-day workshop. We'll do this in 30 minutes. We're going to look at 3 sections. The first section is exploring the link between behavioral psychology and leadership. The second one is understanding the impact of psychological principles on leadership practices. And finally, the third, emotional intelligence, transformational leadership, and social learning theory. Since I did not hear anyone share what behavioral psychology is, I will share it. Behavior, it's also known as behaviorism, and it's a branch of psychology. And it focuses on studying and analyzing observable behavior. It emphasizes the role of environmental factors in influencing behavior, and it suggests that all behaviors are acquired through interaction with the environment. And this approach often involves the principle of conditioning, including classical and operant conditioning to understand how and why behavior changes. There are 4 key definitions and sources, and the first one is by J.B. Watson, 1913. The second is B.F. Skinner in 1953. Third is Pavlov in 1927 and Bandura in 1977. With Watson in 1913 in his foundational work, John B. Watson defined behaviorism as an objective experimental branch of natural science that requires introspection to study the relationship between stimuli and responses. Watson's perspective emphasized the prediction and control of behavior as its goals. But with B.F. Skinner in 1953, Science and Human Behavior, B.F. Skinner expanded on behaviorism by focusing on operant conditioning, which is a concept in which behavior is influenced by its consequences, such as rewards or punishments. Skinner's work contributed significantly to understanding how environmental reinforcement shapes behavior. The third, 1927, Pavlov, that was conditioned reflexes. Ivan Pavlov's research on classical conditioning highlighted how behaviors could be learned through association, demonstrating that certain stimuli could trigger automatic responses when paired repeatedly with unconditional stimulus. And finally, the fourth, Bandura in 1977, that was social learning theory. While not strictly within the traditional behaviorist framework, Albert Bandura introduced key concepts bridging behaviorism and cognitive psychology, emphasizing observational learning where behavior is acquired by watching others. Now, these sources and definitions collectively show that behavioral psychology is centered around the idea that behavior can be studied in a systematic and observable manner without considering internal mental states. And instead, it focuses on external behaviors and the processes by which they are learned and maintained. Therefore, behavioral psychology, again, it's a branch of psychology that focuses on understanding and analyzing observable behaviors rather than internal mental processes. It emphasizes the role of environmental factors in shaping behavior, and it's suggesting that all behaviors are learned through interactions with the environment. The key concepts in behavioral psychology, such as the classical conditioning, the operant conditioning, the social learning, it provides the valuable insights into how individuals acquire and modify their actions based on reinforcement and social influence. Now, we looked at behavioral psychology. Now let's look on leadership. How do these two marry? Well, leadership, on the other hand, it involves influencing and guiding individuals or groups toward achieving goals. Effective leadership requires understanding not only one's own behavior, but also the behaviors of motivations of team members. Next, we will explore emotional intelligence and leadership. These 3 topics or tips that we're going to share here, the first is Daniel Goleman, 1995, Recognizing and Managing Our Own Emotions and Others. And then we'll talk about high emotional intelligence. which is better motivation, conflict resolution, and communication. The third is how emotional intelligence builds psychological safety in teams. I'm sure a lot of you here have heard or practiced and been mindful of building psychological safety in teams. Why is this important? The importance of emotional intelligence, or EI, is so important in a team. The most important reason I can share is when we're in a team, and if we don't feel safe to share an idea or a fear, or if we have a question, or if we need help, that person or that team member will be silent. It is up to the leader to not only know who they are, but to be able to practice emotional intelligence. Can everyone hear me? It says it looks like I'm done talking. Can you hear me?
Yes.
Oh, great. Okay. Therefore, the definition of emotional intelligence, it refers to the ability to perceive, understand, manage, and regulate emotions in oneself and others. Now, Daniel Goleman popularized this concept in his book, Emotional Intelligence, and it was out in 1995. Now, who here knows the 5 key elements or the components of EI? Anyone know one of the elements? You want to guess? Well, there's 5 key elements, and the first is self-awareness, understanding one's own emotions, strengths, weaknesses, and values. And the second is self-regulation, the ability to manage emotions, particularly in stressful situations, and to maintain control over impulses. Third is motivation, the drive to pursue goals for personal reasons rather than external rewards includes resilience and commitment. Now, I have heard multiple times a team member call another person or refer to them as they are so resilient. And that is really being able to practice emotional intelligence. And the fourth is empathy, the capacity to recognize and understand the emotions of others, which enhances interpersonal relationships. And we will touch on that later. But the fifth is social skills. And this is proficiency in managing relationships and building networks. It's crucial for collaboration and effective communication. Next, we're going to look at the benefits of emotional intelligence. These 3 tips here that we're going to share, the first one is how it helps leaders manage stress and model resilience. The second is how it improves team dynamics and it reduces burnout. And the third we'll touch on is how this can lead to higher team performance and engagement. Let's look at the importance of emotional intelligence and leadership. We're going to look at 6. We'll look at 6 items. The first is enhanced communication skills. Do you feel you have enhanced communication skills? If not, this is a great way to practice. We can always learn how to acquire emotional intelligence. By doing so, leaders with high emotional intelligence are adept at conveying messages clearly and effectively while being sensitive to their team's emotional states. By understanding emotional cues, leaders can tailor their communication styles to different audiences, fostering better relationships and reducing misunderstandings. The second is conflict resolution. High emotional intelligence enables leaders to navigate conflicts more effectively by remaining calm, understanding different perspectives, and facilitating constructive dialogue. Also, leaders who practice empathy can address underlying emotional issues, leading to quicker and more amicable resolutions. Third, building trust and credibility. Emotional intelligence helps leaders create authentic team connections, fostering trust and loyalty. When team members sense that a leader understands their emotions and cares about their well-being, it enhances engagement and commitment to organizational goals. The fourth is improved decision-making. Leaders with high emotional intelligence are more attuned to their emotions and those of their team members, which aids in making balanced and informed decisions. By considering emotional factors in decision-making, leaders can mitigate biases and ensure that their choices reflect the values and the needs of their team. Fifth, it promotes a positive work environment. Emotionally intelligent leaders create a supportive atmosphere, encouraging open dialogue, collaboration, and psychological safety. A positive environment enhances employee morale, increasing productivity and reducing turnover. And finally, the sixth point, facilitating change management. High EI allows leaders to recognize and address the emotional challenges or change initiatives, helping team members adapt more effectively. Leaders can lead by example, demonstrating resilience and a positive outlook during transitions, alleviating team members' anxiety. Now, some research supporting emotional intelligence and leadership is one, Goleman's research. Daniel Goleman's research indicated that emotional intelligence is a key predictor of success in leadership roles. His studies found that EI accounts for nearly 90% of what sets top performers apart from peers with similar technical skills and intelligence. There's also something called a bar-on model. The bar-on emotional quotient inventory demonstrates that emotional intelligence contributes to overall job performance and satisfaction. Research using this model has shown that leaders with high EI foster better workplace relationships and improving team performance. Now, there's some practical application of EI in leadership development, and there's 3 of them. It's training programs, regular feedback and coaching, and self-reflection practices. Next, we're going to explore transformational leadership and behavioral psychology. And here, 3 items we'll talk about on this slide is 1, how this is rooted in positive reinforcement and recognition. And second, it focuses on intrinsic innovation and building trust. And third, encourages innovation, engagement, and productivity. Let's look at leadership styles informed by psychology. And this is an overview of leadership styles. Raise your hand if you know your leadership style. There are different leadership styles. We're mostly a mixture. Sometimes you can be one type, but let's look at a few. So the overview of leadership styles is that it reflects leaders' methods and approaches to guide and influence their teams. Behavioral psychology offers valuable insights into how different leadership styles can be developed and applied effectively. And yes, you heard that right. It can be developed. We're not all born leaders. It can be developed and applied effectively based on psychological theories and principles. Now, key leadership styles and their psychological underpinnings, there are, let's see, there's 6. I'll share 6. And the first, you probably guessed it, it's transformational leadership. Now, transformational leaders inspire and motivate their team members to go beyond self-interest for the organization's good. They focus on creating a vision fostering an innovative environment and encouraging personal development. This is a really great leadership style. Now, the psychological basis, and is founded on Maslow's hierarchy of needs, and transformational leadership addresses a higher order of psychological needs, such as self-actualization and esteem. So by appealing to these needs, leaders nurture intrinsic motivation and commitment. Now, how do we apply this? These leaders often use storytelling and vision sharing techniques to connect emotionally with their followers, promoting an empowering culture. The second is transactional leadership. Transactional leaders operate within established structures and focus on the exchange process between leader and follower. They provide rewards for compliance and consequences. Failure to meet standards, you suffer the consequence. Now, psychological basis here, this is rooted in B.F. Skinner's operant conditioning style, and this method relies on reinforcement principles, shaping behavior through rewards and punishments. And the application here for transactional leadership would be effective transactional leaders will clarify expectations and provide feedback, relying on structured systems to maintain performance and compliance. And the third out of the 6 is servant leadership. I fall in servant leadership myself. I am a volunteer in multiple organizations, and I'm sure a lot of you, especially as educators, we do fall into servant leadership as well. Again, we are probably, all of us are a mixture of different types of leadership styles. And a servant leader emphasizes on serving their team, prioritizing the needs of others before their own. They focus on empowering and uplifting team members to help them reach their full potential. Now, the psychological basis here is that it aligns with Carl Rogan's humanistic psychology, and it emphasizes empathy, active listening, and the importance of nurturing individual growth and self-worth. And the application for servant leaders is they build trust and engagement by demonstrating empathy and supporting their team's development, fostering collaborative and positive work environment. And the fourth out of the 6 is autocratic leadership. And autocratic leaders make decisions unilaterally and maintaining strict control over their teams. They rely on their authority to enforce policies and directives. The psychological basis here is that this style can be linked to Kurt Lewin's leadership style framework, particularly in situations that require quick decision-making, and it assumes that leaders believe that they can best determine the course of action. Now, while effective in a crisis or when immediate compliance is essential, and over-reliance on this style can lead to low morale and creativity over time. The fifth is democratic leadership or participative, and this is where leaders will encourage team participation in decision-making processes. They value feedback and input from team members, fostering a collaborative work environment. Now, this is based on the Deci and Ryan self-determination theory, and this style supports individuals' intrinsic motivation by allowing them to feel valued and invested in the outcomes of their work. And a democratic leader, they'll create an atmosphere of trust, leading to higher job satisfaction and commitment as team members feel their contributions are appreciated and impactful. And then finally, the 6 is the laissez-faire leadership. And this is where leaders offer minimal supervision and allow team members to make decisions independently. It's a hands-off approach, and it provides freedom, but may lack direction. This style can relate to Herzberg's two-factor theory, and while it can encourage innovation for self-motivated individuals, it may have less motivated team members without guidance or support. This is most effective when team members are highly skilled, self-directed, or capable of managing their work without constant oversight. Now for this, I would say here the implications for leadership development is a 4-factor here. And one I would say is personalized leadership training, adaptive leadership, focus on emotional intelligence, and team dynamic awareness. We are now going to explore behavioral principles in action and transformational leadership. The 3 items we'll discuss here on this slide is positive feedback encourages desired behaviors, recognition fosters loyalty and performance, and intrinsic motivation leads to sustained productivity. When we explore behavioral principles in action and transformational leadership, basically it's characterized by a leader's ability to inspire and motivate followers to exceed their self-interest for the organization's greater good, fostering an environment of innovation and personal development. And this leadership style heavily employs behavioral principles grounded in psychology to engage team members and drive organizational success. Now, there are some key behavioral principles that are frequently applied in transformational leadership, and they are 1, positive reinforcement, 2, modeling desired behaviors or role modeling, 3 is empathy and emotional intelligence, 4 is creating a vision, 5 is fostering autonomy and empowerment, 6 is facilitating professional development, 7 is encouraging innovation and creativity. Basically, transformational leadership is deeply rooted in behavioral principles that enhance team members' motivation, engagement, and performance. We will move into key theories in behavioral psychology on our next slide. 3 things here we'll touch is this is based on Bandura's social learning theory, 1977. Leaders serve as role models for behavior, and team members mirror leaders' actions, whether calm or stressed. Key theories in behavioral psychology. It's also known as behavioralism or behaviorism, and it basically focuses on observable behaviors and the ways they're learned. There's several key theories here in the field, and this provides a foundational understanding of behavior development and modification. But here are some of the most significant theories in behavioral psychology. Again, the classical conditioning by Pavlov. The second is the operant conditioning, and that's the B.F. Skinner. The third is the social learning theory, and that's by Bandura. 4th is cognitive behavioral theory, and that's Aaron Beck. 5th is behavior modification techniques. And 6th is the drive theory, and that's by Clark Hull. 7 is self-determination theory, Deci and Ryan. And basically, understanding those key theories in behavioral psychology is essential for leaders, educators, and practitioners. The insights gleaned from the classical and the operant conditioning, social learning theory, cognitive behavior theory, drive theory, and self-determination theory will inform effective strategies for behavior modification and leadership practices. We will now look at leaders as role models. I selected 2 different leaders as role models. These were case study analysis that we have in the book, the workbook. And just as an overview, the first one is Steve Jobs at Apple. And this case study was done by Isaacson in 2011. Most of us should know Steve Jobs. He was the co-founder of Apple, and he's renowned for his visionary leadership and transformative impact on technology and design. Walter Isaacson's biography, Steve Jobs, 2011, it provides an in-depth look at Jobs' leadership style, decisions, and psychological principles, which he employed to drive Apple to success. Now, these are some key leadership traits for this case study: visionary thinking, demand for excellence, and focus on user experience. The behavioral psychology principles at play were 3 of them: operant conditioning, social learning theory, and emotional intelligence. There was impact and there was legacy. Highly recommend reading that book if you have not. The second case study is from PepsiCo, Indra Nooyi. And this is from an author, Bactier, 2019. And basically, for the overview, she served as the CEO of PepsiCo from 2006 to 2018, leading the company through significant changes and challenges. There is an article, it's called Life in Leadership, and it's in 2019, and it talks about her leadership style and psychological principles she applied to enhance organizational effectiveness. And those key leadership traits are strategic vision, inclusive leadership, empathy, and communication. Now, the behavioral psychology principles at play is social learning theory, motivation theories, and emotional intelligence. So they are both have that emotional intelligence. Let's take a look at leadership training and development next. These 3 tips here I'll talk about on this slide is training that focuses on self-awareness, empathy, and behavioral reinforcement. Second, adaptive leadership skills for complex environments, and enhance both motivation and responsiveness in teams when we are having leadership training and development programs. Now, developing leadership potential, there's numerous ways to do it. And the 4 top ones for behavioral assessment tools, one is behavioral assessment tools, and it's to identify leadership talent. And you can do this from a 360-degree feedback, a personality assessment, a third is behavioral interviews, and the 4th is leadership simulations. I personally like all 4. Leadership simulations are hands-on, and you can see it, watch it, and you can give that feedback right away. And it's wonderful. I don't know if you want to raise your hand if you've ever done a leadership simulation. Highly recommend. Now, there are training programs, and this follows Kouzes and Posner's Leadership Challenge, 1987, and basically the overview of the Leadership Challenge. It was developed by Kouzes and Posner, and it's a model that identifies 5 practices of exemplary leadership that can be learned and developed. And there's 5 practices: model the way, inspire a shared vision, challenge the process, enable others to act, and encourage the heart. There is an application of the model. It's widely used in leadership development programs, and it helps individuals cultivate essential leadership skills. Highly recommend this at least once in your team. Now, there are exercises and worksheets in Chapter 9 and 10, in Chapter 9, and then there's also a leadership blueprint for personal notes, checklists, as well as action items in Chapter 10 in this workbook. Now, this workbook is a 1-day workshop, and I've condensed it into 30 minutes. So if you would like Chapters 9 and 10 of these exercises and blueprint, you can connect with me on LinkedIn and then message me for the chapters, or you can email me. Now, let's conclude and take a look at future directions. The future trends in leadership and psychology. Well, I heard it before. It's the impact of AI and data analytics on behavioral psychology and leadership. And there are 4 of them: enhanced decision-making, personalized leadership approaches, real-time feedback mechanisms, behavioral insights through natural language processing, NLP. I'm going to go back to the 3rd, real-time feedback mechanisms. These are AI-driven tools, and they can provide real-time feedback. One, I would like to reach out now. It's free. It's called Udily. I don't know if anyone's ever used that, but you can Google it. It's Yoodli, and it's an AI-based, and it helps when we give speeches or speaking or presentations, and I highly recommend that. Now, the potential future developments in leadership theory is integrating behavioral economics, which I love, emphasis on adaptive leadership, focus on well-being and mental health, which is widely discussed now, and collaborative and distributed leadership models. Now, the key takeaways for the critical concepts and applications are 6. Understanding behavior, leadership styles influenced by psychology, motivation and engagement, effective communication, decision-making and problem-solving, and ethical leadership. If you have questions, please feel free to reach out to me. And if you have your phone, you can scan the QR code. This goes directly to my LinkedIn page. I would love to connect with you on LinkedIn. If not, you can email me at my initials, EAR, stands for Elizabeth Ann Ruiz, EAR leadership@gmail.com, EAR leadership@gmail.com, or you can scan the QR code. The majority of the references, there are over 40 references, and they're in the back of this book. I would be happy to share that with you as well. But the top 4 is Bandura, Bass, Deci, and Goldman. That's it. Thank you. Back to you.
Yeah. Are there any questions? Thank you very much for your great presentation, Dr. Elizabeth.
My pleasure.
Yeah. Coming to our next speaker. Our next speaker is Dr. Ariba Aslam. Dr. Ariba Aslam is a distinguished academic and professional trainer with over 10 years of experience in teaching and research, specializing in behavioral, gender, and institutional economics. She has served at renowned institutions including the University of Lahore, and the Punjab Economic Research Institute, Government of Punjab. As a founder of Next Gen Training and Consultancy, she has conducted over 40 impactful training sessions and workshops. Dr. Ariba earned her PhD in economics at the age of 26, making her one of the youngest females in the field, and is a gold medalist in both her MPhil in Applied Economics and BS Honors in Economics and Political Science from Forman Christian College. She has received multiple accolades, including the Best Researcher Award 2021 to 2023, the Phenomenal Woman Award, and was selected to represent Pakistan at the Nobel Laureate meetings in Germany, where she also won the Lindo Seitan in 2021 with 74 research publications in prestigious journals, 2 authored books, and 500 research projects to her name. She continues to inspire through her contributions to academia and professional development. Please join me in welcoming our speaker, Dr. Ariba Aslam.
Thank you so much for the warm welcome. I hope I am audible.
Yes, you are audible.
Thank you. Thank you for a very nice introduction. And I would, before beginning into my the topic that I'm going to be explaining today, I would like to congratulate Dr. Elizabeth for such a wonderful presentation and for her book. And it is really very interesting, and I would surely connect with her. You have done a great job. The topic is somehow, linked with the previous one, because here we are also talking about, health. And when we talk about health, you talk about physical health and the emotional health, which is again the same of the debate that we were talking about. I will be presenting on the topic of the impact of health on earnings of female home-based workers in Punjab from Pakistan. So this research basically dives deep into how health outcomes can shape the economic lives of women in the home-based workforce. I'm Dr. Adiba Aslam from University of Lahore and also the founder of NextGen. So let me start by setting up the context. Pakistan has around 12 million home-based workers, and out of those home-based workers, 25%, which makes 1 out of every 4 of them, are women. Their daily earnings differ significantly from regions like from Upper Punjab and Lower Punjab. And on average, we can say that these women are earning very, very low. How much low? In Upper Punjab, they are earning around rupees 223, and in Lower Punjab, they are earning as low as rupees 190. Now, how do you expect that somebody can take care of, education, food, basic life necessities, in just earning rupees 200 per day? This is something that is below the bar, and expecting and thinking of a life in such low income is almost impossible. So this was basically the motivation which encouraged me to take this project. And this was basically a funded project from my university, and it was funded by SRGP to 2023. So from the respondents, we found out that 60% if you want to say it more accurately, it could be like 67% come from Upper Punjab, and while 33% were taken from Lower Punjab. So the core question that we are addressing here is, how do health outcomes impact the earnings of these female workers? To explore this, we looked at earnings as a function of different variables, which included health, education, experience, and market knowledge, and we followed the Mincer equation function. For our methodology, we employed mixed methods that combine descriptive as well as econometric analysis. Our data comes from a survey conducted by Punjab Bureau of Statistics with an impressive sample of 11,650 respondents. And we built our model around 2 scenarios. One is that positive health shocks, which include access to health facilities and trainings. And then there was negative health shocks such as injuries. And by following these 2 variables, we came up with very interesting findings. Let me go to next slide. So since it was a primary data study, so the R-square was low, and it was 0.47 for Upper Punjab and 0.21 for Lower Punjab, which is the limitation of our study. But our key findings here is that positive health shocks has significantly improved the earnings, with Upper Punjab showing a stronger impact compared to the Lower Punjab. For instance, awareness of health facilities in Upper Punjab boost earning by around 9.83%, while training programs in Lower Punjab have shown no significant impact. On the flip side, negative health shocks like injuries are much more prevalent in Lower Punjab, and it led to significant reduction in earnings. So these findings underline how, you can say, critical health interventions are very important for boosting up the incomes. So now let's discuss the key relationships that we observed. Firstly, we found out that better health directly correlates with higher earnings, as it allows workers to be more productive. Secondly, education plays a pivotal role in improving the health awareness, which in turn impacts the earnings positively. Interestingly, market knowledge emerged as a critical critical factor, especially in Upper Punjab, with a 12.34 increase in earnings. And this shows that improving access to market information can unlock better opportunities for women workers. So conclude, our research basically highlights a bidirectional relationship between health and earnings. And we found out, and we can conclude, that addressing health challenges can help reduce poverty among female home-based workers, and policy measures like integrating the health facilities and providing market knowledge trainings can bring transformative changes for these home-based workers, which are earning very, very low. We have already discussed it. So for future research, I proposed using panel data and across different provinces of Pakistan as well as different provinces of India. Since this conference is happening from Indian hosts on majority, I was seeing their names. So particularly this case could be made even more interesting if we do a comparison between Pakistan Punjab and Indian Punjab. And then let's see how, female home-based earnings differ in two of these regions, and what could be the factors particularly related to health, positive and negative health shocks, which can, help in having a more comprehensive picture. So that is all from my side. I am also the founder of Next Gen Research Trainings and Consultancy, and there we provide a lot of workshops on free basis, and you're most welcome to join it. The link for that has been shared with you in the chat. Thank you.
Are there any questions? Thank you very much for a great presentation, Dr. Ariba.
Thank you.
Sir, may I ask a question?
Yes, you can.
Okay, Mr. Riba, Assalamu alaikum. I wanted to know your this presentation you have shown to us, is this published or not?
No, this is not published yet, and this is one of the reasons why I'm presenting it over here, because in conference, basically, you look for those papers which are, in the publishing phase for your comments.
Okay, thank you. Then we'll be looking forward for it. Kindly share when it's will.
Sure, I would love to. I think there are no more questions. I'll take a leave. Thank you for joining.
Yeah, thank you. Yeah, Dr. Seong, are you there? Hello. Hi, Dr. Seong. Hello. You are on mute.
Yeah. Hello, this is Sangu.
Yeah.
Can you
Yeah.
hear me?
Yeah. I will introduce you, okay?
Yeah.
Yeah, our next speaker is Dr. Seong Gu Wu. Dr. Seong Gu Wu has a BS and MS in Mechanical Engineering and has obtained PhD in Mechanical Engineering from Texas A&M. He majors in energy systems such as HVAC and its heat transfer, optimal design and control of refrigerator, reliability design of thermal components, and failure analysis of thermal components in marketplace using the non-destructive such as SEM and X-ray. In 1992 to 1997, he worked in Agency for Defense Development, Jinhae, South Korea, where he has researcher in charge of development of naval weapon systems. He was working as a senior reliability engineer in refrigerator division, digital appliances, Samsung Electronics. Now he is working as an associate professor in mechanical development, Ethiopian Technical University. Please join me in welcoming our speaker, Dr. Seong Woo Woo. Dr. Seong, you can share your.
Yeah. Can I start?
Yes, you can go ahead.
Yes. Thank you inviting me and the presenter my the presentation. My name is Dr. Wu. I'm working in the Ethiopia Technology University. I present entitled as improving particle design of the mechanical system, such as a refrigerator. This methodology will be improve of the design of mechanical system, and I will give you some case of study. This is a typical mechanical system, and heat engine and the refrigerator. And this is heat engine. Heat engine supplying the heat from the hot source, transfer to the cold sink. In the process, some generating and some work. And on the other hand, and refrigerator supplying the heat from the cold source and transfer the hot source. In the process, generating some works. This is automobile. Automobile is consist of several parts: engine and transmission and driver, electric system, etc. And the total component is 20,000 pieces. Life target is between 10 years. To improve the performance and reduce costing, product will be designed yearly. By the live testing, engineers should define design flow of the product module. This is airplane. Airplane consists of the machine and door, aviation control, etc. Total component 200,000 pieces. Life target is between 10 years. This is a refrigerator. Refrigerator consists of the cabinet, door, internal fixed, general part, etc. Total component 2,000 pieces. Life target is between 10 years. This is the definition of the reliability. Reliability can define of the ability to item to the perform required function and under the state and environment operation condition for the sufficient period of time. And most of mechanical systems, the reliability can be described as bathtub. If I follow the bathtub, the product will be rejected, and because of the initial failure rate, higher failure rate, short lifetime. Because of the company set up the right close plan as a design improved, and the bathtub changed to the straight line, and the product reliability can be achieved design the failure. This is a sinking picture of the RS Titanic and the 1912. It can be the cold seawater, brittle steel, and the temperature. The starboard side, the Titanic struck iceberg. And as a result, RM's Titanic had 2,000 people on board. It takes 2 hours, 40 minutes to thinking drowned to death, and more than 1,500 people. This is disaster of the challenge. It came from lucky booster was sealed with 2 rubber, brittle O-ring with the winter weather. As a result, this debacle occurred in 1986. All crew members lost their lives. This is a collapse of Point Pleasant Bridge in 1967. It can be the metal fatigue of the critical wall due to the land traffic load. As a result, on the December 15, 1967, the Silver Bridge collapsed under the weight of the rush hour traffic, resulting in death of 46 people. This is a crash of the Harland Comet. This is the first commercial jet. It can be a structure failure, resulting from the metal fatigue in the airframe. And as a result, and the problem starting emerging and the suffering and the catastrophe in flight. Years entering airline service with the 3 combat lost. This is a failure mechanism and the design, and this is structure. A structure subject to the repeatable load. There are some the design flaw on the structure. The structure will be collapsed each lifetime. The issue, how to find the design flaw, the layer flowability. The solution is reliability testing under X-Live testing. This is a test material in product and metal and polymer and the ceramic and the composite. This is my graphic study of the abstract. First, I will explain the quantum error model and then the transport phenomena on the material. In the process, I will find the general stress model and to developing and accelerate factor. I will modeling and the system, deriving and the communication and time to failure model and accelerate the factor. Finally, I will carry out the parameter alter with the sample size equation. In the process, I will find some design problem on the system. This is a quantum error model. This is Schrödinger equation. This is a boundary condition. Based on the boundary condition, we can derive the wave function and the energy. This is a linear transport process in mechanical field. J is a flux, X is the driving force, L is a transport coefficient. And for example, and the fixed law is diffusion. The F is flux, and the delta C is diffusion force, and L diffusivity. This is one of the example of the transport phenomena and solid state diffusion impurity in silicon. It takes place electromigration inducing voiding, buildup of the chloride ion, traffic and the electric field, electronic and the holes. This is a junction function in the material. And if I apply and some electric field and electric in the void is migrate and the right hand side. Finally, junction function is a model as a sine high function and the exponential temperature. This is junction function in silicon. If I take inverse, we can derive the general stress model. The issue how to define of the sine high function. Sine high function start linear, and power stress and exponential. Most of test is carried out the medium the effect. Time to failure model simply and defined as n power stress, exponential temperature. Finally, and the accelerate factor is redefined as a ratio of stress and exponential temperature difference. This is how the multi-port system. Powers can be defined as a product of the effort and the flow. For example, and the translated system, effort is a force, flow is a velocity. Most of the stress is came from the effort, and the accelerate factor is the redefined as the ratio of the effort exponential temperature difference. I will explain how to derive the sample size equation. And the product follow the y-bar distribution. Life function is defined as a function of the shape parameter and the characteristic life. If I take logarithm, we can define as a Vx life. Vx life is defined as a logarithm function and the characteristic life. Characteristic life is defined as a chi-square function and the testing data. Finally, and the Vx life is a function of the chi-square and the logarithmic and the testing data. To derive the sample size equation from the approximation Vx life, there are two approximations. One is a chi-square approximation. Another one is a logarithmic approximation. Confidence level is 60, R is less than 4. Chi-square function approaching and alpha is 1. And logarithmic function approaching x. If I rearrange it, we can derive the sample size equation. I will give you one of the case of study and my design theory. This is a redesigned compressor with crankshaft. This is a refrigerator. This is a compressor with the new redesign of the crankshaft. There are a lot of design port in compressor. We don't know which filters. Compressors lifetime is dependent on the pneumatic part. To find them, it requires the lifetime methodology. This is a filament design of schematic. Compressor is designed to the increasing pressure from low and higher. We don't know that the customer and the load environment condition. Engine should be designed each part optimally. Lifetime methodology consists of 3 parts: failure analysis for the return product, filament art design modification, finally checking and the product achieved life target. This is a compressor in vapor compression cycle. This is a vapor compression cycle. It consists of the compressor and the condenser and the coupling tube and the evaporator. This is the pH diagram. This is schematic diagram of the compressor. Compressor operating by the slide crank mechanism. This is damaged product in peel. We found a lot of the wear on the surface of the crankshaft due to the lubrication problem in peel. It came from the improper design of structure. To modify and we can reproducing parameter art and collect them. This is the load analysis for the X-light testing. This is vapor compression cycle. This is a test diagram. From the conservation of the mass in coupling tube, energy balance and the condenser and the evaporator, we can determine the mass evaporator and the temperature of the evaporator and the condenser. Finally, time to failure mode depends on the pressure difference and the exponential temperature. This is accelerator factor, and accelerator factor is defined as the ratio of the pressure difference, exponential temperature difference. And this is how to calculate of the accelerator factor. For pressure, worst of case and the pressure difference almost 1.1. For accelerator testing, pressure difference almost 2. Accelerator factor is 3.4. For the temperature, worst of case dome temperature is 19. And for accelerator testing, dome temperature is almost 120. And total accelerator factor 4.6. We are applying some duty cycle. We can search out design failure. This is the how to calculate the mission cycle. Life target of domestic compressor is beyond life 10 years. Accelerator factor 4.6. Total sample size of domestic compressor is 100. Compressor life target for 10 years, almost 87,000 cycle. There is no problem 19,000 cycle. We can guarantee compressor life target beyond life 10 years. This is equipment used for X-light testing. This is a test trigger. This is schematic diagram of the compressor. And we can proceed the parameter art with the equipment. This is a result of the first parameter art. Compressor locked due to lubrication 7 and 10,000 cycle. This is a field photo. This is a result of the first parameter art. We found a lot of the wear on the surface of the crankshaft. By parameter art, we can reproduce computer failure in field. And we checked the design of the compressor. We found 3 design problems. One is a low lubrication area. Another one is a low starting RPM. And then the compressor material problem. Ejection plan, we redesign of the crankshaft and changing and some the dimension, adding in the new glue, changing material from the FCD 450 to the FCD 500. By parameter art, we can collect the compressor failure. But this is the result of the second parameter art. Crankshaft wear is found in 19,000 cycle. and it came from the interference between the crankshaft and the slash word due to the narrow clearance. This is an old design. This is a new design. We modify and the clearance from the 0.1 and the 0.5. And by parameter art, we can modify and design port of the compressor. This is a summary of the parameter art result. There is no problem in compressor 19,000 cycle. And in first parameter art, we found the lubrication problem and crankshaft. In the second art, we found some air on the surface of the crankshaft. In third art, there is no problem. And 19 and 20,000 cycle, compressor achieved life target beyond life 10 years. This is another case of study hinge kit system. This is a refrigerator. This is hinge kit system. Hinge kit system is consists of several parts and cover, damp, and spring, and housing. There are a lot of design flaw of the hinge kit system. We don't know which parts. Hinge kit system life target depend on design flaw of the part. To find them, it requires the life methodology. This is a parameter design of schematic. Hinge kit system is depend on the hinge kit system designed to the close the door smoothly. We don't know how the customer and the load environment condition. Engine should be designed and each part optimally. Light methodology that consists of the 3 part: failure analysis for the return product, parameter art design modification, and finally checking and the life target is achieved. This is a damaged product in field. We found there are a lot of the crack on the surface of the hinge kit housing in came from the fragile structure. By reproducing parameter art, we can collect them. This is a load analysis for the X-ray testing. Hinge kit system depend on the door weight, and to increase impact, we added additional weight on the end of the door weight. By controlling impact, we can carry out X-ray testing. This is how to calculate the missed accelerated factor. And as I mentioned, the accelerated factor depends on the ratio of the impact. This is how to calculate of the accelerated factor. Worst of case impact is 1.1. For accelerated testing, the impact is 2.8. Accelerated factor is 6.3. We apply in some duty cycle, we can search out design failure. This is how to calculate the mission cycle. Life targets the hinge kit system beyond like 10 years. Accelerated factor is 6.3. Total sample size of the hinge kit system is 6. Hinge kit life targets for 10 years, almost 37,000 cycle. There is no problem, 41 mission cycle, we can guarantee. And life targets the hinge kit system beyond like 10 years. This is equipment for the user for the X-ray testing. This is hinge kit system, and this is a test jig, and then the controller. We can proceed the parameter art with the equipment. This is the result of the first parameter art. Hinge housing of the hinge kit system crack and 7 and 50,000 cycle. This is the field photo. This is the result of the first parameter art. We found a lot of crack on the surface of the hinge kit system. By parameter art, we can reproduce design flow of the hinge kit system. As action plan, we reinforced the fragile structure of the hinge kit housing system. We added some rounding outside. We also give it to the reinforced lip on the housing and the deck system. This is the result of the first parameter art we found in the licked oil damp. It came from the chromatic sealing structure. This is old design. This is new design. By parameter art, we can reproduce design port of the old damp. This is the result of the second parameter art. Housing cover of the hinge kit system is cracked, and the 7 and the 19,000 cycle. And it came from the material problem. And when operating hinge kit system, damper spot, strike, and the hinge cover. Finally, and the hinge cover is a fracture. And as action plan, we modify the material from the plastic to the aluminum die casting. By parameter alter, we can modify and the fragile housing cover of the hinge kit system. This is a summary of the parameter alter result. There is no problem in hinge kit system 41,000 cycle. In first parameter alt, we found in fracture of the housing cover and leakage of the oil damp. In second alt, we found in some fracture of the housing cover. In third alt, there is no problem. 41 and the 74,000 cycle. Conclusion. This is my paper submitted to the mechanical system and the signal processor, entitled as Improving Live Target Mechanical System During Transit and Established, and the Quantum Transported Live Stress Prototype and the sample size. This page explained my background of the design theory. This is my books entitled as Design Mechanical System. This experimental design theory methodology describes the U-parameter art for the reliable quantitative test specification. It able to the mechanical civil engineer to find the design flaw and achieve the target and the product reliability. It also suggests the apply of the case of study on the mechanical system, present the Daguchi method and the alternative experimental methodology. This is my recent publication. Thank you. Thank you for listening to my presentation. Hello?
Yeah. Are there any questions? Yeah, thank you very much for your great presentation, Dr. Seong.
Thank you. Thank you.
Yeah, 2 minutes, please. Yeah, Mr. Adam, are you there? Hello.
Hello. Yeah, good afternoon.
Yeah, you are not audible.
Can you hear me?
Could you speak a little bit louder?
Okay. What about now? Can you hear me now?
Yeah, it's okay. It's perfect now.
Okay.
Yeah, our next speaker is Mr. Treasure Adama. Mr. Treasure Adama is a passionate microbiologist and emerging public health advocate specializing in viral immunology and infectious diseases. During his undergraduate studies, Adama played a pivotal role in research projects addressing global and community health challenges. His thesis, High Prevalence of Hepatitis E IgM Antibody Among Pregnant Women in the second and third trimester in southwest Nigeria, was published in the Pan African Journal of Life Sciences. He also contributed to an EU funded project investigating the role of nanotechnology in the rapid diagnosis of rotavirus infections. This experience has found his expertise in molecular virology techniques, including PCR and gel electrophoresis. Currently, he is serving as a graduate assistant under the National Youth Self Corps at the University of Benin. Please join me in welcoming our speaker, Mr. Treasure Adama.
Okay, thank you so much. Uh, it's a pleasure
Yeah, could
to
you
be
speak a
here.
little bit louder?
Yeah, can you hear me?
Yeah, somewhat.
Okay, good. Maybe because of my earpiece. I want to believe you all can hear me. It's a pleasure to be here this wonderful afternoon. It's afternoon here in Nigeria, and I'm happy to share with you what I have today. I would like to share my screen now so that you
Yeah, could you
see that.
speak a little bit louder? We are not audible, okay? The voice.
You hear me now?
No.
Okay, sorry.
Yeah, it's perfect now.
Okay, good, good.
Without the
Yeah,
headphones, it
so
is perfect.
okay, that's okay, that's okay. So I'll quickly share my screen so that you could follow with me as I present on this very important topic. I appreciate the introduction that Mr. Dr. Kiran has done. And can you see my screen now?
Yeah, yes, we can. Yeah, it's perfect now. Okay, we can share. We can see your screen.
Okay, okay, thank you. Oh, okay, that's okay. Now I will be speaking very briefly. Of course, I am a virologist, so that I make an impact in this field, and I will be talking on the topic titled Evaluating the Impact of Enteric Viruses on Public Health, a comprehensive review of noroviruses and rotavirus challenges and the prevention strategies. Of course, I would introduce to you what we call the enteric viruses. Enteric viruses are those viruses that causes gastroenteritis, right? They affect the abdominal parts of the body. They affect the system. They affect us, maybe perhaps when you take some little doses of those microorganisms, of course, perhaps the viral particles, it leads to what? It leads to a kind of severe gastroenteritis that leads to some symptoms For example, you have vomiting, diarrhea, and the likes. So enteric viruses such as norovirus and rotavirus, they significantly impact public health. And we are going to be diving into this topic because it is something that is so important. Like Dr. Kiran introduced, I did my bachelor studies, and then during my research project, I worked on the prevalence of hepatitis A and hepatitis E.
Mr. Adam,
Um,
sorry for the
can
interruption. Click on the full screen mode. Click on the full
sorry?
screen. Click on the full
Can
screen mode. Okay. Top here you will see settings button on the top.
okay. Sorry.
No. Please open the slides.
Sorry. Sorry for that technical. Can you see me now?
Yeah,
Is that
show me
is it
your
fine?
slides. No, we are not able to see your screen. I mean, your
Okay.
slides.
Can you
Yeah,
see it
there
now?
you will find on the top, you will find full screen. Yes, perfect.
Okay.
Use
All
the
right.
arrow buttons now, okay?
Okay, it's good. Okay. Yeah, so sorry for that short disruption. So this presentation, it reviews their challenges, the transmission methods, and the effective prevention strategies. And then we would have to also, I would guide you to understand these viruses, that they are crucial to mitigating their effect on vulnerable population. There are some persons that are vulnerable to this particular viral infection. For example, the children, and of course the elderly, and the immunocompromised, those that are not immunocompetent, those that perhaps have any kind of underlying issues, it leads to this infection. And I would like to also note that noroviruses, you just need a very little dose of that virus to have the impact of the gastroenteritis that could come with it. For example, those that are in the biomedical science, you know that, for example, Vibrio cholerae that causes cholera in, of course, adults and even in children, you need a very high dose. There's what we call the infectious dose. You need about 1 billion virions of virion particles of cholera, cholera vibrae cholera rather, before you can do what? Before you can fall into having that disease or that infection. But noroviruses, you just need a little dose of it. Just a few of those particles could lead to a disease condition, and that is why it's a pressing public health issue. Now, understanding noroviruses. Now, I'm going to be speaking more on noroviruses because it caught my attention, and I would like to also progress in my postgraduate studies, studying this particular virus. It's a single DNA, RNA virus. And why am I very interested in norovirus? It is because I term it to be a stubborn virus, right? Yeah, I term it to be a stubborn virus because over the years, a lot of research has gone into this particular virus to ensure that it's been culturable through, cell tissue and the likes. But unfortunately, a lot of scientists all over the globe have found it very difficult to have this virus cultured. And for you to understand the pathogenesis of viral infections, of course, you would need to at least have an animal model in which you can study and see how they, affect the immune system. Norovirus has been a terrible one at that. But for, of course, for rotavirus that I've also worked on, was opportune to carry out a research to join one of our researchers in Nigeria to do a research on a kind of nanotechnology diagnostic tool for rotavirus. And currently, as we speak, rotavirus has a vaccine, a valid and an effective vaccine that helps to negate its negative impact on public health. But we are yet to get a norovirus vaccine because, of course, there are a lot of what do I call it now? Clinical trials that are going on. The Ilvas, Moderna, also they have an mRNA vaccine that they are working on, but currently it's still not fit for human use. It spreads rapidly through contaminated food, water, and surfaces. Its resilience against disinfectants poses a challenge for public health interventions, making knowledge of its characteristics important, very, very important. The way, in fact, I wish I would be able to, talk about the epidemiology. Of course, I'll try to do that, and the pathogenesis of how this particular virus negates the immune system. It's a STAT1 dependent immune virus, and it ensures that it passes through all of those defense line that has been put in by our white blood cells and of course other immune cells that are there to defend us. Understanding rotavirus primarily, it affects infants and young children. That's the target population, of course, and it causes severe diarrhea. Vaccination, like I said earlier, rotavirus has a vaccine, an approved WHO vaccine that has proven to be effective. Of course, a lot of research are still going on to ensure that we get a better therapeutics, of course, and of course, maybe a better vaccine for this virus. But so far and so good, as much as I know for now, there is an effective vaccine for rotavirus. Vaccination has significantly reduced its prevalence, yet outbreaks still occur. Yes, very correct. And particularly in low-income region, understanding its impact helps in formulating effective health policies. And that was the reason for the research that I participated in, where we were able to come up with a diagnostic tool, a rapid nanotechnology diagnostic tool to ensure that we don't have to do the so-called PCR and the so-called ELISA tests to be able to detect, rotaviral infection amongst children, because we are talking about a population of children between the ages of 0 to 5. We're talking about a population that can go down, with any form of severe gastroenteritis if there's no rapid, diagnosis of that particular infection. And secondly, the transmission dynamics of norovirus and rotavirus, they are similar in transmission. They are being transmitted similarly via the fecal oral route. Contaminated food surfaces and person-to-person contact contribute to outbreaks. Recognizing these transmission dynamics is vital for developing effective prevention strategies. I would like to also bring to your notice that during the COVID-19 pandemic, the norovirus infection, according to research, was recorded to, go back to its pre-pandemic state, meaning that it was drastically reduced. But after the COVID-19 bans were lifted, we saw that the infection began to rise. The incidence and of course the prevalence of the infection was on a rise. That is to show that if we can keep to some of these principles, if we can understand the transmission dynamics, it will go a long way to help global health as pertaining to the negative impact that these viruses also causes. Public health challenges. I would like to bring to our notice very importantly that according to research, the effect of these enteric viruses, when we talk about enteric viruses, like I said before, now we're talking about noroviruses, we're talking about rotaviruses, of course, we're talking about astroviruses, of course. There are so many of them like that, but we are focusing on these two subjects today. Now, when we talk about the public health challenges, it is being recorded, and according to research, globally, there's an annual, 60 billion naira, sorry, I said naira, US dollars, that goes into this particular infection. They lead to about $60 billion loss in global wealth as touching the effect of this infection, and that is why it is of great global challenge. It's a great global challenge, and it's our aim, as upcoming virologists, to navigate and find a way to provide solution to this challenge. And like I said earlier, the infectious dose, it leads to rapid transmission. The infectious dose of norovirus is so little. It doesn't need a lot of particles. It doesn't need a lot of viral particles or virons to lead to a disease condition. A little there could actually bring down, the immunocompromised, the elderly, and of course the children. I want you to take note of that as well. The high morbidity rate, of course, and strain variation. Now, noroviruses has a lot of genogroups, it has a lot of genotypes, but currently we just have about 3 genotypes that are prevalent among humans. Among the genogroup 2, we have the genotype 2, the genotype 4, and then the genotype 6. Those 3 genotypes in the genogroup 2 of the noroviruses, they are the ones that lead to disease condition, and they are the ones that lead to the infections that we are suffering today for those that have contact and with that particular viral particle. And these factors, they complicate outbreak management and necessitate coordinated responses from public health authority, according to Carlson et al. 24. So, what are the symptoms and diagnosis of these particular enteric viruses? Symptoms of noroviruses and rotavirus include vomiting, very, very important, diarrhea, and abdominal pain. Diagnosis typically involves clinical evaluation of laboratory testing. Early detection is crucial for effective management and containment of outbreak. Very, very important. In some developing countries like Nigeria, you see that it's perhaps will be difficult for someone that just started having a kind of vomiting. Perhaps what they do is they go for rehydration. We go get this rehydrating salt, and then there's a way we mix it up, and then you see people drinking it just to make sure that it's there's a balance of the salts in the body to ensure that that person does not get dehydrated. And that was what was the basis of the research that I was talking about. We're able to develop a diagnostic tool, a nanotechnology diagnostic tool that you can test rotaviral infection almost immediately. You don't need to wait for any kind of, you don't need to wash the ELISA plate, you don't need to carry out a sequential PCR test to ensure that you get to know that these infections are what are caused by these enteric viruses. Why is that very important? It is important because the rate at which, how fast you detect this viral infection, it goes a long way to preserve the life of those that are infected. Because those that usually go down with severe gastroenteritis, what happens is this: when it gets into the body, it gets them dehydrated, and then due to some kinds of complication, for example, it's been recorded according to research that in low-income country, basically the children are the ones affected by this viral infection. But in developed nations, in developed countries, we have the elderly being the one that goes down for this severe gastroenteritis. And why does it happen like that? It happens because some of our elderly ones are being challenged with some underlying illnesses, perhaps someone that has sepsis, someone that has a kind of abdominal discomfort. It could help to aggravate the effect of this particular of this particular virus. And that is why it's very important that more research are being done. I know there are global leaders in this meeting, there are global leaders currently in this call. Let's see how we can push ahead to see that we bring about getting a vaccine and a faster diagnostic tool for these particular viruses. Now, I would like to talk on the impact of the on vulnerable populations. I've tried to explain this even before now, but I'll just read through my slide. Children and the elderly and the immunocompromised individuals are at higher risks for severe illnesses from this virus. I would like to state very categorically this morning, maybe this afternoon in your place or this evening, that this virus they are self-limiting. What do I mean by that? It means that when they come into someone that is immunocompetent. For example, myself, when I get infected with this virus, provided that I am immunocompetent, I believe I am, yeah. So, provided that I'm immunocompetent by the grace of God, I am not really going to perhaps show forth some of these symptoms. I wouldn't develop a severe, there's what we call the severe gastroenteritis. The severe gastroenteritis, I might not necessarily come down with the one that will lead to my total dehydration or perhaps death. Yes, they cause death. Acute gastroenteritis, according to research, causes about approximately 1.5 million deaths per year annually globally. 1.5 million people are reported to die as a result of this infection, and according to research, about 250,000 to about 280,000 of that death is being caused by norovirus. Yes, caused by norovirus. And when I talk about gastroenteritis, remember, I'm not only talking from the view of a virologist. I am not only talking about viral gastroenteritis. We're talking about a bacteria, of course, could lead to gastroenteritis, and some other factors could, lead to this disease condition. So understanding their vulnerability is essential for target public health intervention. If we understand that the vulnerable are the children, the elderly, and those that are immunocompromised, having underlying issues, it will help in public health intervention and resource allocation. According to research, the elderly, of course, are more prone to severe cases in developed nations, like I've said earlier, while children often go down with severe cases in developing or underdeveloped or low income nation. Prevention strategies. Effective prevention strategies for norovirus and rotavirus include hand hygiene, safe food handling, and vaccination for rotavirus. Take note of that. Of course, hand hygiene is important for all enteric viruses. Safe food handling is important for all enteric viruses. But when we talk about vaccination, we exclude norovirus because currently research is still going on for us to get an effective vaccine. And it's also my goal and part of my career aim to be part of that research. I've taken deep interest in studying the biology of noroviruses, and I am sure that when we work and when we put the work into place in the lab, we'll be able to come with a positive result for this to help improve public health. And of course, public awareness campaign plays a crucial role in educating communities about these preventive measures. Of course, efforts should be put into making sure that we share. Of course, we are global health leaders, and of course, we are here because we want to see an improved global health. We want to see people especially preventive diseases not coming to play because people are aware. There's a saying that knowledge is power. We want to empower people as well in our community and of course in our social media handles to ensure that we spread this news to improve the life of people. The role of vaccination against rotavirus has proven effective in reducing hospitalization rates, of course, but currently in some developing countries like Nigeria, not every child have access to the rotavirus, vaccine. So you see a lot of people going down. You see a lot of children being infected with this particular virus, and some eventually lose their lives as a result of this virus. So that's why we're working hard as well to ensure that developing countries and low income countries have access. Yes, they should have access to these vaccines so that it will help improve the health and living standards of the vulnerable population in these countries. Understanding the roles of vaccine is crucial for improving public health outcomes. Various clinical trials, like I've said earlier, are underway by ILVAX and Moderna. Moderna, they're currently working and they're doing a kind of a mRNA vaccine. They are doing some kind of clinical trials in the UK, trying to make sure that they put in some things together. And we are hopeful that would definitely get a positive feedback from their clinical trials. So outbreak management. Effective outbreak management requires surveillance, rapid response, and community engagement. Collaboration among health agencies, of course, schools, and local organizations is essential to control the spread of these enteric viruses. Generally, in the field of biomedical sciences, you would notice that it's very important that if you want to maintain public health, a lot of surveillance goes into play. You put in a lot of rapid response, and of course, you engage the community that are prone to these infections. So, my future research directions, according to the current trends in the field of enteric viruses, now to be specific, noroviruses, future research should focus on developing norovirus vaccine. Yes, I'm aware, like I've said earlier, there are a number of those vaccines that are being worked upon, but there's still some research. I was reading through a research uh, Cast et al. 2024, and we saw that the immunological effect of this virus is now, is in the opposite angle, because normally that when you give birth to a child, there's what we call the immunological benefit of breastfeeding. You are supposed to perhaps breastfeed the child to ensure that he or she gets a kind of a level of immunity, because when you breastfeed a child, there are some kinds of uh, antibodies that comes through from the maternal body, and it gets into the child, the sucking baby, and it goes a long way to prepare their immune system for this viral infection. While I was reading a research by some scientists at the University of Florida, I saw that what happened was that the breastfeed that comes from the maternal body was enhancing the what the norovirus infection. It was making sure that the norovirus had more adverse effects on the young ones. It was a sample. It was a research, a huge research, and what I wanted to look at was that, okay, what are those factors, immunological factors, that affect or improve the disease condition of this virus? And then notice that those mouse, of course, they made use of mouse. Those mouse are actually ensure that they kind of allowed some of the antibodies from the mother get into the young mouse. We noticed that eventually those things led to what? It led to an improved disease condition for this virus, and that is why I call norovirus a stubborn virus. And I am sure that with much research we are going to get to the end of this, and when an effective vaccine is being approved and tested, I am sure that it will go a long way to release and reduce the disease burden in the nation. So, in conclusion, I'd like to say that norovirus and rotavirus pose significant challenge to public health. Understanding their transmission, their impact, and their prevention strategies is essential for reducing their burden. Collaborative efforts, you cannot do it all by yourself. The healthcare professional, the scientists, the researchers cannot do it all by themselves. It has to be a kind of collaborative effort, and ongoing research are vital for the future advancement of these infections. So, thank you so much for your time. If you have any questions, I am very much available. to answer your questions, and perhaps you have any questions you'd like to email me as well, and I will be very much happy to attend to any of those questions. I remain Treasure Adama, the young upcoming molecular virologist. Thank you.
Are there any questions? Thank you very much for a great presentation, Dr. Adama.
Thank you.
Yeah. Professor Laura, are you there?
Yes, I'm here.
Yeah. Our next speaker is Dr. Laura Ayan. Dr. Laura Ayan holds a PhD in psychology at Salinas University of Sciences and Literature in Italy. She is an associate member within the American Psychological Association, a graduate member within the British Psychological Society, and a certified NLP trainer being trained by Dr. Richard Bandler, the co-creator of NLP and his team. Laura has a strong publication record, contributing articles to reputable journals such as Scientific Research Psychology Journal, Journal of Communication and Behavioral Sciences, and Sarah's blog, School of Advanced Studies, Research and Accreditation, Spain. Furthermore, she has actively participated in various psychology and neuroscience conferences, where she has been honored with invitation to serve as a keynote speaker. Join me in welcoming our speaker, Dr. Laura Ayan.
Okay, thank you very much for your introduction. I'm very pleased to be with all you today here, and I have heard so many great presentations so far. So I'm going to share my presentation with you. Okay, just hold on for a second. Okay. Okay, let me, okay, can you see my presentation?
Yes, we can see. Could you please click on the slideshow option?
Yes, I did so. Slideshow.
On the footer, you will find comments, okay?
Yeah. Yeah, just hold on for a second.
Yeah.
More. I don't see it.
Yeah, I will let you know. On footer, you will find comments, okay? 97% the zooming level. At there, you will find the slideshow option, okay? Please move your cursor. I will let you know.
Okay.
Yeah, move the cursor down.
It's like layout and options.
It's besides the comments. The fourth one. After comments, the fourth one, stand, you will find.
I don't see comments. So okay, share, react. Okay, but I don't see comments. Oh. I don't know what's going on. You're sharing now. It says I'm sharing it now.
Yeah.
Okay. Let me see again. Stop sharing. Again, share. Okay. Okay. Now it's okay with you?
Yeah, it's okay.
Okay.
Slideshow option, it will be better, I think so. So that everyone can see. Yeah, down. Yeah. Yeah,
Okay.
next one. Next.
Next one. Okay.
Next.
Next one.
Next.
Okay.
Next. Yeah, that's all. Perfect. Okay.
Okay.
On the arrow buttons, okay? It will move.
Okay. So, my presentation today is about the role of neurolinguistic programming techniques in changing underlying patterns that create destructive thoughts that lead to negative behavior in borderline personality disorder. The content of my presentation is about abstract background, research questions, and hypothesis methods, results, discussions, and of course, resources. So, neurolinguistic programming in the field of neuroscience, psychology, and psychotherapy is a topic of much debate for the time being, and I think it will be in the near future as well. The purpose of this present study was to examine the effectiveness of neurolinguistic programming, challenging and changing the destructive thoughts that lead to negative behavior, mood swings, anger, impulsiveness, and instability in borderline personality disorder. According to National Institute of Mental Health, borderline personality disorder is considered to be a mental health condition that affects mainly the way people think and feel about themselves and others, making daily life routines extremely challenging. This includes patterns of unstable, intense relationships, as well as impulsiveness and an unhealthy way of thinking and perceiving themselves. Impulsiveness specifically involves having extreme emotions and acting without seeming to think about them first. Destructive and distorted thoughts are at the base of the extreme feelings and impulsiveness, instability, and swinging decision taken within minutes, being a consequence of these disruptive patterns of thinking. Neurolinguistic programming essentially is focused on how we filter, how we perceive, acknowledge, and give meaning to the inner and outer world, and the way that different conscious or unconscious bias, patterns, limitations, and principles influence our outcomes. The main theory behind neurolinguistic programming is that the moment we become aware of our cognitive and sensorial filters and biases, we can begin to make choices, obviously in a conscious way, that resulting in positive changes. As borderline personality disorder is dealing with distortions, among others, deletions and generalizations leading to disruptive and destructive patterns of thinking that, of course, lead to specific emotions and feelings, these leading to certain type of impulsive and unstable behaviors. As neurolinguistic programming has specific models, such as meta-model and reframing, and tools to challenge mind's limitations, distortions, deletions, and generalizations very common in borderline personality disorder patterns of thinking, it is the most appropriate psychotherapeutic intervention. Critical appraisal of evidence-based research in this particular type of personality disorder to indicate the benefits of neurolinguistic programming in treating borderline personality disorder is highly needed, along with increasing randomized controlled clinical trials. And the moment the effectiveness of it is demonstrated, the necessity for neurolinguistic programming to be admitted worldwide as a top form of psychotherapy, on target and lucrative intervention is a must. Background. Well, in the 1980, borderline personality disorder was introduced first in DSM-3, the mental
the Manual for Mental Disorders, based on a study of Spitzer and Hall, who drew both on research by Gunderson and colleagues and on Kernberg concept of borderline personality, by including the main and specific problems of identity and interpersonal relationships, characterized by sudden shifts and swing from one extreme to another. In DSM-5, a main diagnostic criteria for borderline personality is a pattern of unstable and intense interpersonal relationship, characterized by altering between extremes of idealization and de-evaluation. Borderline personality disorder remains a challenging disorder from both perspectives, mainly to find the most suitable therapeutic approach that could lead to best expected results. At present, there is still controversy concerning its conceptualization as either a personality disorder or a level of general impairment in personality functioning, with a keen focus on the ability to mismatching and swinging in extremis between concepts, ideas, and beliefs. According to the UK National Institute for Mental Health and Care Excellence, psychotherapy is the treatment of choice for borderline personality disorder. However, almost 50% of borderline personality disorder patients do not respond sufficiently to common psychotherapies, so that further research in this area is clearly warranted, NLP being the top 3 methodologies to be assessed. On short, I will describe for you the main symptoms of borderline personality disorder and the 4 types of borderline personality disorder, so as to understand better what we are dealing with and why NLP might be the best approach ever. When it comes about the most common symptoms of borderline personality disorder, I will start with the fear of being alone. Then we talk about aggressive behavior, self-harming, suicidal thoughts, paranoid thoughts, severe mood swings, social anxiety, and difficulty in maintaining relationships with people. The 4 types of borderline personality disorders are like quiet borderline personality disorder. And why is it called quiet? Because people are really quiet in expressing their feelings and their thoughts, comparative, for example, with impulsive borderline personality disorder. They are afraid of being abandoned. They keep emotions inside and blame themselves rather than others. They feel guilty for, I don't know, for example, their parents staying at home with them and not going to work. They feel guilty for not fulfilling different kind of tasks like going to school or doing homework, and they keep everything inside them. On the other side, impulsive borderline personality disorder tend to be distracted and hyperactive. They have like chaotic emotions and behaviors, and they tend to have risky behaviors that can harm selves or others. Self-destructive borderline personality disorder is one of the worst, as it shows masochistic traits, direct feelings inward, which can lead to harmful and abusive behaviors, often moody and suicidal. This kind of people tend to do harm to themselves in order to, I don't know, to deal with life and to deal with everything that happens around them. If they feel anger, they might harm themselves. If they feel inappropriate in a context, they might harm themselves. If they feel like not accepted in a group, they tend to say about themselves that they are not good enough for that group, and they might go home and harm themselves as well. The tolerant borderline, it's about having unpredictable mood swings and the passive aggressive personality style. They need to feel in control. These type of borderline personality disorder patients are those swinging between one decision and another in extremis. For example, a teenager with borderline personality disorder might want for the time being to go to a party, and within seconds saying no, and he or she is keeping like the entire family at home because he or she doesn't want to go for that party without having a specific reason for not doing this, at first sight at least. Research questions and hypotheses. If key meta programs or strategy variables in a person being diagnosed with borderline personality are at the base of all person decisions and actions, and meta programs are deeply assessed by neurolinguistic programming, and we'll see later on what are meta programs in the field of neurolinguistic programming, being one of the most important aspects or tools of it. What stops organizations and institutes around the world in charge with mental health to acknowledge and accept that changing meta programs is one big important aspect that could lead to long-lasting changes in borderline personality disorder in person's life if addressed properly through NLP. In NLP terms, the main characteristic of the person who gets to be diagnosed with borderline personality disorder is a severe sequential incongruity, both at emotional and rational level, mismatching and wrong meta programs leading to severe manifestation. In external relationships, for example, this is expressed in swings from idolizing another person and wanting to be with them, for example, to despising them and wanting to escape or run away from them. This pair of in extremis mismatching, addressed properly using meta model, for example, could lead to acknowledging the rational violations present in their minds, and this is the first step taken to success. In the person's relationships with themselves, on the other side, is this expressed in swings from arrogant self-promotion to self-hatred and even disgust. Cognitively speaking, this means constant polarity responses without any cognitive filters present to detect and change distortions, deletions, and generalizations. And meta model of NLP, again, could make a huge difference. Well, methods and the results of the systematic literature review, you can say later on. It's not very important for the present presentation, but it's in here so as to understand the resources I've used for my work. Results. Neurolinguistic programming is considered among many countries around the world as a therapeutic technique used to detect mind distortions, limitations, generalizations, and deletion, and reprogram unconscious patterns of thoughts and behavior in order to alter psychological responses. The co-creators of NLP have proved that there is a connection between the neurological process, language, and behavior patterns learned through experience. And once the mind was capable to program itself for destruction, it means it is capable as well to program itself for construction and success. Changing meta programs and creating rapport in borderline personality disorder is extremely important. As I said when I was talking about background of my research, meta programs are extremely important in borderline personality disorder, being at the base of the behaviors a person with this kind of disorder is having. Meta-programming, neurolinguistic programming are programs which guide and direct other thought processes within human mind. Specifically, they define common or typical patterns in the strategies of thinking styles of an individual. The moment you change a meta program, you change the entire program defined for the specific action, and you can literally shift from running away from others, for example, to running towards others with benefits of NLP report, on the other hand, again in borderline personality disorder, it is a sense of connection, acceptance, and openness between people, allowing communication to happen for change in the benefit of the client. Rapport helps us to lead, helps us to learn, and to creating an accepting environment for others. Reframing in borderline personality disorder, as reframing is a very important tool in neurolinguistic programming. Content reframing is the process of using visualization exercise to reframe how we see a situation in which we felt victimized or powerless, inadequate, or disappointed to others. Instead of letting our perspective of a situation flood us with feelings of hopelessness and despair, we begin to look at it with a positive outlook. The entire process is happening at the conscious level, and the key to success is to saturate the brain with the new image created up to the level of deep submodalities. To stop swinging from arrogant self-promotion to self-hatred and even disgust, for example, one important step to be taken is to reframe based on logic and reasons the contradictions and the violations of self-logic and reason. I am great, for example, and within minutes the person moves to I am a disaster, I hate myself. Reframing may sound like I think I am great, then I must have some evidence here, but sometimes I do things not at my best. What are the evidence that requires improvement? Instead of I am a disaster. If moving or swinging from I'm great and later on I'm a disaster produce nothing. I mean, it doesn't move people from hesitating to action, from failure to success. On the other hand, reframing gets the person into the reality, helping him or her grounded about what's happening around. Like, I think I am great, and I bring some evidence for this, and I'm able to talk about what are the reasons I'm saying that I'm great. And then, but sometimes I do things not at my best, or I do wrong. I do bad things or in a wrong way, and I'm bringing up the evidence for this. I'm able to work, constantly and in a concrete way to everything that I have to settle down and improve so as to feel better about myself. Meta model in borderline personality disorder. Very important key component of neurolinguistic programming. And it has, of course, key components as well, like distortion. Distortion in meta model is about identifying and challenging statements that seem to alter reality. On a daily basis, human mind is working with distortions, deletions, and generalizations. And these are like normal processes, but sometimes this kind of processes stop us from achieving success, stop us from going from hesitation to action, from moving from point A where we are blocked, and limited to point B where we can see many other opportunities. So here is meta model coming, helping people to challenge these distortions, deletions, and generalizations, and breaking down, for example, universal quantifiers, so as to bring up precious information at the surface and work with it in our benefit, of course. Example.
Ai pus tot ce
If
ai găsit
someone
pe
says,
foița de aur, pune și foița de aur în pachet. Nu pune niciun fel de sticlă, că am sticlele cu pictură acolo. Doar pune pensulele, iarăși pune-le într-o pungă și pune-le.
Sorry, I don't know what's happening.
Dr. Lara, 1 minute, please.
Nu uita pachetul de afară din casă. Bun. Te sărut cu drag și te iubesc foarte mult. Drum bun, drum bun. Mai trimit o dată pe mesaj adresa ca să nu fie niciun fel de dublu. Da? Okay. Mulțumesc, domnule. Din tot sufletul. Și vedeți pachetul de afară, pachetul ăla de afară.
I don't know what's happening. I think someone left the audio.
Yeah, 1 minute, please. 1 minute.
Da? Ați văzut pachetul de afară, dintre etaje. Bine, deci faceți 2 pachete și are scoci ca să lipiți cu bandă de scoci adresa și numele Dana York și telefonul are mama, da? Mai trimit o dată toate datele pe text. Mulțumesc mult!
Astea ajung direct acasă?
Bagajul pleacă singur cu...
Okay.
Sorry for the interruption, Dr. Lara.
Okay, no problem. I will go on.
Presentation.
So, example, if someone says, I'm not good enough, I disappoint people, an NLP therapist might ask, how do you know you're not good enough? What is the evidence? What part of what you are doing you consider you're not good enough? To uncover the process behind this feeling. Generalization is about addressing statements that apply specific experiences broadly. Example, people always treat me bad. Can be challenged by asking, can you think of a time when people treated you good? Break down the what do you mean by treating you bad? Who are people? The moment we bring up this information at the surface, we can work with it and somehow, it's not about demonstrating, but somehow supporting the people suffering from borderline personality disorder to understand that they are in a wrong place. They are having some limitations. They are having bad thoughts. They are having unrealistic thoughts or dialogues in their head. Deletion is about filling in missing information in communication. I always feel bad when I fail going to school. Might be an expression said by someone suffering from borderline personality disorder, and can be specified by asking what specifically makes you feel bad. What is the meaning you give to I fail going to school? Like putting the equal sign between I fail going to school means what or equals what? Meta-model in borderline personality disorder. Meta-model is a comprehensive framework consisting of specific questions designed to uncover and clarify the details of a person's language. So the moment we challenge deletions, we recover, the missed information. The moment we challenge distortion, we correct the information. And the moment we challenge generalizations, we challenge the quantifier, the universal quantifier, like always, never, and people usually talk with universal quantifier. You never supported me. You always prove to me that I'm wrong, which is not true if we look for specific times when I proved you controversy, Meta-communication describes the subtlety of language, underlying requests, or guaranteed information or precious details like those hidden in misconceptions and destructive meta programs that as soon as they are recovered due to meta model of NLP, the key to therapeutic intervention is assured. Discussions. NLP techniques such as changing meta programs, meta model, building rapport, timeline therapy sometimes, and reframing to challenge their limitation and swings from one mood to another, from one idea to another in extremis must be assessed. Critical thinking was improved by so many studies in other areas, mind health and education, due to meta model of NLP. It is becoming increasingly difficult to ignore neurolinguistic programming. The most crucial role of NLP is to help humans better communicate with themselves and control negative emotions, depression and anxiety, comorbidities encountered in borderline personality disorder. NLP is considered an assistive technology that can help people after experiencing instability and impulsiveness or dealing with swinging behaviors in extremis within minutes to develop outstanding skills such as critical thinking, emotional intelligence, self-efficacy, and empathy to challenge and change misbeliefs, limitations, and blockages. These skills are necessary for understanding what they experience and changing and challenge all the limitations, preconceptions, and other limitative beliefs, along with the meaning they gave to different internal and external events, with a keen focus over mismatching concepts. The purpose is to gain self-conscious knowledge so as to lead to self-conscious control of their own mind in dealing with borderline personality disorder. The next slides are about resources I have used for my presentation, and I will close that with a big thank you to all of you listening to me. Thank you.
Are there any questions? Thank you very much for a great presentation, Dr. Laura.
Okay, thank you as well. Have a great day.
Yeah. Yeah, our next speaker is Professor Dana York. Professor Dana York is an expert in the field of research in lasers for biomodulation. Her academic background includes a degree in education from the Academy of Distinguished Educators in Clinical Teaching, New York University, PhD in laser therapy and MSc in biophysics and cellular technology, University Karol Davila Bucharest. Professor York has served on the board of directors of the International Phototherapy Association of Japan. She has conducted clinical trials for photobiomodulation techniques with different technologies and has published this research in peer-reviewed journals as well as presented at international conferences. She was awarded the prize for Best Research Paper at the Florence Laser Conference in 2002, as well as the International Academy of Laser Medicine and Surgery and Bone Regeneration in 2015. Professor York has recently joined the study group for artificial intelligence within the new European Surgery Academy. She sits as a delegate for the Universal Healthcare at the United Nations and is a fellow of the UK Royal Society of Medicine. Her first degree is as a doctor in dental surgery, followed by periodontology. Dana is also a philanthropist. Her work brings her to Africa to help the cause of the children victims of gender-based violence. Please join me in welcoming our speaker, Professor Dana York.
Hi, Mr. Quara. Thank you for your kind introduction. I hope you hear me well. And I'm going to start the lecture. Our lecture is, can you hear me well?
Yeah, there is a somewhat disturbance from your end, Professor Dana.
Yes, I put it as maximum as possible. And I'm going to start my lecture.
Yeah, okay.
It's okay?
Yeah, it's okay.
Okay. So I'm going to tell you now all about our passion European Medical Laser Association has been there since 1983, and everybody from the conference is going to become honorary member for free membership. Now, because I moved to New York from Europe, I started to teach at New York University. So I want to invite you all to this course for photobiomodulation regeneration that it is in March 2025. I hope you can come. You get a certificate from New York University and get to meet lots of friends, and also you get one laser with you. Now, these are the pioneers of lasers in medicine, laser photobiomodulation. This skinny girl here is me long time ago. Please go to emla.info to see the articles, all the knowledge we put in, everything we plan to do, and so on. What is this cold laser? Cold laser means the invisible light that you put it on the body, and with that invisible light you cause this regeneration, photobiomodulation, anti-inflammatory effect. How did that happen? First thing, Professor Einstein proposed the phenomenon of stimulation emission of irradiation. This is his grave. But 40 years after his death, this nice man, Theodor Maymin, put together from Einstein calculation the first laser. And then, only 2 years after, in 1962, Professor Isaac Kaplan decided to do what it is, a phenomenon of a laser used in medicine. Isaac Kaplan in South Africa found the laser in industry and went and put it into the oral maxillofacial surgery, first on few dogs and immediately in oral maxillofacial surgery, and he became the father of laser in medicine. You see this dark-haired lady here, that's me. I asked him for a life advice, and he said, take good care of yourself. And it's true, because if you take good care of yourself, then you can take good care of the others and so on. But 5 years later, after the explosion of popularity of laser, Professor Menster said, this laser causes cancer and I'm going to prove it. So what he did a program in which he did a public double-blind test in which there were two groups of mice. One group was the group with laser irradiation. The other group was the group with no laser irradiation. And then he found out that the laser-treated patients, the mice, they had better biological blood tests, they had better hair growth, and he didn't know what he found because he wasn't a scientist. But finally, he found in the benefit of photobiomodulation, and he spent his life to prove it. Is the laser horrible and scary? No. Laser is used in entire hospital, in the biomodulation, in the laser therapy, in the LLLT, in the cold laser therapy, in the soft laser therapy. All these in nomenclature are names used, but for the same method. These are different types of machines. They have, even now, they have a gynecologist magic wand that is given to the patient at home to use for regeneration for gynecological problems. One advice, don't get your education from the detail man. Who's the detail man? Is the representative from a medical company? No, you must think and you must study. Is the laser bad? Should we say, oh, are you crazy? Put that thing away from us. No, laser is wonderful and I will show you why. So let's see technical parts. Ordinary light is chaotic. Laser monochromic light is coherent, and LED is monochromatic but non-coherent. What does that mean, coherent? Is one light like a line and is from the same direction. LED is monochromatic and goes in all the directions possible. So, what are the clinical effects? Anti-inflammatory, tissue repair, analgesia, bone recovery. In the spectrum of light, the laser that we use are at 700 nanometers. What is the nanometer? Is the calculation of the particle of light. This is visible light that we see. You see those lasers where you have blue light, red light, or is invisible light where is near infrared. Now you see, when we go to the beach, why we go? To get the vitamin D, to get the sun. Same is the laser, concentration in a little device, exactly the nanometer, the wavelength, that we know that is effective to give this regeneration. I see here Professor Ras. Hello, Professor Ras. And I see Dr. Laura Yuon. Hello, and greetings from Cannes. I see as well wonderful doctors that I'm so glad to know, and I hope we will have mutual collaboration for the rest of our lives. Now, depending on the laser, we have different types of penetration. So if you see, the infrared light goes to 600 to 800 nanometers. What does that mean? That means that you put the light here and it have action 6 centimeters into the head, or 8 centimeters all the way to the heart, all on the spine. For that, laser is non-invasive. It makes this therapy non-invasive. Also, in the spectrum of light, we see the absorption of blood, light in the blood and light in the water. So we have 830 nanometer and we have 630 nanometer. And then we have the effects. Let me explain you what is the effect. Primary effect goes inside the nucleus of the cell into the oxygen. Secondary effect is signal of calcium, potassium, secret growth factor, enzymes. Tertiary effect goes to the nerve conduction, serotonin, natrium and potassium pump, calcium pump via nerve and conductory, and then protein C reactive from anti-inflammatory effect is activated. For that reason, we have pain relief. Pain relief. Then on the other effect, we have effect on the soldiers of the body. which are the soldiers of the body, interleukin and tumor necrosis factor that resolve inflammation. On the other side, it makes an effect on tissue repair and nerve regeneration, and that is just wonderful. Those are 4 major effects of photobiomodulation laser therapy: pain relief, anti-inflammatory, tissue repair, and nerve regeneration. For that, imagine when you have Alzheimer patient or when we have cartilage. For that reason, FDA approved it in 2002. So now we are 22 years after, and it's still a novelty. If you tell me how many of you knew already about photobiomodulation, I tell you, Dr. Ras and Kiran, they know because they heard me before. My dream is to have a laser unit on the size of a lipstick in every single pocket, in every single purse, in the pocket of every man and every woman, because this will be replacing a full jar of pills. In the 80s, this lady, Tina Karu, said the dose response, and she scientifically proved in her book how the cell activation, cell inflammation. So for that, we have the immediate effect, anti-inflammatory, and the long-term effect. And if we use the laser in pulse, it causes anti-inflammatory regeneration. If we use in continue, cause anti-inflammatory. Now I'm going to show you my lifetime work about periodontal bone regeneration. And I'm going to talk to you about artificial intelligence. This is a book that we wrote in 2005. This is Laser Florence, where you should come on November 2025. I'm going to show you a clinical study that we did. We enroll 110 patients. 55 patients, they received laser, 55 didn't. Then we separate the patients in young ones and more mature ones. Then all of patients, they had in common that had periodontal disease or third degree. There are 4 degrees of periodontal disease. These, they were second, third degree. And what did we do? We studied 6 parameters. Improvement of bone regeneration, the most important that we search. Reduction of inflammation, hemostasis, pain relief, low recurrency, and reduction of usage of antibiotics and other problems. This is our patient, Maria. So then we separate again the patients, healthy ones, patients with toxicity from kidney and liver, patients with diabetes, and patients with just calcium metabolism. So from that, what did we do? We do classical treatment exactly for everybody, local and general anti-inflammatory, state-of-the-art, whatever we had most, chlorhexidine, clinical treatments, a reduction of inflammation in general, brushing after every meal, using propolis and mouthwash, and periodontal and bone reduction. We did not provide surgery in any case. Then we proceeded, after we really clean, after we make sure the patients have beautiful parallel prosthetics in the mouth, so all the forces are parallel, and we did all the anti-inflammatory procedures possible, we started to do laser treatment. 0.5 joules at each interdental papilla, then we scan entire area on the outside. When we do a laser, think of acupuncture and Chinese medicine. Laser is as well like acupuncture, but no needles. So we did interdental space for 10 seconds and then outside scanning all the maxillaries, because our purpose was the maxillaries. As well as is a procedure for sinusitis. Frontal, maxillar, and the procedures for Alzheimer, the procedures for temporomandibular joint, the procedure for each tooth pain, the procedure after the extraction, the procedures for pain, if I have pain on the articulation, if I have pain in the finger. Photobiomodulation is very easy. Post-operatory protocol, we did 3 weeks, 3 times a week. And we asked the patient for maintaining oral hygiene and general nutrition for the rest of their life. We use this no GR frequency, which you don't hear about too much, with 2 frequencies. So it is found that this no GR, together with the light, they cause this biomodulation. Whoever says that it does with another kind of is at borderline. I don't really believe too much. So this is the arms that we use for interdental space, and then we use the scanning entire area with the laser. We have the patient using for gum, and then scanning the entire area, and then also we can apply directly to the tooth. This is before the surgery. We see the papilla inflammation, granulation tissue, and we see the surgical site after the surgery, after the treatment with the laser, how the inflammation went away. And first 3 days, each day, then 3 weeks, 3 times a week. In chronic cases, put longer dose. Repeat in the autumn, repeat in the spring. And in all cases, we found in the bone regeneration, we found in the benefit of the laser. Other blood tests, you also see that the blood is clean. And there it is. We measure everything, and we've evaluated those 7 parameters: gingival bleeding, pain relief, bone recovery, anti-inflammatory, use of other treatments or not, complete healing, and if we had any recurrence. These are all the numbers that we count. Bleeding parameters we found in all the cases in the benefit of the laser light. Then we have counted on all groups: diabetes, kidney and liver toxicity, osteoporosis, or healthy patients. In all the cases, mature or young patients, we found in the benefit of light. Please read for me the pain relief parameters. How do we do? I'm going to show you. So the pain relief, for the pain relief, we utilize the patient journal. The patient journal, what does that mean? The patient journal means that we ask the patient to keep count. How much is the pain? From 0 to 10. The patient says 7, 10, 20, da, da, da. For that, we did also look at the protein C-reactive, and we arrived to the calculation that the laser group benefits from the laser therapy. In all cases, in all the groups, diabetes, osteoporosis, kidney and liver toxicity, and healthy patients with iatrogenic problems. For pain relief, for bone recovery, the same. And for complete healing, we found an aesthetic scar and less possibility of recurrence. As well, for diabetes, we found that it's better for the patients to have good anti-inflammatory treatments. Because the diabetic patient doesn't feel the pain. So they get to have terrible consequences. But with the laser, they get good general outcome, because we have the local effect where we use it here, here, here. But also we have general effect always look at the patient at the local part and the general. The recurrence, we don't have recurrence, and we don't use as many anti-inflammatory, opioids or antibiotics. So the treatment became inexpensive. So we see in one of the clinical studies how the bone regeneration happened with the laser. What did we do in this case? We open the canal, we clean it, we put the laser in, and then we put the laser at the apex. And this is a young patient that you saw in the picture before. We found bone regeneration in 4 weeks. Then we take an X-ray again at 6 months, we take at 8 weeks. In all cases, we found in the benefit of laser therapy for the past 30 years of my knowledge, and as well at the blood tests. And the results of this study show that the subjects receiving laser got better treatment, better in all the parameters studied, and mastication and aesthetic function were restored. Photobiomodulation promoted regeneration of bone and recovery of tissue. I show you a little gallery of patients' work. Look at Maria. Thanks of our treatment, she managed to get a job and have her social life restored. There you go. This is a minor, very good outcome. And also because we restore the patient smile with confidence. Lazar got a second chance of life because of our treatments. That's his name. So in conclusion, no post-surgery complication, long-term effect, rapid anesthetic scar, healing. The results depends on the age and general health status, but in all cases we found in the benefit of the laser. The lasers are very inexpensive. The cheapest is $70, but remember, you must buy a laser, not an LED. So let's see the light. Our hope is that a laser is going to be in every pocket and every doctor will use it. Lots of journals were written all around the world, and NASA used it, American Army. This is a book that I wrote in 2005. This is, you see, European Medical Laser Association, that I'm the president, and on the right you see Santa Apollonia, which is the protector of the dentists, barbers, surgeons. That was the only one. This is a painting from 1700s, and I repeat it, so this is one of my paintings. When we look at the classification, you must know that we have 4 classifications, and our laser that we use for light is 3B. So whenever anybody says, I took the course, so our laser that we use is class 3B. And the wavelength is between 780 and 1,000. What is a wavelength? You know what is a wavelength? Is the the distance between electrons. So either we can put continue, or we can put wavelength like this. So the fight between electrons can be 780, can be 10,000, can be 12,000, and then is the power. If we put low power or if we put big power. Spectromagnetic of light we have from the X-ray all the way to microwave. And we are here in the diode, and we are here exactly at infrared. After 700 all the way to 1,000, and those are different types of lasers. And in the spectrum of light, you see this rainbow that you see when you use the hose to sprinkle the garden. The calculation of the dose, the calculation of the power, and this intensity of the dose curve stimulation, inhibition of the curve. Now you see the nomenclature and you see where this laser is used in entire medicine, in all the departments. And then a randomized placebo course of low-level laser therapy for the tendinitis with good benefits. We see the neck pain with good benefits. We see as well the laser therapy for third molar and endodontic. We see the use in all kinds of for temporomandibular joint. We see the use for ankle sprain. We see the use for chronic tendinopathy. We see the use against NSAIDs. What are NSAIDs? Ibuprofen, Tylenol, Advil, all those painkillers. So we can use the laser as a replacement of the pills. It's more effective, have lower cost, and have no side effects. Remember that NSAIDs is the biggest killer of tendon bone healing, is the 5th killer in America. And it is also a risk of heart failure and then erectile dysfunction. Collagen synthesis is better with laser. Postoperative pain is better managed with laser. Knee healing as well. Analgesia, neck pain, fracture union is better managed with the laser. So how does it work? The tissue is healed. Then we have the cell, mitochondria, electron transport, cytochrome oxidase, and energy into the nucleus. Mechanism, remember, tissue repair, anti-inflammatory, and pain relief. Tissue repair, inflammation, anesthesia. It's not about laser. It's about the reaction of the patient with the laser. There you go. And as well, what I want to show you is how the laser penetrates. Laser penetrates like this. You see how deep, and you have the target, but it penetrates in non-invasive way all the way inside the body. And that's wonderful to do a treatment at a distance. As well, you see, when you compare steroids with laser, is the scar formation. The collagen deposits is in the benefit of the laser. When we do treatment on the spine, this is a vertebrae. We found in the benefits of nerve conduction. For that, we have Professor Longo, who does these treatments on the spine for regeneration. From Professor, he does the treatment on the spine in a non-invasive way and causes this regeneration. For Alzheimer, for dementia, we use the laser, scan entire area of the brain, or now we have a helmet, and this causes this regeneration. For heart, after infarctus, after the myocardial infarctus, we put the laser on the heart, and when we look at the healing after infarctus, without laser and with the laser, we found in the benefit of the laser. So I'm very grateful. This is me. Write my email, write my mobile phone, and see the website of EMLA. And now I'm going to continue, if you let me. Again, I show you, this is our course. You must come to New York and participate to our course. Now, we will talk about COVID from these people that are part from the chorale, where my father was part as well. Misoti Synagogue, they came, and this is the director, they died because of COVID. And I really think this COVID is a biological weapon. This is in 2019. They didn't tell us that they do this in China already. So what did they try to make us believe? Oh, people will be in cage and animals are out, and this bat is the cause of all this spread. And then the perfume of 2020 became Clorox. And then look at the pandemic. I studied this biocellular technology, and they teach us that this pandemic is like a bell, like it's not something like this. And then Professor Nobel Prize winner, Professor Montagnier, he said, this is not a pandemic, this is a biological weapon. This is man-spread and man-made. And he died 6 months later at 80. So we see, when we look at COVID and we look at rubella, measles, mumps, they look the same. And then we see again, when we look at the vaccines and when we look at the COVID, we see that the children know COVID. Then from 20 years old and then the old people know COVID. Why? Because they got vaccinated with the ROR, with the MMR vaccine. If you know the vaccines, the mandatory vaccines, right, that we give to the children from 0 to 2 years old, we're supposed to give them to the very old. For that very, very old, because they go to hospital, they had less. But somehow now they say you have to vaccinate every 10 years, but we didn't. These are the standard vaccine given. Hold on. So you see, you have tuberculosis, dysphalia, coqueluche, hemophilia, hepatitis B, pneumococcus, meningococcus, papillomavirus, and Rugella aureus rubella. But who from all those viruses are corona? Only ROR, rubella. So then Professor Adams at Cambridge, he said, hey, look at that. I tested this COVID and this rubella, and it's the same. It's the same. They look at the RNA of this SARS-CoV and that, and they found 60% of the RNA identical. And they studied this and they published in beginning of 2020. The dentists in France, because they closed us the pandemic all this time, you know what they did? They did that. They made the protest, so everybody put themselves naked in the practice. And 187 dentists protested against lack of masks and goggles, and there you go. Was a wonderful. Also, we learned Corona Sutra that changed the life of the population, because they learned not to be close mouth to mouth. So please look at this educational poster of Corona Sutra. Means Kama Sutra for prevention for the COVID. This is an article that I wrote in April 2020 when I said that this MMR vaccine, you know, mandatory vaccine, and COVID MMR vaccine might help with the corona because it's from the same virus root from, if you look on ResearchGate, you will find that. And then Professor Chukwuka Nwemeka from National Institute of Health, then he moved now in Californian University as a dean, he discovered, and this is the article, that If we use laser on the bronchi, laser kills bacteria and is good against COVID. So now I'm going to talk to you about post-traumatic stress disorder. We have patients, we have family. I tell you the 6 steps. 1, remove the victim from the place of violence. 2, secure the belongings, the objects, secure the objects. Make sure the checks are not missing, everything secure, the home, because the victim of violence can become vulnerable for rape, vulnerable for theft, vulnerable for violence again. Then relocate the victim so it's doesn't have the the fate to be aggressed again. Then the victim must be surrounded by people that love the person, and very important, immediate boost of happiness, a moment of joy, a moment of dance and music and good surprises and light. That is the method. And the most important, no pills to put the patient on sleep. Also, surround you with people that love you and do something interesting until you forget what happened to you. That's right. No medication is needed. Recurrency of after post-traumatic stress disorder is capped, but the victim can be healed with complete restitution. Now, next subject, artificial intelligence. This is the first computer for artificial intelligence. And there it is, how it works. Repetition and roars, full of information, and all together it looks like artificial intelligence, but remember, you can always pull the plug. You can always pull the plug. What is the definition of artificial intelligence? It is a field of study of computer science, where the term may also refer as the intelligence of the machine. The names important are John Carty, Marvin Minsky, Alan Turing, but the most important, Alan Turing, because he did the first test. Alan Turing, what did he do? So the first test he did, he took a machine, he took a human, he tested them both for the same thing, and he found that the machine won. Then over the years, from the 50s all the way now, it was up and down, and now artificial intelligence is very important. So what are the two things? Machine can get language, can get computer, can get data. You can put in the machine everything. And dialogue and all that. What the human does, memory, perception, anticipation, problem solving, and decision. The research progress with all kinds of programs, and then we have AI chat. Then we have, from the artificial intelligence, we have the use in all domains like geoscience, life, medicine, chemistry, physics, materials, mathematics. So what it is a net of information, and then goes to be layers and layers and layers. It looks like it's thinking, but it's a program, and we can always pull the plug. Benefits for cybersecurity are very important: ongoing learning, recovering of threats, enhanced security, all that, detecting vulnerability. And I tell you, if you're good with the computers, you're an amazing detective. So from micro scale to atomic scale to webinary, tertiary, unitary, the proportions make that we create this net that it looks like an artificial intelligence, and it's wonderful. It's wonderful to be used for diagnostic. It's wonderful to be used, and we use it all the time, more than you think, in the hospital, The computer detects all the problems in an X-ray and then give the results, and then is a doctor that says, yes, I read this is okay. So you cannot do this without a human being. For implants, for 3D scan, it's like a GPS. And also what we have, which is amazing, you know what we have? Robotic surgery. And how do we use this robotic surgery? We use it because Professor Michael Stark. So what he did, he prepared the surgery in this country, and is another team in another country that is there guiding the surgery. Also, it can be used for moving handicapped patients, wheelchair patients. What are the challenges? Can be expensive, it's hard to learn, technology is immature, is oversold, is too much commercial doing. In the mental field is so important. Then we have 75% of the patients, they say, yes, I want my doctor to have AI. And then 86% of businesses, they say, yes, we want AI. Legal and ethics considerations. Imagine now, they say that the robots have rights. We have now virtual nurse. It's cheaper than the live nurse, and never moan, never nag, and she looks good at all times. When we look, what are the benefits? Improving clinical outcome, improve operational performance, improving the system efficiency, administration, it makes it cheaper, so financial aspect, and then the engagement with the patient makes us look good. We look at the data and they say that in 2030, it will be everywhere, artificial intelligence. We can see the advantages and the disadvantages. The disadvantages: cost, talent needed, potential of misuse. And then summary, please embrace artificial intelligence. Finally, remember that we can always push the plug and be afraid of the deep fake, like they use now in Bollywood, in Gazawood, where they put all kinds of fake images which are not true, and saying, oh, they killed 30 people, they killed 30. It's not true. They make this online looking like it is done over there, but it's actually done by artificial intelligence. Please be curious, learn, and be healthy and generous, and thank you very much. Now, Dr. Kiran Kumari, tell me, 1 hour completed, one word, mercury toxicity, drill field bill is not good, and their grades of toxicity with mercury. And then what we can do is we can test, and only patient that want mercury in their mouth is the patient with the Tin Man, you know, metal man. And then the symptoms, look at those symptoms. If you have any of those symptoms, you are yourself a victim of mercury toxicity. This is one of the children victims of Minamata disaster in Japan, when they spill mercury on the river. From that, they got these symptoms. From that, they put mercury in the vaccines, and we got autistic children. And then we got infantile necrophilia from powder, mercury in the teeth, and we have the maniac insanity. So the best detox is to remove mercury, to do this biomeridian test to see the intolerance, to test if we have mercury, to remove it, to test and clean it until it's 0% mercury. Of course, mercury comes from the water, but now we have the test, so less and less fish with mercury coming to the digestion. So all we want is magic, beautiful heart, and not the mad hatter. Why the Mad Hatter? Because in the past, they used to have some workers that they were polishing with mercury those hats. And then all these workers, they became mad dementia. From that, we have in the book, the Mad Hatter, and then we have the Mad Hatter disease. This is a lady, is called Naomi, and for her, we need artificial intelligence because she's in Tanzania in an orphanage for victims of sexual violence, and she was a victim. And imagine if I am in a place where they don't have doctor, I want to have any artificial intelligence that would answer to my questions, and then close it with a pharmacy. Everywhere, if I would be an hospital bed, I really would like to have a nurse that is an artificial intelligence. This mother have 2 children albinos, and she is, why she got albinos children? Because she became victim of violence. Those children, she didn't have protein P, and she gave birth to children with no melanin. This is the orphanage, and this is me. We put the beds. This is the orphanage, and we love them. Another victim of violence, 13 years old, and for them, artificial intelligence is very important. This is my course, and thank you very much. Let there be light. Any questions? Dr. Kumar, thank you so much. I finished my lecture. And if you want to give the line to any other, Dr. Russ, thank you for being there. It's an honor to be with you again. And Laura Yuon and everybody else. And if anybody have any questions, please, here I am. If not, I give the word to our wonderful, wonderful Kiran. Please come to the next Artificial Intelligence Conference, and please come to New York for the laser course. And as well, please come in Malaysia in September for the Gynecology Conference, if it is for you. Gynecology Conference in Malaysia, it is happening in September in Kuala Lumpur, which is a magic place. Also, in 2025 in November, we have Laser Florence. Now, public health is very important. Dr. Ross, you want to say some words?
Yes, hello. Thank you for that, Dr. York. Very, very interesting conversation always. Bringing the light is very important, and as we'll see later on in the continuation with the photobiomodulation talk, it's very important. And you just mentioned about gynecology. So I wanted to know, are you using the light therapy in the gynecology space? And then the second question is, are there differences between gender or ages in using this light therapy?
You can use light therapy with any gender. Like if you have inflammation for prostate, is very good. Of course, remember, this is an addition treatment. So you have to use the state-of-the-art hygiene methods. Any other, for example, for women, right? Menopausal women. The first thing they asked me, I met with a girl, completely other reason. So she told me, so the first thing they ask is, so the ladies is inside, right? They put this liquid, anti-inflammatory liquid or gel, and then they put inside the magic wand. If you Google magic wand, I don't have a picture of it, but I brought one to my mother. So you see, at the supermarket in the United States, at the CVS, you have moisturizing for inside for the ladies. And then this moisturizing together with the magic wand causes regeneration, anti-inflammation. And then we have as well, we have for men, scanning the inflammation area. Also for the women, laser is non-invasive. Either you can use it inside or you can use it outside. And it's wonderful. It's wonderfully magic, the magic wand. But any laser, if you send me a message, I see here a chat. Okay, in the chat, somebody send a message. LinkedIn. Aha, good. And I'm gonna put for you in the chat my phone number. I am so happy to hear from any of you. And remember, all of you became a member for life for European Medical Laser Association. And we have free courses, we have webinars, we have all the time information that we add up on the website. And as well, if you need to buy a laser, I can send you in directly to the factory where you get one with $199 instead of $2,000. I went to a conference in Taiwan recently, and it was a crook who was selling a machine that it cost $20 for $1,000. It wasn't not even a laser, it was an LED. So now you've been to the course, you got the basic course in laser therapy, and you are smart to know LED, no. Laser therapy, infrared, 830 nanometer. So when somebody say, hey, I have a laser to sell to you, you say, what wavelength? Oh, it's 660. No, goodbye. You don't say you're a crook, you say, not for me. And then if it says 830, oh, I'm interested. How much does it cost? What is the power? Because laser doesn't need much power. You check the safety, you check the warranty. Yes, because if something happened or you want to recalibrate. Yes, Dr. Ross.
Yeah, I have another question with this. Thank you for this information because it is practical, as well as conceptual information. So I also wanted to know, is this light photo biomodulation therapy, is it covered by insurance?
I never put the patient to pay. So I incorporate it with my treatment, and it makes my life easy because I have 3 patient rooms, right? Consultation laser. And I ask the patient, put the laser where it hurts. And it's simple. Or I put a special room, I said, hey, scan entire area where you have pain. That's it. Or I give the patient the laser at home. Or I ask the patient, go buy best investment in your health you can do. Go buy yourself a laser. I had once, I bought them from a Russian company when I was in Finland. And I never had them back. I had like 15 lasers I would give to the patient at home, and I waited for the patient to bring it back, never had it back. I have so many, and we test. I buy many devices. I can tell you if it's bullshit or if it's real. That's how I knew about this crook in Taiwan, because I bought one for $16, for $19, and she was selling it for $1,000. And I expose it. You have to expose.
Thank you, Dr. York. And so I'll definitely be in touch, and we have to talk about the photobiomodulation in the oral cavity. I'm very interested to learn some more. And also,
remember only 2 things. Yeah. It's simple. It's simple. Remember 2 things. You have pain here, you put it where is the pain. But before that, you have to remove the inflammation. You have to be sure it's not dirty. It's clean, the area that you treat. Whatever area you treat. And then after you use the laser locally, you have to scan entire area. Like for example, you have pain in the TMJ here, then you have to do a little therapy in this side. Why? I don't know. We still have to research lots of stuff, but I know for 30 years that it works. If you Google laser therapy, if you look in the engine search for scientific papers, you will find 1 billion papers by now for each subject that you want to learn. So let's there be light. Thank you so much, Kumar.
Yeah, hi, Professor Dana. Yeah, can we introduce our next speaker?
Please do, yes.
Yeah, our next speaker is Dr. Alvin Chan. Dr. Alvin Chan is a data scientist with a PhD in engineering, specializing in artificial intelligence, where he held roles in startups, academia, and government organizations. He is currently the co-founder and CEO for Neuro, a global neurotechnology company that specializes in the utilization of brain-computer interface technology. Its extensive portfolio and an array of offerings empower digital therapeutics and brain fitness solutions are backed with clinically validated research by A-Star, an institution widely known as being at the forefront of Singapore's research endeavors. Its core technology, Neuro-OS, is a platform ecosystem that empowers healthcare professionals and developers with an artificial intelligence AI-driven platform to analyze brain signals to provide complementary mental wellness options for ADHD children, cognitive rehabilitation, and many other neurological challenges. Please join me in welcoming our speaker, Dr. Alvin Chan. Due to some emergency issues, Dr. Alvin Chan has sent a link to play in this webinar. I will share the
Kyron, before you begin, can I just mention, so again, Alvin Chan and Neuro is invited, as a part of a collective of what we're doing here at GNN, Getty's Neural Network, and presenting to you a number of treatments, innovations in the therapeutic brain space. And so with the photobiomodulation, as you will hear from Brooke, McKeever and Light MD, ultra red light therapy, you'll hear later on. But yes, again, now with the neuro and the brain computer interface and the non-invasive brain reading and what that means in that therapeutic and educational space. So I just wanted the audience and the people to know that, this is being presented as a part of a block and a really conscious effort for non-pharmacological types of treatment and alternative medicine. Okay.
To Neuro. I'm Alvin Chan, and I'm the CEO for the company.
Yeah, can I play the audio, Dr. Ras?
Yes, you can play it now. Thank you.
Yeah.
In Neuro. Now, in Neuro, we were established in the year 2013. Hi, everyone, and welcome to this introduction to Neuro. I'm Alvin Chan, and I'm the CEO for the company Neuro. Now, in Neuro, we were established in the year 2013, and we specialize in brain-computer interface technology. And of course, with what we do with BCI, we offer various kinds of solutions that include digital therapeutics, brain fitness solutions, stress management, and so on. And all these were backed by lots of partnership in Singapore, especially with our national research agency called the Agency for Science, Technology, and Research. We also work with the Institute of Mental Health. We work with Duke and NUS, our local university that has a collaboration with Duke University in the US, our National University of Singapore, and also with the Geriatric Education and Research Institute here that studies the elderly for research. So a bit of background about myself. Formerly, I was a CTO of a previous startup, which we built and sold quite successfully. That was in the area of social media intelligence. And I have a PhD in engineering, specializing in AI, which I gotten from one of the universities in Scotland. So my specialty is really more in artificial intelligence. And together with my team, I have my Chief Operating Officer, Michelle, my founder and chairman, Eddie, my Director of Engineering, Serene, Operations, Delani, and we also have an in-house cognitive psychologist called Davina. So what we do in Neuro and what our unique value proposition is about making sense out of EEG. So we have collected a lot of EEG data, and with that, we have built machine learning algorithms to interpret these EEG signals into mental states like attention, relaxation, mental workload, and fatigue. And there are many more which we have planned this year, including things like emotions and so on. So we're constantly collecting data, and we're constantly trying to create new mental states to make it easier for developers to use. So how we do all this is we have the technology. Firstly is our EEG headset, our device, which you can see here. This is how it's worn in the model, and this is how it looks like in on its own. So it has 7 electrodes, 4 data channels, 2 on the front and 2 on the sides. We also have a PPG sensor that measures your heart rate and oxygen level. We also built in an IMU sensor, so we detect movements in the head and directions as well. Now, we're also using a medical grade chip here for the EEG data, where it's sampling at 250 Hertz and a resolution of 24 bits. Connectivity is via Bluetooth 5.0, and continuous use will give you from full charge up to 6 hours. And today, as a company, we are also certified under ISO 13485 by Tutsuit. So a lot of quality management systems and so on has been put in place to ensure that we build a quality product. So how we do that with the hardware, we have built what we call a Neuro-OS platform, or you can consider it like an SDK. So the Neuro-OS platform incorporates all the libraries that is needed to communicate with the SenseMan, and it also has all our proprietary algorithms that make sense out of the EEG data, like mental states, as I mentioned before. And we have successfully demonstrated use cases in all these areas together with partners ranging from children, applicable to adults, up to the elderly. And our main aim and vision is to have third-party developers use our platform, use our hardware, and create a lot of different applications that help solve a lot of mental health challenges in the world. Just like Android OS, we call it Neuro-OS because we want to proliferate out there. We want the device to be as useful as it can be by creating many different applications based around EEG. So for us at Neuro, we have 4 pillars of what we do as revenue streams. First is for children, where we created a software together with our EEG device, which we call KOGO. It's a attention training program, especially for children with inattentive symptoms or with ADHD. This is clinically proven, and I will talk about it further in detail in the next few slides. Second pillar is Galini. This is our stress management solution where we actually help people to do mindfulness, meditation, listen to music, and we actually measure your mental states to ensure that you are really, really relaxed and not getting stressed. And it tracks over time how you perform. Third is for the elderly space. I guess this is very important as Singapore is also having an older population, and there are more and more people today getting dementia. So this is actually a brain training solution where we train the elderly on 5 cognitive functions, and we have over 18 games in this application. Our last pillar is actually for third-party developers. We have been working with various developers and partners over the years that have created various solutions. This is actually version 1 of our SenseMan. And to explain a few of these examples that we have a company in US that actually use our EEG device. They created a pain management solution to distract people from their pain, especially people with cancer pain where it's aching, people with lower back pain. So a lot of it is to do with neuropathic pains. Second, we have a partner in Belgium that created absence seizure detection, okay, especially for children with absence seizure or suffering from epilepsy. So this detects that's an epilepsy seizure that's happening. We also have various use cases that people have done for fatigue monitoring for drivers, stroke rehabilitation, and so on. This is also a partner here that we have in Germany and Netherlands that created a neurofeedback therapy app using our hardware and our algorithms. And what you see here in this image is how they go about to train neurofeedback trainers that use the system, and then they go out and treat their patients. So at Neuro, we have quite a fair number of global patents, ranging from algorithms for how do we detect attention, to calmness, relaxation, mental workloads, to how do we treat ADHD patients with EEG-based solution, stroke to elderly, helping you better sleep, and so on. This is all together with our research partner, which is our National Research Institute, A*STAR. So they are the ones that hold the licenses, but we are the ones that partner with them to commercialize the various solutions. So I want to talk about the first use case for children with inattentive system that we use EEG for. Now, we call this COGO, and what happens is the children puts on the device, and when he focuses, the child focuses, the bird here in the game will actually move. And this is actually training on sustained attention. So in this game, we train different kind of attention, from sustained attention to selective attention and into inhibition. And how we train on selective attention is by giving a list of fruits for the children to pick as the fruits come by. As the fruits come by, they need to click on the right fruits and make sure they control themselves and not click on the wrong one. So what we're doing here in this whole process, gamified training, is to instill a habit in the children to develop that part of the brain to be better in attention. And we have found with clinical evidence by doing a 24-session training program that it complete within 3 months, we see very positive results. In fact, this has almost 10 years of clinical studies that have been done. The pivotal trial was done with 172 children with ADHD here in Singapore with our partner, the Institute of Mental Health. They have shown that they have improved by about 30% just after 2 months of training. And a very good publication that was done was we also did fMRI brain scans to show that part of the brain that is responsible for attention, after using our solution in training, that part of the brain has changed. It's shown that they actually got better. And this was published in Nature under Translational Psychiatry. This is US top journal that has been published. So our collaborators who are the researchers in these institutes are very proud of these publications. Here is a better view on, the entire journey on the clinical trials that we have done, where from the beginning,
And Kyron, the audio is out.
was done on the 7th of April, 3 months of training. You can see that it's become more normalized here. This part of the brain that's responsible for attention. So this has shown that our solution actually did affect the child's brain in a very positive manner, improving the child's inattentive symptoms. So the next I want to talk about is, brain training, where we focus really more for the elderly. And in fact, in Singapore, the dementia is on the rise. And I think just last year, some research has been done. Actually, a lot of people in Singapore do not know that they even have mild cognitive impairment until it's too late that they get dementia. And Singapore is also an aging society, very similar to Japan. So what we do here is more of a preventive solution or preventive care. We have an application which we call memory, and we have 5 categories of games that we train the elderly on: memory, decision-making, cognitive flexibility, spatial ability, and attention. Attention is very important. Attention is the fundamental for any of your cognition. If you don't pay attention to anything, you can't do anything. So attention is always very important. All right. So just some examples of how the games work. So for this, in this screen here, this is a game which we call Mindcopter. All right. And this is how we train on attention. This is a very fun game, and this is one of my favorite. When you pay attention, when you wear the device, the helicopter goes up. When the helicopter goes up, your threshold, you hit the threshold of a certain attention threshold, it turns green. And to get the helicopter to come down, you have to relax and not focus. So you're training and disciplining yourself to learn to pay attention, but also learn to let go. And you use the paddle sail to control left and right. So as you get up to higher levels, you're given more tasks to do, and you're actually training your attention further and further. And in the game, we will distract you further to ensure that you are still able to pay attention. Now, of course, Who's Who is one of the elderly's favorite. This is where we show names and faces. Right? And they have to remember the names and the faces of the characters. So really, right, real life situation, sometimes we can't remember the persons that we meet. So this is all about practice and training that part of the brain, all right? And in this case, when we're measuring EEG signals, we're measuring his attention level, and we're measuring the participants' also mental workload. Is he putting in a lot of effort doing this training? And again, all this that we do, we have clinical trials done together with our research partners. And with our research partners, we have proven that using our application for about 3 months, 2 to 3 times a week of training, we've shown improvements in the elderly in attention and memory. But what we also found as a secondary outcome was that the intervention group maintained their walking ability or their gait speed, but the control group actually deteriorated further. All right, so this is an interesting finding, which means that by improving your cognition, you're also improving your ability to walk and so on. So that will lower the risk of falls as well. And again, like the previous work we did, this have also almost 10 years of research, all right, from the beginning, where we did some short trials and testing the concept of using EEG with the games. And then we ran a trial for about 100 elderly with a mean of about 68 or 69 years old for the elderly that we did. This was done as a single-blind randomized control trial, all right? So these were all with positive results. So what I want to talk about now is really more on our Neuro-OS SDK, which we call it enhance, empower, and innovate. What can you do to enhance what you're doing, empower what you're doing, and can you innovate further? So this is about inspiring people on what will be your next application, all right? So just to share, there's a lot of research lately has shown that, we will all develop some mental disorders by the age of 75, all right? So throughout our life, we will suffer from, as we're young, maybe suffer from certain anxiety, or at work professionally, certain stress, so on. As we get older, of course, there's dementia, so on, right? This is an example of some work that we did with one of the hospitals in Singapore, where we created irritable bowel syndrome app. These are people that are too stressed and too much anxiety, and they have been diagnosed with IBS. All right. And in this app that we created, we help participants to understand about nutrition, understand about, journaling, how do they take note, and how do they feel better. And we put in mindfulness activities in there to actually get these participants to help relax and so on. Because having IBS symptoms is because a lot is to do with mental. It's not just physical alone. So this was done and researched and developed by our Singapore General Hospital here in Singapore. Together with Singapore's Ministry of Manpower, or together with DHL as well as a partner, we also had a prototype we created with them. These are all funded by the government, where we created an app to monitor the fatigue levels of drivers with our EEG device, the heart rate. And of course, with a phone, we have GPS and we're monitoring their various mental states. And we could also track where drivers are fatigued, along which roads they're driving. And we can look at individual drivers throughout each day, when they were tired. Is it after just having a heavy lunch, then they're tired, and so on. So this was done, and we successfully demonstrated to DHL that they could better monitor, their drivers and look at their status and see if we can lower the risk of any accidents on the roads, or even optimize how they schedule their drivers to be more productive. Okay. We also have some partnerships with in Singapore here called the Center of Mindfulness, and they've been using our device and been experimenting with it. So I would like to play this video for you to have a listen.
We at the Center for Mindfulness have been exploring various ways to measure the effects of mindfulness, especially when someone is meditating. And that's when I discovered this particular sense band, which is an EEG device that helps us to measure brain waves. So through our own discovery, we realized that this is a great way for us to understand what happens to the brain, or what happens in the brain when someone is practicing mindfulness. So in our very short experiments with people who have been practicing mindfulness, we have seen very, very interesting results from this particular device, where we see literally and instantaneously the changes that are taking place in the brain while someone is meditating and when someone is doing another task or even not in meditation.
Okay, so these are just some of the works that we've done with various partners. So what are the other possibilities? I think the sky is the limit. That's why we're here today. Some ideas that come on my mind, which we have some projects that we're working through. It's about human performance. Can we help air traffic controllers who are monitoring the traffic in the sky? Can we make sure their performance is better? How about the police and military? They also need some way to monitor the performance of the soldiers to ensure that they're at peak performance. Of course, we want to have healthy aging. Everybody is living longer now, but we want to make sure that the quality of life is also there, all right? In the areas of helping with cognitive impairment, or also people with rehabilitation, Of course, today, because of COVID, a lot of people talk about mindfulness, stress management. Can we do more? All right. There are also people with social anxiety, impulsivity. Can we also do more in that area? And next, what I want to show is we actually have this in the office where we call it a neuropod. So this is a structure we built. And this structure is where we wanted to have different people to come together with different ideas on what do we want to do. Can we put someone in this pod, put the device on the person? Can we cover this structure up, make it such that it's complete darkness? We attach lights in there. Can we do experiments to see what happens if there's different light shown to the person? Or we can also put different speakers in there all around, maybe 3D, 4D kind of soundscapes. Does it make the person better? What happens when the person hears different kind of sounds? What happens to their brain waves? So these are things that we are embarking on to actually experiment and seeing how a person reacts through his EEG brain waves, right? So if you have any ideas and so on, if you're happy to come and be part of it, do let me know. So our NeuroOS SDK, right, is actually available for your Android, iOS, Windows, and of course for Unity, because a lot of the stuff we do is developing games on the Unity platform. It gives you access to our Neuro's proprietary algorithms for attention, relaxation, and mental workload, access to raw EEG signals. You can have it filtered or unfiltered, up to you how you want to use it. Also the motion sensor readings, the PPG readings, activity indicator as well. On the front of our device actually has a light that you can control. For example, if a person is paying attention, you might want to control the light to be green. If it's not paying attention, red. So there are some of these features that are available through the SDK. So as part of the SDK, we also give you a kind of a control panel toolbox, which is developed in Unity. So we have all the functions that will have the code shown to you, so you know exactly what the code does by actually playing with this application it comes with the SDK. Like how do you toggle the scanning of Bluetooth? How do you turn on and off to trigger the EEG signal to come through? Controlling the light indicator on the device, and so on. So this is available, so you can look under the hood and see what is the code that's controlling this to use in your own applications. So just going through 4 channels, you get the raw EEG waves if you choose. You got all your, alpha, beta, delta, theta waves as well. Your raw PPG waves if you want to create HRV algorithms and so on. It's also available. And of course, our proprietary algorithms for our mental states. And we also have the function here to calibrate the motion sensor. Again, you look under the hood with the code, you can see what is going on, and that will help speed up you developing using our SDK, right? So that comes to the end of my presentation. So come talk to us, drop us an email, we're happy to chat and ideate, and maybe we can create a positive impact to society today. How can we help society? All right. Thank you very much.
Thank you for that, Kyron. Dr. Ross here, and Alvin Chan is on the road. I will say fortunately, because he's handling some business. But if anyone has any questions to the information in the pre-recording, definitely I'm here. I can answer any questions live right now, and also beyond this point as well, because I am and we are partners with Neuro, and I'm here in the States and, looking to do clinical trials and some research studies with this and other devices as well. So if there's any questions, I'm available to answer and to reference to what you just heard.
Yeah, Dr. Raz. Hello.
Yes. Yes.
Yeah, can we play next recording of Brooks?
Okay, you would like me to play it?
Shall I play?
Yes, if you can play it. I don't know if Brooke is live right now. I did message her to see if she would jump on after, but yeah, she will be available at some point today. But yes, you can play the video now. So this would be then the trans photo biomodulation and the introduction of Brooke McKeever. Yes, please.
Yeah, I will introduce her, okay?
Okay.
Yeah, our next speaker is Dr. Brooke McKeever. Dr. Brooke McKeever has spent the last decade using her personal and professional experiences to help her clients get out of pain quickly, reduce stress and anxiety, and balance the body's systems without drugs or surgery. She owns and operates Ultra Red Light, a health and wellness business in Newport Beach, California, specializing in advanced photobiomodulation therapy, where she gets hands on experience by helping people with brain and whole body health and wellness. As a director of provider services for Light MD Inc., Brooke is selected to sell the unparalleled PBM technology nationally and internationally, train and support doctors, chiropractors, wellness practitioners, and clients who want to add Light MD to their lives or to their practice so that more people can benefit from this natural healing innovation. She has a passion for transcranial PBM after suffering multiple brain injuries and beginning her own brain healing journey with light so that she could help her clients even more. Please join me in welcoming our speaker, Dr. Brooke. I would like to play her recorded video.
I'm Brooke McKeever, and I am thrilled to be here with you all from the HK conferences. So thank you so much for the invite, Dr. Rastafa Geddes and the Geddes Neural Network. I greatly appreciate being here with you all, and I'd love to answer any questions that you may have as well. And let's dive into photobiomodulation of the brain health, transcranial photobiomodulation, or TPBM. This presentation is by myself and LightMD, which is a division of Applied Biophotonics, a worldwide company. Cognitive disorders encompass a broad spectrum of neurological deficits. This includes Alzheimer's and dementia or memory-related diseases, mild cognitive impairment, early onset dementia, frontotemporal dementia, Lewy body dementia, stroke-related cognitive dysfunction, or we have TBI, MTBI concussions, neurological diseases such as MS and Parkinson's. So we'll start with where in the brain and the functions. In the frontal lobe, we have the cognition and motor skills, parietal is perception, temporal lobes, memory and audio, occipital is vision, hindbrain, memory and motor as well. In the brainstem, we've got the autonomic nervous system, metabolism, as well as the connection with the spinal cord from the brain to the spine, so your central nervous system. We've got the ganglia, which with interneural communication, and the corpus callosum with the left and right brain communication. Now, for the pathology, we can have motor dysfunction, cognitive disorders, metabolic dysfunction, or endocrine dysfunction. And these can come from etiologies such as MTBI, concussion, strokes, hypoxia, or hypoxemia, pathogenic infections that can happen in the brain, metabolic dysfunction, allergies, toxins, or even congenital defects. Some comorbidities can lead to these neuropathies in the brain, such as hypertension, diabetes, arteriosclerosis, inflammation, autoimmunity, and genetic factors. Today's cognitive health challenge is that few modalities treat brain neuropathies. There is an option for surgery or pharmaceuticals, but they're just not good viable options, and we haven't found cures for these or anything really to prevent and to dramatically slow down the process. So neuropathic cognitive impairment is a pervasive and growing public health crisis. That includes Alzheimer's and dementia. We also have a chronic traumatic encephalopathy, so CTE, brain fog and inflammation. The common brain neurological etiologies are the TBI. This occurs mostly from accidents or sports injuries. The type of different strokes that can occur are ischemic, hemorrhagic, or TIA. We've got also drugs toxicity, so overdoses with narcotics, also pharmaceutical addictions, age-related neurodegeneration diseases. Also affecting the brain is Lyme, herpes, and long COVID, as well as mitochondrial bioenergetic dysfunction. So there is a lack of therapeutic options, which is where we come in. So introducing LightMD's photobiomodulation. So photobiomodulation is the therapeutic application of non-ionizing electromagnetic radiation in the near infrared and visible light spectrum applied to living cells, which invokes a metabolic and gene expression mechanisms to combat disease, injury, and pain. On your screen here, you'll see what the LightMD Mark II PBM system looks like. It can fit in a shoebox or a backpack. It can be carried with you. It can be used in hospitals. It is hospital grade materials. You'll see Light Doctor, that's our sister company from Applied Biophotonics that operates in Asia. This is a professional product used by professionals, hospitals, doctors, but also consumers. It is medical grade quality, hospital safe, FCC certified to not interfere with any other technology, radio waves, or anything implanted in the body. It's also IEC rated, eye safe. Now, there are a lot of light devices coming out, and this certification is imperative as a lot of the treatments are beauty treatments, plus over the brain, you often will have the light in your eyes. So it's important that this is eye safe. It's also FDA and GMP manufacturing approved. So we've been through multiple audits and have passed everything, some as long as 2-week audits. So we are free and clear with the FDA. This device and the therapeutic use of it is non-invasive. It is non-toxic. We are not adding any chemicals or needles or knives or anything in order to achieve the desired results. It's non-porous polymer materials in the pads, does not harbor bacteria like some of the rubber neoprene materials that you've seen. It is kidney and liver safe. So doing this treatment, you can't damage your organs or have negative side effects besides dehydration, which is very controllable. So it's completely safe to use and has been tried and tested since actually early 2000s. It is not a drug or pharmaceutical. And last but not least, it's very convenient and comfortable. It's easy to use, it's easy to operate, and the results are amazing. So we've got versatile software and precise photonic control of the photobiomodulation. So the Mark II PBM system has reconfigurable light pads. You can see these pads here. They're in 2 sets of 3, meaning that you can treat 2 areas of the body at once. You could do the brain and the gut, the brain and the heart, the brain and the spine, the brain and the lungs, or you could do the brain and a knee if you have knee pain. So it can literally, or you can do 2 brains at once. So it is quite user-friendly, and it is controlled with dynamic frequencies as well. You can control the duration of time. You can adjust the irradiance, so the brightness of the LEDs, which will ultimately affect the overall power. You can do a precise dose, which is the fluid. So this is a big thing right now, a big topic in the photobiomodulation industry is getting the precise doses. So a lot of studies are coming out with the need for dosing. This system allows you to control the dosing. So it's already way ahead of its time, and adding that in is we are prepared for the next stage. It's got algorithmic sessions. So they are sequenced and easy to use. Also a hierarchical software. Let's dive into the biophysical mechanisms of photobiomodulation. So we have light absorbing molecules called chromophores, which are in the mitochondria of our cells. The mitochondria is known as a little powerhouse or power plant of the cells. In these, the chromophores are cytochrome C oxidase, also nitric oxide. You have lipid protein, water homeostasis, and mast cells. You also have the transient receptor potential for calcium cation. So when the light hits the tissue, specifically in the cells and the mitochondria, this process, a photochemical process occurs. Okay, so the cytochrome C oxidase responds to the light and it enhances the mitochondrial membrane potential and starts the process of ATP synthesis. So give me 1 second. So when we have this and we're affecting the transmission of the electrical transmission of electrical signals, you have nitric oxide release from the cell, allowing for fresh oxygenated blood into it. You have calcium cation modulation, and you also have nuclear transcription factors releasing. The physiology of this is that the vasodilation occurs. You have an increase of circulation. So now you have the blood vessels that have expanded, so more blood flow can go through, more circulation happening. The lymph system is doubled. The oxygen saturation is affected, often increased immediately or in minutes. You've got protein, hormone, and enzyme synthesis, leading to neurogenesis, angiogenesis, and fibroblastic activity. So all of this happening, I'll give you a timeline here in a moment. There we go, timeline of mechanisms of action. So neuromodulation happens first. That happens in the first 10 minutes. This can be through brain entrainment, usually on the frontal and temporal lobes with pulse frequencies in the low hertz range, coordinating to whatever brain state that you want to achieve. We also have neuromodulation through pain relief through the back of the brain. All this can occur in 10 minutes. In 20 minutes, you have the reactive oxygen species and nitric oxide generation. So those are released from the cell. This starts the process of the vasodilation and circulation. We have anti-infective frequencies too for innate immunology. After this process and the temperature of the tissue has increased, then in 6 to 8 hours is when the ATP is generated from the light energy. So ATP, adenosine triphosphate, is cellular energy, and that is increased with the MMP as well. And this is part of the molecular signaling, and increased metabolism occurs. Then in 24 to 36 hours, so basically the morning after, you have protein synthesis that begins and gene expression. You have the nuclear transcription factors, which is leading to the protein synthesis and the translation of the mRNA. Okay. And then that carries on from 24 to 36 hours. In the process of 1 to 3 weeks with continued sessions, that's not every day. It could be 2 times a week. It could be 3 to 5 times a week. It just depends on what we're working on. That's when the major process of inflammation and remodeling can occur. So major edema, you have inflammation and granulation, you have wound repair. Now, wound repair is a complex process. It is started immediately after the 24 hours with the light therapy. But to get that complex level of healing, it really is going to take 1 to 3 weeks. After that, we have greater than 3 weeks, we have homeostasis. The equilibrium is going to be reached. We have a healthy cell state and physiologic equilibrium. Now, this can take 3 months. It can take a year. It just depends on how far out of homeostasis that the individual that we're working with is. I can give you an example. We have a client in our clinic who was way out of whack. And the doctor, she's seeing about 4 different doctors, and oncologists and rheumatologists, endocrinologists, and internal medicine, as well as naturopaths. These doctors thought that she would be better, gave her an estimation of 2 to 3 years. In 4 months, we got her to homeostasis. So it can happen a lot faster, and that is the goal, is to speed up the natural healing process for all injury, illness, and disease. So Mark II's transcranial photobiomodulation is unlike any other because, number one, we can treat a large area. So these pads can treat up to 1,200 centimeter squares. There's over 1,200 LEDs working on this to penetrate the surface of the skin and to provide this overall fluence and energy that's going to help you heal yourself. The pads are easy to place and forget. You don't have to hold them on. We usually have a wrap to hold them in place, or somebody is, or we have a mechanical arm if we don't want the pads to touch the brain. It can be positioned over affective lobes. So as you see on the bottom, we have the light ABP, the neck pad, which is called our cervical collar as well. It can go there around the neck, but it can also be used as a chin strap to get up into the pituitary, the pineal, the hypothalamus as well. You can use the 3 pads or 2 pads over the face, which will also cover the ears and the temporal lobes. You can go from the back of the neck, the back of the head. You can go to the top to cover the corpus callosum and down into the temporal lobes. You can even have it going from the frontal lobe to the back of the neck, and the forehead. So you can treat the forehead with both the neck collar or the regular pad. So either way, we can cover all regions of the brain. The pads are flexible, so they bend to match the skull contours. This is super important because you want the light to hit the surface of the skin at right angles. So all of these pads can contain both red and near infrared light. It's important to have both. Near infrared light is the light that's going to penetrate the skull the most. Red light also is known to penetrate the skull, but just not as deep. Our system also uses pulsed frequency, so controlling this is important. And there are sequence sessions. We have silicone covers to keep this hypoallergenic and to keep everybody's skin cells to themselves. And then it says also the neck pad for the brainstem and the vagus nerve. Does light penetrate the cranial skull? Yes. So just getting into this, we show that near infrared and red light penetrates the skull bone. This was a study done in 2012 in a cadaver. So you can see on how far that it's going to penetrate. I'd like to see with the new style of cadavers that Dr. Ross and his neural network are working with, which are pretty lifelike. It's fascinating. I'd like to see if this changes and to track the penetration. So that would be something fun to look at and to add to this research. So penetration depth depends on the wavelength. So that means the red or the near infrared in the 600 or the 800 range. The frontal skull in women and men and different ages and sizes varies. So that is a factor. Studies confirm both red and near infrared reach the brain. A majority of cognitive deficits involve the cerebral cortex injuries, so frontal lobe of the cerebrum. Cerebrum and cerebellum affect motor neurons and coordination. So you can see on the left parietal skull, the near infrared is this one with the 8.3%, whereas the red is 1.7. In the left parietal skull, another model had 9.7 and 4.4. 2 models in the front had 4.4 and 7.4 versus 0.3 and 1.8. So as you can see, there's a lot more of the penetration of the near infrared light. So modalities of LightMD's transcranial photobiomodulation. we have figured out that by precisely controlling the irradiance, which is the power, the luminance, which is the energy, and the pulse frequency, the Mark II is able to target neurons non-invasively, delivering 3 distinct therapeutic modalities to the brain. Neurological repair with neurogenesis and tissue oxygenation, neuromodulation, like analgesia and pain management, and brain entrainment through the front brain is the neural subnet syncing. So why does the frequency of PBM matter? The neuron repair is frequency dependent. Ion channels require time to transport charge. Nerve transduction is a process of transmitting electrical signals along the neurons. So it does have a maximum frequency. Neuron cannot re-trigger during the absolute refractory period. This is because it needs a break. It will not have enough energy. This happens all through action potentials, which are the rapid changes in the voltage across the neuron's membrane. So the maximum frequency, as you can see on this graph, it refers to how often the neuron can fire its action potentials. The neuron can't fire continuously without a break due to physiological limits. And then after an action potential occurs, the neuron goes through 2 of these refractory periods, the absolute and the relative. So during the absolute, it cannot fire another action potential no matter how strong the stimulus is. And this is because sodium channels are inactivated and they need time to reset. This ensures that action potentials only travel in one direction, and also that signals are distinct and don't merge together. So the absolute refractory period, you can think of it as a cool down phase for the neuron. Now, the neuron during the relative period can have a re-trigger, but it requires a much stronger stimulus. So it's temporarily hyperpolarized. There's a frequency dependence of photobiomodulation. So neurologically, it's a radiculopathy, and oxygenation, and neurogenesis. Those are all different frequencies from high to low. The EEG and brain waves. So providing the brainwave entrainment, you can have the low you can have like 1 hertz. So in delta, you can have theta, which is like 4 to 7 or 4 to 8 hertz. Then you have alpha, which is 8 hertz and up. And then you've got, gamma into the 40 hertz range. So just depends on what you're working on, whether you want to induce sleep and go to delta. If you want to promote relaxation or meditation, you go to theta. If you want to improve cognition, you go to alpha, and to improve memory, you would go to gamma. So these are able to be entrained in the brain as EEG and brain waves. Other frequency dependents are neuromodulation. You can achieve analgesia and the pain relief, or homeostasis in the balance. So a wide range of frequencies with the LightMD system. You can go from 1 to 10,000 hertz that are already pre-programmed in, or 10,000 to 20,000 hertz, which can be customized and entered manually. We've got quite a bit of case studies for the Light Doctor, our sister company in Asia, transcranial photobiomodulation. We have some here in the US as well, but not quite as many there as are there, and they're doing them in hospitals as well. So for MTBI and concussions, a lot of those were done here with Dr. Joseph Leahy, who's a San Francisco 49ers team doctor. There's over 140 of those. We've also got major depressive syndrome, stroke, Alzheimer's, and dementia. There's 10 of those. Pathogenic infections like long COVID, brain fog, Lyme disease, and pandas. We've also got 4 studies for neurodegenerative diseases, Parkinson's, and lupus. So these case studies are profound and have led to us developing protocols as such. In the pictures you'll see, this is a Excellent headband placement for the forebrain and hindbrain. This is a common treatment that we do for Alzheimer's and dementia. So for transcranial therapy of MTBI or concussion, we've treated over 145 MTBI patients. This is also, like I said, through Dr. Leahy and other clinicians. These can come from car collisions or mostly sports and football specifically, and soccer. Lots of women with soccer as well. The positive outcomes happen in 142 out of 145 cases. They did the transcranial PBM by Light MD, and you want to work on the area of injury, but also on the brainstem and ears. We have subjective assessments, so patients self-reporting as well as testimonials. There's also the doctors performing concussion evals, like the ACE test and the SCAT-5. The objective measurements were EEG through the Neuro-Sci and the Leahy Concussive Index, which is an LCI. Now for EEG, we are exploring now the Neuro device, which you'll hear from Alvin about, or if you haven't already. So we're very excited to be testing that technology so that we can have more data points and can help our clients better. This is a young lady who had a concussion. She said, after receiving my first light session, it was like a complete 180. I was more of one myself. My energy increased. I was able to focus and remember a lot better. I was really impressed. So the LCI is a quantitative measure of concussion. That's Leahy Concussive Index, measuring its nonlinear signal processing, measuring Higuchi fractal dimension, the Shannon entropy, and the EEG scaling. I will go into more of this later, but because we're a little low on time, I'm going to go just pass through this. The LCI does confirm the TPBM efficacy in our concussion therapy, though, so showing that the patients can go back down to baseline after the treatments. So that's very important. So we've got the brain swelling and trauma, the first session, and then additional sessions will get you further. So your LCI 0 to LCI 1, a change of about 16%. These are all patients, and these are the changes that they went through 0 and the first session. So transcranial photobiomodulation of depressive syndrome. This was done at a hospital in Taiwan. So treatment across the top of the head in the frontal and temporal lobe, reduced emotional symptoms while increasing tissue oxygenation. So you can see the negative symptom severity decreased here in the PANSS negative scale score. This is showing an increased area of oxygenation here. So here's before with poor circulation and oxygenation. This is afterwards, and this shows the changes. So really profound here. The other part of this study is showing the change in the increase of transhemispheric neural connectivity. So big changes here before and after transcranial PBM by Light MD. I have some additional case studies here as well. So, excuse me, we have an 80-year-old female with advanced Alzheimer's disease, unable to care for herself, recognize family, or comprehend her surroundings, made a full recovery in cognitive and motor skills in 8 weeks after commencing Light Doctor TPBM. She now plays mahjong without assistance. Our second one is a 93-year-old female living with Alzheimer's. She was living in 4 years in an assisted living memory care unit. This is one of my clients. Unable to remember the many countries she traveled in her life. After 11 biweekly sessions, her neurologist noted that in her 20 years of practice, she was the first ever to improve enough to pass the dementia exam. So both the neurologist and the family of this client ended up purchasing our system. We have some Parkinson's case studies here, which are profound. We have a 69-year-old female with Parkinson's 1 year after diagnosis with mild but steadily increasing symptoms. She tried a 40-minute TPBM session. Later, 2 days later, following her only session, her shaking and other symptoms remarkably improved. she ended up purchasing because she lives in a rural area and was not able to reach a clinic for these treatments. So she and her husband are self-administering these sessions. And her daughter, who is a neuro nurse, has exclaimed how much this has benefited her family, especially her mother, and slowing the progression of the Parkinson's. Another interesting case from my clinic is a 64-year-old male with PSP. So that is a rapidly progressing supranuclear palsy form of Parkinson's. And it's a rare disorder causing which the medications, they do not respond to the normal Parkinson's medications, causes dysfunction in speech, movement, walking, balance, vision, swallowing, eye movement. His doctor had given him 6 to 8 months to live. After performing light sessions on him three days a week for 2 weeks, his wife said she had her husband back. He could talk to her on the phone. He could handle business calls. He could write. He felt normal. He was even golfing. And after 8 weeks of treatments, his doctor withdrew the prognosis of impending death, and he purchased a system, and he is still golfing today. We also have cases with pandas, which are phenomenal: aborted stroke, CVST stroke recovery, vaccine injury, and long COVID, a gunshot wound leading to CRPS, neuroendocrine failure as well. This is a stroke recovery case study. So after 1.5 year remaining unresponsive, paralyzed, and bedridden, the patient made a full cognitive and motor recovery in less than 8 weeks of light therapy. So passed all of his tests, and it was a dramatic recovery. This was also done in the hospitals in Taiwan. So transcranial PBM offers an emerging non-invasive modality in the treatment of cognitive and motor impairment from stroke, trauma, and disease. Case studies confirm that TPBM, cognitive recovery of MTBI, depressive syndrome, stroke, and Alzheimer's, the biophysics of 3 transcranial PBM modalities and the frequency-based mechanisms are disclosed. High-frequency brain neuromodulation for analgesic relief from pain, neurological repair and neurogenesis via NTFs and enhanced oxygen, and brain entrainment, enhancing gamma beta cognition. Like Norman Vincent Peale said, if you can change your thoughts, you can change your world. These are protocols that they only really apply to people who have systems. I'd be happy to go over those with you if you are interested. I also want to thank Richard Williams, Dan Shell-Kinlan, Jeff McKeever, Dr. David Kahn, and Dr. Joseph Leahy for their contributions and cases contributing to this presentation. And the companies Applied Biophotonics, LightMD, Light Doctor, My Clinic, Ultra Red Light in Newport Beach in Southern California, and Chase Chiropractic up in Northern California. And last but not least, let's keep in touch. You can find me on LinkedIn or email me directly, brookm@lightmd.com. You can find me on social media, Ultra Red Light, Instagram, Facebook, and YouTube. We at LightMD are interested in sales, research, both clinical and case studies, podcasts, corporate events, conferences. We are open for things. So let's dive in. Let's learn more about the brains and how photobiomodulation can affect not only the brain, but the whole body. And let's make a movement to help each other heal. Thank you again, everybody, for your time. And I love being here. I'm available to answer questions.
Thank you, Kyra. And again, Brooke is not available, I believe, at this time. She will be in later. But if anyone has any direct questions right now, I again can answer any questions you may have about the transphoto biomodulation or LightMD or ultra red light therapy. Thank you, Brooke McKeever, and everyone over at LightMD.
Yeah, shall I go for next presentation, Dr. Ras?
Yes, sir.
Yeah. Yeah, our next speaker is Miss Esra, Dr. Esra Hamed. Dr. Esra Hamed is a pediatric dentist and dental public health consultant since October 1, 2021. She is passionate about oral health and research. After obtaining her bachelor's in 2007, she pursued her studies in pediatric dentistry and dental public health at Faculty of Dentistry, Ain University, where she was granted her master's degree in August 2016 and continued her PhD in the same field of study at Al Azhar University in August 2021. Additionally, she volunteered in different non-profit organizations promoting oral health awareness. In 2022, she began researching in environmental field of study and was a keynote speaker in more than one international conferences and looking forward to collaborating with different researchers in the same field. Please join me in welcoming our speaker, Dr. Esra.
Hello.
Yeah, hi, Dr. Esra.
Hi, how are you? Thank you for invitation.
Yeah, thank you.
I will share my presentation now.
Yes, you can share your presentation.
Okay, we are going today to talk about eco-friendly dentistry. As we all know that we have climate crisis, climate change, and global warming. So, as of course, we know that climate change has impacts on different aspects of life, especially on the human health. There are changes in vector ecology leading to some diseases such as malaria, Lyme disease. There are increasing pollutants and allergens that cause different respiratory diseases, allergies, and asthma. Also, there is extreme heat and hot weather that leads to cardiovascular disease and sometimes to death. Also, there are disruption for the water quality impacts leading to some diseases like cholera, malnutrition diseases, and even climate change can lead to psychological impacts because it causes environmental degradation in some countries, leading to forced immigration from countries. In my field of study, in particular, is the oral health. So, how climate change affects our oral health. Honestly speaking, there is not yet evidence-based and proven statistics on the association between climate change and oral health. However, many researchers have researched in this area of field of study, and we have found that there is an association between air pollution and climate change and some oral disease. For example, this is a systematic review that was formed in 2016 to see the correlation between maternal exposure to air pollution and the risk of orofacial clefts in infants. And they found that ozone, the harmful type of ozone, was most consistently associated with increased risk of orofacial cleft anomalies compared to other air pollutants. However, carbon monoxide and nitrogen oxide was correlated with a reduced risk of orofacial cleft. Another study in the same field also was conducted in 2021 to see the association between air pollution exposure during early pregnancy and the risk of orofacial clefts. And yes, they found that the maternal exposure to different gases such as carbon monoxide, nitrogen dioxide, silver dioxide during the first trimester of pregnancy may contribute to the development of orofacial clefts. And this is independent of the particulate matter of the size of the gas. Also, there was an ecological study that was conducted in 2020 to see the association between global environmental indicators and early childhood caries in 3 to 5 years old children, such as carbon dioxide, methane, silver dioxide, and nitrous oxide. And they found that there is a direct association between nitrous oxide and the prevalence of early childhood caries. However, other emissions such as methane emissions was inversely associated with early childhood caries. However, still the pathophysiology of how nitrous oxide increased the risk are unclear and require further research. Also, we have a condition in the oral health called MIH, molar incisor hypomineralization, that is a disruption in the mineralization during the period of tooth formation, during the amelogenesis period, and it leads to the presence of white opacities on the first permanent molars and also in permanent incisors. And there was a study conducted in 2020 found the impact of environmental air pollution on the prevalence of MIH, and it found that there is a relation between air pollution and MIH. However, it's not clear whether air pollution causes MIH or, of course, a child living in a country with a lot of air pollution will be affected by many respiratory diseases and allergies and asthma that include that it takes different medications. So maybe the medications that he takes is a reason of MIH, not the air pollution. It's also further research is needed in this area of study. Okay. Is dentistry eco-friendly? Unfortunately, dentistry is not eco-friendly at all, because dentistry is an resource invasive industry that depends on the usage of many resources and many energy, including water, electricity, waste products. So recently there is a new term called green dentistry or eco-friendly dentistry, which is an upcoming emerging trend in dentistry, involves a high technology approach which reduces the environmental impact of dental practice in moving towards an ecologically sustainable healthcare system in order to maintain sustainability. As we know, in order to promote the oral health and well-being in dental practice, there are a lot of waste products, biomedical waste that is evolved, and the dentists use many instruments and many heavy materials, all of which can result in imbalance in the environmental environment and leading to pollution. Of course, we know we have many waste products, including tin foil, including plastics, including fixer and developer solution chemical waste. We have different types of waste, unfortunately, associated with the practice of dentistry. And of course, all these have a negative impact on the environment, leading to a great amount of carbon dioxide gas emissions. And therefore, we have to stand and find which steps we can omit, or we can replace it with other steps in order to decrease the carbon gas emissions that are emitted from the practice of dentistry. Another problem is the dental carbon footprint. Environmental footprint of travel within dentistry is considerably higher than elsewhere in the medical sector, because many dental procedures need more than one visit. We don't finish our treatment in only one visit. Also, we have follow-ups. We have procedures to be performed that have to be delivered first to the dental laboratory and then to the patient. So there is an issue of travel carbon footprint in dentistry. Other sustainability challenges is the use of some drugs like nitrous oxide that we use in general anesthesia. Actually, it leads to 298 times emissions of carbon dioxide more than the carbon dioxide itself, and especially if it is given in association with other general anesthetic drugs like sevoflurane. So this is another challenge that we meet. So what can dental professionals do? What is the solution? First of all, as Hippocrates said, we have first to do no harm. All the dental team, including the dentists, the dental assistants, and all the dental staff, has to stand and see what they can do in order to provide the patient with ideal dental treatment, but with the least possible harm to the environment. So that was my motive to do a research, cross-sectional study survey under the title "The Awareness of Eco-Friendly Dentistry Among Egyptian Dental Practitioners" in order to assess the degree of awareness of Egyptian dentists about eco-friendly dentistry as a way or as a step for the preparation for its future implementation in Egypt. It was a cross-sectional online survey, CAP survey, that was conducted involving 380 Egyptian dentists distributed across different geographic regions in Egypt, and it consisted of 41 closed-ended questions in order to assess the knowledge, the attitude, and the practicing of the eco-friendly dentistry. Actually, the results showed us that the main factor that are influencing the adoption of green dentistry is the knowledge. About 78.8% of the dentists said that the knowledge is the main factor. The awareness of the eco-friendly dentistry is the main factor to adopt it, followed by the cost, followed by the time. Also, when we especially asked the question, are you aware of the term green dentistry? Has been found that 65% has heard before about the term, and only 30% was hearing it for the first time during the period of conduction of the survey, and 5% was already practicing it and was from the central area of Egypt. So why only 5% was only practicing it, although they have the knowledge? Also, they show us that the willingness of all of them had the willingness to implement green dentistry. And of course, it will be more complex procedures, like the infrastructure of the dental hospitals and dental clinics. We have to modify in the infrastructure. We have to adopt some recycling systems and maybe the cost. So we have concluded that the Egyptian dentists have a good knowledge about green dentistry, although maybe the economical barriers be a barrier to implement it. So what are the solutions, or how we can overcome this? First of all, for the basic concepts of green dentistry to be implemented, we have many models. The most common model is the 4Rs model, including the rethink, reduce, reuse, and recycle model. Of course, for example, we're talking about the travel. We said that in dentistry, dental travel is a part of many carbon emissions that we have to minimize. How to minimize? First, we take the first model is rethink. As we know, is the changing of the mindset in general is the main step to change. We have to first change our mindset to accommodate any new habit to form. So we can use, as in the period of COVID-19, all of us use teledentistry for remote consultations. And by this way, we will minimize the number of visits that the patients will do to the dentist. So we decrease the carbon travel footprint. Sorry. Also, we can make family appointments. That means that the father and the mother and the kids, all of them will have this at the same time, their appointment at the same dentist. Of course, the dentist will have more than one specialty. There are more than one dentist that can work with each one of the family in one visit, for all of them to minimize the carbon travel footprint. Also, we can reduce the number of delivery supplies. We can use online deliveries. We can use online dental laboratories or digital digital dental apparatus like CAD/CAM systems to minimize the travel footprint from delivering to the dental laboratory and for the try-in, for the delivery, to minimize, make it an in-office laboratory restoration. And of course, consider preventive dentistry and provide high quality intervention that don't require revising, so as to decrease the failure and decrease the number of follow-ups. And that was what the FDI made. It made a sustainability and dentistry project that ensures that the best step and the most important step in order to maintain sustainability in dentistry is to ensure the provision of an actual good preventive system, so as to ensure high quality treatment to all patients and minimize failures and minimize revising and follow-up. Also, regarding our equipment and supplies, we can reduce purchasing products that we don't need and that may waste later on. We can reduce paper waste by, first, we have, as I said, going digital. Green dentistry means going digital. Everything is digital, starting from the patient recording system. We no more depending on paper system, depend on softwares, digital X-ray, all is digital in order to minimize the use of paper. If you want to use paper, so you can print on both sides to minimize the number of papers. Educate your patients on sustainability. You have to motivate not only the dental practitioners, you have to motivate your patients to seek green dentistry practice, so as to be motivated as us, because the environment is belongs to all of us. Educate patients on using alternative non-plastic oral hygiene products like bamboo toothbrushes, like tubeless toothpaste tablets, like biodegradable products, okay, that cause no harm to the environment. Also, as I said, we have different chemical wastes in dentistry. We have the amalgam restoration that has a lot of, consists mainly of mercury and other products like tin and silver, all of which plays a very important role in environmental pollution, because amalgam, if went with our water waste, it will go to the soil. It will be transferred to something called methyl mercury that is very harmful to the animals and plants and to the human, causing lung and kidney diseases. So we have to use in our units amalgam separator to separate the amalgam from the waste products, and of course using amalgam alternatives like glass ionomers, composite. In Egypt we mostly no more using amalgam anymore, and actually when I made my study in this survey, we found that most of the dentists are not using amalgam nowadays and they don't like it, and they of course aware of the problem of mercury. And also there is a very big problem with the disposing of mercury or amalgam. Okay. Another issue is dental radiography. We recommend, of course, going digital and exclude the ordinary X-ray, because it consumes. First of all, when you use digital radiography, you expose the patient to 90% less of radiation. So that first of all. Secondly, we don't use chemical waste. We don't use fixer and developer, and preventing their dumping into our waste products and water pipes and so on, because unfortunately not all dentists know how to recycle these fixers and developers and chemical wastes. We also get rid, by using digital, we get rid of the point of the lead exposure, and that's found in the lead apron, found it in the rest of the film. So all of this will save the environment. Also, we have to install and use low energy fluorescent or LED lighting. If when our computers are not in use, we have to shut it down or put in sleep mode to decrease 70% and reduce 70% the usage of electricity. We have to use the light motion sensors. We have to use water faucet sensors to decrease the water wastage. And unfortunately, also in our survey, very limited number of dentists that use these things. And that's why I'm saying that maybe the economical barriers are standing to the implantation of green dentistry, because this you have to make a big change in your infrastructure. Also, we go to the another thing is the reuse. Reuse means to switch to reusable things, to stop using disposable items, instead using reusable items, like reusable bibs, like using clothes sterilization bags that can be washed and sterilized later on, not the plastic sterilization bags, using closed patient barriers, you wearing clothes lab coats and organic straps instead of the gowns, paper ones that is disposed, replace plastic single-use items wherever appropriate with stainless steel one that can be sterilized and reused for years. And in our survey, the dentist was willing to do all this except with the cups. No one, and even the patients, no one was willing to use a ceramic cup or metal cup that is sterilized. So we recommend to use biodegradable cups instead. The last thing is recycling, and recycling is our last resort, and it's we have to do it in all our life. Recycling is a viable way to reduce the overall contamination of the environment. You have, for every dental office, there must be a participation in an instrument recycling program that turns them into industrial material. You can also, you have to medical shred your paper and recycle the copy paper and choose a medical shredding service that recycle this shredded paper. Also, in the staff rooms, we have to put recycled bins to minimize our waste products. By this, I have ended my presentation, and thank you for attention, and let's save the environment all of us. And any questions, I will be happy.
Are there any questions?
I have, thank you. Oh,
Thank you.
Thank you
wrong
very much for
one.
your great
Hello.
presentation, Dr. Astra.
Thank you. You're
Hello,
welcome.
Dr. Estra. Dr. Rossi, I do have one question. So as
Yes.
a independent, if you're working as an independent in the field and you want to begin to take some sustainability development goals, changes in your operation, where do you begin? And like, is there an organization, or how do you begin to go down this route?
I'm actually still beginning. To be honestly speaking, I'm still beginning. We are a team, and we are seeking making contacts with public universities in order to begin in public universities making eco-friendly dental clinics. Of course, we seek the help of non-profit organization for funding. So we are still researching this point and making studies in that point in order to make eco-friendly dental clinic. It's in progress.
Thank you. Thank you. And my last question is, are you in collaboration or in connection with any organization or individual in the United States that's taking this effort on with you?
Actually, no, but it will be a privilege. Yani, if you know someone or you have the intention to this, we can contact, of course.
Absolutely. You have my information there, as well as you can get in touch with Kyron to get any more information about me. But I'm definitely interested. I really believe in the SDGs and whatever industry you work in, it's important. So yeah, there's a few conversations from what you spoke that I'd like to talk about. So thank you for your time and your expertise.
Thank you. I will write my email so you can contact me. It's okay. It will be a
Yes,
pleasure.
ma'am. Thank you.
Please, miss, send yours if you don't mind.
I will share the contact of Dr. Ras to you, okay? In WhatsApp.
Yes, please share the contact, please. It will be a pleasure.
Sure. I will do it right now, okay?
Okay.
Yeah. Our next speaker is Ms. Kyra Massey Kennedy, has a BS degree in mathematics and mechanical engineering. She attended Florida A&M University on a full ride, life gets better, $40,000 scholarship in engineering. Kennedy attended FAMO Private High School in Tallahassee, FL. She was the first student in her high school's history to travel to Moscow for 1 month as a student ambassador to Russia. Kennedy is currently continuing her education and will graduate with an MBA in marketing. May 2021. She will start her Doctor of Business Administration with a specialization in strategic marketing in June 2021 and graduation in June 2024. Kennedy is currently the president of Maskin Foundation. In the past, she was the chief technology officer and a pioneer of wearable Wi-Fi military, non-military, and medical technology at Maskin Inc. Maskin Inc., founded in 2013, creates innovation technology devices and services for multiple industries, bedsores for those who are bedridden. The other prototype is wearable device to help read vitals and locate our soldiers if they are ever lost or captured. She was awarded the patent for her devices on January 12, 2016. Please join me in welcoming our speaker, Professor Kyra Kennedy. Ms. Kyra, please unmute your mic. Hello. Ms. Kyra, you are on mute. Dr. Raz, Ms. Kyra is on mute.
All right, give me 1 second.
Hello. Okay. Okay. All right. Hello, can you hear me?
Yes, we can hear you.
Okay. Sorry about that. Well, my name is Kyra Kennedy. I'm not sure if my presentation is up or not. So I'm new to the group, so I guess I'll just do like a brief introduction, or we're able to get my email. It's kind of detailed, so I wasn't really sure what to present, but I could just go ahead and introduce myself. I am Kyra Kennedy. I am a scientist, technologist. I have a degree in engineering and mathematics. I am an innovator. I have 4 products under 1 patent that is revolutionary in multiple industries, from medical, non-medical, military. It's products that are near and dear to my heart because it was inspired from my dad through the things he went through with his stroke and things like that. Can you all see me? I didn't realize I didn't have my video on. So I'm not sure if presentation is shown, but I can just continue to talk. Okay, y'all see me. So what all do I need to present? Just brief of the innovation I have, or Ross, what would you like for me to expound on?
So this again, we're speaking in the space of psychology and neurology. So
Okay.
again, you can, it's right in the avenue, everything you want to talk about,
Okay.
you can speak
So
about and exactly what you're looking for as well.
okay. So my father had a stroke, and he had brain surgery. And so I went to check his pillow, change his pillow, and realized there was leakage. So from that situation, deal with my dad who had a stroke early on, I created a medical pillowcase. And this medical pillowcase detects any moisture from above the neck. So if someone had any brain surgery, eye surgery, if they have issues with regurgitating or anything, and up to 30 different liquids, my medical pillowcase will text and email loved ones, the doctor, that one, you just released someone who just had brain surgery and they're leaking from the brain, and it will text them directly and let them know what patient it is, and the loved one. So like I'm in the room watching TV, it'll text me there's something going on, and also text the doctor. The same technology underneath that pad is also a pad that can go under bedridden people who are dealing with bed sores. Um, and the pad will text and email the doctors and loved ones. So if you have someone in a nursing home, and let's say the nursing center is not doing their job as far as changing your loved one, and they're soiling themselves through their garment, it will text you, text the doctor, and keep a log of what's going on, how many times this happened, and actually until it's cleaned up, the monitor stays on red until it is actually cleaned up. Also, under that patent is also things for open heart surgery and back surgery. So I am definitely looking for investors to help get this product out there. Eventually, they release it, license it if possible. Looking for a team of people who are very good in adding more options to it, like people very good in AI. And again, I have other medical patents things that I'm working on, but this is what I have going on right now. I'm really excited about it. And it was centered around how can I help my dad, and it wound up being something that can help millions of people who are in that situation as well. And I think that's about it.
So do you actually have like a visual presentation?
Yeah, I emailed it,
to
but
Kyron?
basically, yeah. I emailed to Kyron, but basically, what I found, and as far as my research is with the um medical pillowcase, of course, it's patented and it does not exist right now. But a lot of times when people have, people get brain surgery, they're sent home. There's no other way to monitor their issues or monitor how they're doing, if there's any leakage or whatever. And this is an amazing product that can help the neurologists and others who do any work above the neck and want to monitor their patients. So I'm really excited about it.
Okay, thank you for that. He did not receive the presentation.
Oh, he did? Oh, I'm
But
so
you are
sorry.
in
Okay.
so this is a room and a presentation in dentistry, public health, psychology and neurology. So you have professionals in all of these industries. You have investors in these industries. You have students that's in these fields. So this is an opportunity for you to present visually as well as verbally, not just what you have, but what you type of relationships and what you're looking for. So if you do have a slide presentation you can present, it would be best to have that available to the audience because this is being recorded and it will have legs and reach, right? So this is an opportunity to put that information out there in this community.
Yes, I did. I emailed at around 10:34 to I believe Kyron's email, and it didn't come back. Does he not see anything from Kyra Kennedy? I did email it though.
Okay. Well,
So
with
maybe
that,
I
if
could go
anyone has,
into. Mhm.
yes, if you could go in a little more detail so the audience can understand, because you have individuals from different fields as well. So the more they understand, the more they can see where the intersections and verticals are.
Okay. From the standpoint of, I guess, with neurology, as far as so the medical pillowcase is some I would say that can be used even for animals because it's a multi usage device because of course animals can't talk. So when they're leaking or they're having issues, this pillowcase can be used for humans, animals, or whatever. And the whole thing about it is this accountability and detection. And again, uh, the device that I can can uh, can recognize 30 different liquids. So just imagine it has been tested with 30 different liquids with the material that we use, the technology that we use. And so basically, as far as what neurologists deal with, as far as their patients and how they're keeping up with them, this will be another step in technology to keep up with their patients after they send them home, how they're doing, and the money that we're looking for this project is also to add more technology to it. What else do these doctors need for us to help monitor outside of leakage or whatever? So there's opportunity for more options in the current project I have. But right now, the basic need that we're wanting to push is that we have something that'll hold everyone accountable for the loved one, a person who is in that situation. And again, when someone is asleep, a loved one just came from surgery. Once they're lying down, you're walking away, you're moving around, you're doing different things, and you don't know that, hey, my loved one right now is leaking from the brain after they just came home. And this device will uh, help monitor that situation and help the doctors know, okay, they may need to come back in or whatever. So it's more so, I won't say accountability, but just technology that will enhance um, surgical procedures. And the pad that I have with the same technology, but it's flat, that could the pad can even go to under a hot water heater and let you know that you have a water leak. So that's why my different devices go under multiple industries. But since this is a neurology type of and psychology type of webinar, uh, it can be used for babies who have acid reflux. My pad that I have for children who have acid reflux to let you know. And the reason that was created, my son was in his crib and he had wet himself, and I thought that he was dry and everything. And I was like, gosh, had I known that he was wet, I had some kind of notification, then he wouldn't be sitting here and he had soaked himself. So it all came around from my family and experiences that I had with my family to now being patented devices that I'm trying to get into production. And also my devices will also help with with Medicare because they spend close to $16 billion a year on bed sore claims in hospitals and in private nursing homes. And my pad will help with that to bring that number down I wouldn't say it will cure bed sores, but at least it'll knock that number down in claims and lawsuits from family, because this pad also is something that can be accountable to the loved one and to doctors. So
Thank you so much, Kyra. I see so
you're
much
welcome.
use case scenarios for this. So how can individuals get in touch with you, and where are you at doing this research? And as far as moving forward, what type of individuals are you looking for to build your team out?
Okay, so I'm located in Alpharetta, Georgia. I gifted my uh, patents to my nonprofit, but I will be uh, revamping and to a full tech firm where I need more AI people, more people uh, in cloud technology, because also each of these devices have cloud technology capability to, and has also capability to actually call. I forgot to mention that, but texting is a big thing to text a doctor to their pager, but also both of these devices have the ability to actually call loved ones as well, phone calls. But anyway, what I'm looking for is cloud-based people. I'm currently looking for a bigger building. I'm working out of my office here in Alpharetta, but I'm looking for just a little bit bigger building where I can have everyone together to help work on these projects together. And I'll put my information into the chat of how I can be reached. And what else did you ask me? And so as far as the investors, the revamping of my company, I will be providing stock options for those investors who are like the main ones for the company, and things like that. We work all that out. But yeah, I'm offering shares for the company, and I'm also under a nonprofit where we can also get funding from the government if necessary. As a woman, economically disadvantaged small business. So but I'll put my information in the chat just so people can reach me directly.
Thank you for that. And yes, and don't make any commitments now. Keep your options open.
All
And let
right.
me just ask you with this, would you be open to consider the south side of Atlanta, College Park needs a college, it needs an institution, and I'm working on a BCI brain computer interface laboratory, and I think your neuro devices roll up that alley, but I'll be presenting shortly now, just summing up some things and showing a number of websites and connections related to a number of the things we talked about. So I look forward, and I'm excited to discussing with you the potential of the future of what you're doing independently, and also what we can do collectively for not only the individual cities we live in here, but the state of Georgia and the country, and if not the world.
Yes, awesome. And my nonprofit, Masking Foundation, inspires young kids to go into engineering and science. So that's reason why I created my nonprofit, to have more kids be excited about going to STEM fields, because right now our children are into cell phones. Now a lot of them are interested in STEM camp and things like that, and we're losing them. So my nonprofit is to kind of make them more excited about STEM, just like I was at an early age. So, but again, thank you so much for letting me present, and I'll put my information in the chat.
All right, appreciate you. Thank you for your time.
Thank you.
Yeah, shall we go for next presentation, Dr. Ras? Hello?
Yes, I think, yes.
Yeah, our next speaker is Dr. Ras Geddes. Dr. Ras is a distinguished figure at the intersection of neuroscience and artificial intelligence. With a background in neuroscience, Dr. Geddes deeply understands cognitive process, which he seamlessly integrates into his work in AI. Under the mentorship of Peter Scuta, a renowned industry machine learning or large language model expert, Dr. Geddes is honing his skills in AI development by understanding and researching computational cognitive developmental neuropsychology. His research focuses on elucidating the parallels between biological neural networks and AI systems, with a keen interest in simulating human like cognition by teaching AI. Dr. Gaddis is committed to pushing the boundaries of AI research, striving to bridge the gap between neuroscience and artificial intelligence. Please join me in welcoming our speaker, Dr. Ras.
Okay. Thank you, Kyron. And I have the ability to share, I believe. Let's see. Okay. Okay, so can you see my screen here?
Yes, we can see your screen.
All right, excellent, excellent. So I would like to start here. I'm going to do a very unorthodox presentation because what I want to do is addressing the topics and some of the things that you've heard so far. First, I'd like to introduce myself and then go through a number of actual websites that tie some information together because I want people to see that this is not just a prefabricated information that you not get to, but this is real world information. And I think it's vital to kind of have to that in that way. So if you can bear with me now, Sunny, how much time do I have if I can page myself here?
Sorry, Dr. Ras?
How much time do I have?
Yeah, it's 30 minutes.
Okay, all right, in 30. Okay, so I am Dr. Ross. That's Ross the Forgetties, but I go by RAS because I'm really a scientist and I'm in College Park, Georgia currently. However, I am Jamaican made and American raised. I was born in Spring Garden, Jamaica, and I grew up in New York City. I went off to Binghamton University to become a psychology student and eventually a neuroscientist. So I've done research in that area and went off to Penn State Hershey Medical Center to then get a master's and a PhD in neuroscience with a focus on behavioral neuroscience, neuroanatomy, and neurosurgery. After that, I went on to Emory University to the Brain Research Lab to learn about traumatic brain injury in juveniles, and then on to the University of Wisconsin and the VA hospital in Madison to look at, again, traumatic brain injury and Alzheimer's disease later on in life. So I've basically studied damage to the brain, so neurotrauma, and then the endocrine system or reproductive hormones and how they impact neurogenesis and the regeneration and recovery of function throughout the life cycle. So looking from perinatal hypoxia ischemia all the way to like Parkinson's and Alzheimer's disease and traumatic brain injury in older individuals. Okay. With that, I'm back in Atlanta, Georgia now, or College Park specifically. And within that time, I've created a course called My Brain and Me. And My Brain and Me is an immersive 30-day journey where we talk about science, technology, research, engineering, arts, and math as I introduce the individuals to their five senses and the brain and how all roads lead to the brain. And also we have Getty's Neural Network, which is my global network of individuals, all you guys out there that I've connected with over the last 30 years of higher education. And then also I have a clothing store, which I believe you have to represent yourself. And so for whatever, whether you're nerdy or whatever, you should have a real authentic styles. So with all that being said, I try to use traumatic brain injury and what I do in the community as a STEM educator to allow individuals to get into education and maybe change their life and the life of the individuals that they love. So, with that being said, I am currently a chief medical officer over at Micron. Micron AI is a AI company that work in the space of medical technology, of agricultural technology, and defense as well. And you guys can go and check out the website specifically. But I wanted to start off here because as we get into the psychology and the neurology, AI technology, which is based on neuroscience and how a neuron or a brain cell works or neural networks, it's technology and the brain is merging every day faster and faster. So I'm able then to work through the medical technology, just like you heard from Kyra. So again, some of the things that she talked about would fall under that medical technology experience. So I would like you guys to really check out Microtron AI. We have a lot of machine learning, large language models, and different things going on there from the individual levels as well as to enterprise levels for use case scenarios for building out your personal projects as well as for your businesses. So again, and then with that also in the community, I'm able to work with the Atlanta chapter of the Society for Neuroscience, and as well as Georgia Tech and Emory University, where I'm able to get brains from different types of donors, whether they be animals or humans, that we can use to teach in the community and have PBL or project-based learning. And also, I am part of the STEM professional, or I'm a STEM professional of part of Science Atlanta. And if you guys don't know, Science Atlanta and the Science Atlanta Festival will be in Georgia, in Atlanta, Georgia, in March. And it's 2 weeks of science education. Again, and I'll be presenting brain information there as well. So if you guys can go check out scienceatl.org, and for sponsors, or if you want to present, it's about 30 to 40,000 people in town over a 2 week period that ends with a weekend expo. And all of this is important because this is where we bring the psychology and the neurology, the neuroscience, and all this information that we do in the laboratory and in the hospitals into the actual community. So, and with that, one of these programs, the STEM Professional School Partnership, through this program, I'm able to go into the local public schools from K through 12, as well as work with undergraduate students at these universities to be able to bring some of this neuroscience and biomedical education to the students. Okay. Also being in not only in Georgia, but also reaching out because with technology, we can be global, and also associated with the T2M MedTech Corridor, which is the Tampa to Miami Medical Technology Corridor, which again deals with aggregation and management of medical technologies, and in my case, brain technology specifically, and how to identify your minimum value product and being able to understand your customer market and things like that. Also building partnerships, and so this is a great place as well, in a way for us to be able to interact with the community, but also stakeholders, businesses, as well as government officials to have an impact in our community. Okay, as I take a breath with all of that, you guys heard earlier from Alvin Chapman, and Alvin is the CEO of Neuro. And again, you can go to neeuro.com, but Neuro is a new partnership that we are working on here at Getty's Neural Network, as well as the other organizations that I just mentioned. And again, this is the being able to use BCI, a brain-computer interface, where the energy or the information coming from individual or collective brain cells, by understanding the localization of the brain function, we're able then to utilize this information to augment brain stimulation, calming down the brain, being able to understand different levels of brain activity, and then utilizing that information again through using Wi-Fi. You can then interact with software that you can actually not only understand what the brain is doing, but also use that information to interact with devices that can further train your brain. So, and with that, this psychology and the neurology and thinking about that space and how we can bring technology and information to that, pairing something like the neuro and this EEG device of a individual. This is personalized medicine. But then when we talk about, you heard from Brooke McKeever and the ultra red light therapy clinic, and you can also check her out. This is actually her website and service because again, this is important that we're in the age of combinational therapies, right? Looking at multifaceted therapies, not only trying to see non-pharmacological approaches, but again, we can see how using this light therapy treatment is impacting the individual by combining that with something like the neuro, as Brooke mentioned, we're going down that road as well to investigate. So as we talk about these things, I was very interested in presenting something that is important to the older individuals. As I get older, this is a space that I'm working in. And so I'll take a quick break, and I want to present into the focal fusion, and that was the next innovative technology I wanted to talk about. Is along with the photobiomodulation, which is the infrared light therapy, and excuse me, and the EEG brain computer interface device. I want to talk to something related to, which is the focal fusion. It uses ultrasound and magnetic resonance imaging together to then look at biopsy for prostate. So before I get into that and why that's important, I would just like to jump over to really quickly and mention put pauses here. I don't know if you can hear this, but okay. The audio is not playing well, but basically, I just wanted to mention again, speaking of psychology and neurology, Emory University Alzheimer's Disease Research Center has every second Thursday of the month here in Georgia. In Atlanta, they have a monthly minority men's health program, and it's free to come out and to learn about these different things that's available from the clinical, the health and wellness side as well. You can go see that on Eventbrite, or you can also just look it up on YouTube. That's Emory Brain Health Community Outreach, and that's through the Emory Brain Health program at the Gozetta Alzheimer's Disease Research Center, the ADRC. And that's important because, hey, Hollis, that's important because as I speak about this prostate device, it's a semi-robotic device that can help minimize the trauma that you have to deal with as an older male when this time comes to have to, look at things like that. And that's Dr. Parker, the brainchild of what I just spoke about. Um, Okay. So the reason I mentioned that, and I hope you guys are still with me and my audio is good. Um, uh, but the reason I mentioned that is because I also want to talk about an innovation in that field, which is the B focal fusion BX and the focal fusion MR. Give me a second, my window is frozen here. But again, you can find all of this information that I'm giving is freely available and it's out in the world, right? It's accessible and we're accessible people. And that was the point of these presentations. But if you go to focalhealthcare.com, you will see the focal fusion. And this device, again, it uses, let's see, here we go. It merges together the use of ultrasound technology as well as MRI technology to be able to have a more precise experience when doing a prostate biopsy, so collecting tissue from the genital area in older males. So I'm not playing the audio just because of the issues, but again, this is just to demonstrate that, this device is semi-robotic and it's precision medicine because it uses this Gen AI or AI technology to do real-time adjustments on if the patient moves it, so the stereotaxic or spatial, um, the spatial positioning of the needle, as well as the patient. And not only that, it uses very high imaging, MRI imaging technology to be able to then source the area and identify through the video imaging areas that are malignant. So this will cut down a lot on the proking and prodding in that area, and then all of the sensitivity and healing that has to go after having such a procedure. So now if you imagine, we can attach this procedure, or we can attach the ultra red light therapy or the EEG device to procedures like this. We can not only have better procedures on their own, but also be able to have a better patient care experience. And so that's what my talk is really about. How do we put all of these things together and bring individuals that's in the GNN Getty's Neural Network, or just in the world, this professional healthcare space that I work, that we can provide novel, holistic types of treatment. With that, I have two more organizations that I'd like to talk about that's in this space again that I think will bring some importance to this. And before I go there, there is another point I wanted to make. And if you guys, let me see, hold on. I hope you're still with me and my audio's good, everyone. I wanted to mention there's an effort going on. Okay, internet is a little slow, but there was another effort of fundraising to help rebuild the Walter Smith Library after a hurricane. So here in the States, we had a couple of hurricanes during the season, which destroyed a very important library in Tampa, Florida. And again, it's a library and a museum that's named after Walter L. Smith Jr., which is a former president of FAM University. But again, it's important because knowledge and where knowledge is kept, we're working with this library to bring to convert it into a digital library, but we also need to restore the physical library itself. And again, I just wanted to mention that out there, if anyone has or can share the word about the rebuild for this library, that would be good. Okay. So in wrapping up, I wanted to mention two more important, I think, IPs, but also relationships that I have through the Tampa to Miami corridor that I believe is very important to when we speak about psychology and neurology and life and experience and health and wellness, even in the dentistry space as well. So this is two other technologies that I'd like to have conversations about and bring to the table, which is SciGlass. SciGlass is the imaging technology, 3D imaging technology that's utilized by scientists as well as educators. And so being a neurotrauma endocrinologist, I think this is a very special educational tool because it allows me to interact with the students from the space of a scientist and speaking from, the scientific method and that type of approach and analysis with the students. But then I can also switch and get into the teacher side and the educational side, right? As far as more utilizing this technology inside of the actual classroom. Okay, so bringing the laboratory inside of the classroom and bringing the classroom inside of the laboratory. So again, SciGlass is something that I think can add important to a number of the things that we mentioned before. And then lastly, but definitely not least, I would like everyone to look out for and reach out to Global Anatomics, because this is also another very interesting partnership. We'll be working closely together. They have the highest fidelity cadavers, or donors available in the world, meaning the preservation technique that's used here in these cadavers is like no other. It's unmatched. And also they come with proprietary visualization techniques as well. So you can look at micro vessels. I mean, if you guys understand the vasculature and what we're seeing here, there's a lot we can do with this technology in training on donors and cadavers in the medical space, but also research for all you individuals who have robotic or healthcare companies and work on or need cadavers or donors to be able to work out your products in the efficacy or what have you. We're open to that as well. So with that, this will basically bring a conclusion to my discussion, but I wanted to again give a thank you to all the individuals that committed their time and their expertise to today's webinar, and also to my colleagues that also dedicated their time and committed some content to this overall holistic approach that we're trying to do. And I look forward to 2025 and beyond. Kyron, if there are any questions, I am here and open and ready for them. I am Dr. Ross, that's R-A-S, because I'm really a scientist. I also go by the TBI guide. You can find me on LinkedIn, and all my information is in the chat. You can also reach me at rascorp1911@gmail.com. You can also reach me at this contact and set a meeting at coursesforyou.com/DAR-RAS/. So thank you for that, and I will stop sharing. I'll take any questions, comments, concerns.
Yeah. Thank you all for attending the conference. Hope to see you in our next edition. Thank you so much. Yeah, Dr. Ras.
Yes,
yeah,
sir.
Do you have anything to say?
Just thank you all. Reach out to Sunny here, Kyron, and HK conferences. We do conferences all different disciplines, and we'll have some surprises coming up in the new year for some new experiences, more interactive. Please, we look for sponsors, donors, monetary or in kind. If you have ideas, we're open to all of that. So I just wanted to thank Kyron and Ashkoff, thank Dr. Dana York and the whole committee and everyone involved.
Yeah. Thank you all. Dr. Kolo, Dr. Esra, Miss Carey, Miss Kaira, Dr. Siong Wong. Bye-bye. Dr. Ras, goodbye.
Thank you, Sunny.
Yeah. Dr. Ras, I will
Yes,
send
sir.
you one link right now, okay? After this, okay?
Okay.
Yeah.
Thank you. Thank you, Dr. Ras. Thank you all for this amazing conference. Thank you.
Thank you. Yes.